Hello. Sure, sir. Yes, yes. Good morning, everyone. On behalf of MAHA AHA Raigad, IIP Raigad, and in association with MGM Medical College and Hospital, Kamothe, we welcome all the delegates and faculty to the second MAHA AHAcon 2026. The theme of this conference is Building the Bridge to Healthy Adolescence. We begin our session with the paper presentation, and for this, we welcome our judges, Dr. Shilpa Kshirsagar Madam, Dr. Jayant Pandrikar Sir, and Dr. Chitra Kulkarni Madam. We also welcome our paper presenters. Each presenter has 6 minutes to present, followed by 2 minutes for questions raised by the judges. Now I call upon the first presenter, Dr. Bodanki Praharshitha.
Good morning, one and all. I'm Dr. Praharshita. I'm a resident in D.Y. Patil Medical College, Pune. My paper is based on the topic Clinical, Pathological and Radiological Study of Post-COVID Positive Patients in a Tertiary Hospital in Pediatric Age Group of 1 month to 15 years of age. COVID-19 caused by SARS-CoV-2 has affected children all across the groups with a wide spectrum of clinical manifestation. Although pediatric patients generally experience mild acute illness, increasing evidence suggests that post-COVID sequel has involved multi-organs, including the respiratory, cardiovascular, neurological, and hematological systems. The emergence of post-COVID conditions and multi-system inflammatory syndrome in children has highlighted the need of comprehensive evaluation of affected children. The study was undertaken to assess the spectrum of post-COVID manifestations among children aged 1 month to 15 years of age attending a tertiary care hospital. The rationale: there is a limited Indian data regarding the multi-system clinical, pathological, and radiological sequel of post-COVID illness in children. The study was conducted to characterize these manifestations and identify predators of severe diseases. The primary objective is to study the clinical, pathological, and radiological manifestation of post-COVID positive patients aged 1 month to 15 years. Secondary objective is to compare the clinical manifestation, clinical characteristics and outcome between multi-system inflammatory syndrome in children and non-multi-system inflammatory syndrome in post-COVID patients, to evaluate laboratory markers associated with disease severity and multi-system involvement, to assess radiological and echocardiographic abnormalities in post-COVID children, and to also determine the factors associated with adverse outcomes, including ICU admission and mortality. The methodology: this is a cross-sectional observational study conducted for 2 years, and inclusion criteria was children aged between 1 month to 15 years, and exclusion criteria with children already having evidence of hyperinflammatory state but negative SARS-CoV, and patients whose parents did not consent. The study was conducted in a tertiary center, D.Y. Patil Hospital. Imaging assessment, chest X-ray and MRA were indicated, and 2D echo was done, and data collection was clinical manifestation systems involvement, laboratory investigations, radiological findings, and treatment details and outcomes, classification into multi-system inflammatory syndrome and non-multi-system inflammatory syndrome. The results of the study are 66 post-COVID children were total included in the study. Majority belonged to 1 to 5 years of age with male predominance. Respiratory involvement was most common manifestation, followed by cardiac, gastro, and neurological and hematological involvement. Multi-system inflammatory syndrome was diagnosed in 16.7% of children. Multi-system inflammatory syndrome patients have significantly higher cardiac, gastro, and neurological involvement when compared to non-multi-inflammatory system involvement. Significant elevations in inflammatory and cardiac biomarkers was observed, including ESR, proBNP, TROP-I, CPK, and D-dimer. Echographic abnormalities were present in 39+4. Mostly coronary artery dilation was common. Chest X-ray commonly showed consolidation and opacities, while MRI abnormalities were detected in 33%. Overweight status was significantly associated with multi-system inflammatory syndrome. Mortality was higher in multi-system inflammatory syndrome children when compared to non-multi-system inflammatory syndrome. The present study highlights the diverse multi-system manifestations of post-COVID illness in children with respiratory and cardiovascular involvement being the predominant clinical manifestation. The findings are consistent with previous studies, which demonstrated significant multi-system involvement following SARS-CoV-2 infection in children. Multi-system inflammatory syndrome consists of 16.7% of our cohort and associated with significant greater cardiac, neurological, and gastro involvement. Similar patterns have been reported by Gottfried Cato, who described cardiovascular and gastro involvement as major features of multi-system inflammatory syndrome in children. Conclusion, post-COVID illness in children is a multi-system disorder with significant respiratory, cardiac, neurological, and gastro involvement. Multi-system inflammatory syndrome represents the most severe post-COVID phenotype, characterized by marked inflammation, myocardial injury, and prolonged ICU stay, increased mortality. Coronary artery dilation and elevated cardiac biomarkers were important indicators of severe disease. Early recognition, timely immunomodulatory therapy, and comprehensive cardiac surveillance are essential to improve the outcome. Long-term follow-up of post-COVID children is warranted to detect and manage delayed sequelae and prevent long-term morbidity. By the data used from the hospital.
What studies did you do? How did you come to the p-value? You showed that there is significant correlation with ECG findings and cardiac markers. Yeah, what test did you use for that?
The student t-test use.
Come to the next, your results. Results. This overweight was significantly associated. Those tests which were done, can you give some light on that? How was the data collected?
From the hospital
records. So this was a retrospective study?
Yes, retrospective and current ongoing patients also, if anybody is there.
Okay.
Thank you.
Thank you.
Now I call upon the second presenter, Dr. Mohan Kamara.
Good morning, everyone. My topic, good morning, everyone. I'm Dr. Mohan from Family Medicine Department. My narrative, poisoned at the threshold, ask whether about the endocrine disrupting chemicals are potential primary drivers of an early puberty onset in Indian adults and girls. Endocrine disrupting chemicals are exogenous substances that alters endocrine function and
Can
cause
you be a bit louder? Bring that mic.
okay. Endocrine disrupting chemicals are exogenous substances that alter endocrine function and cause adverse health effects in our organism, its progeny, or subpopulations. This matters. The average age of first period in India has fallen to about 12 and 12.5 years. Early puberty brings shorter final height, psychosocial stress, and lifelong risk. Obesity, diabetes, and moderate rise in breast cancer. India is the third largest pesticide market, still uses DDT and produces over 9 million tons of waste per year. So what do we know? EDCs are EDCs can trigger early puberty in the lab. Indian girls are maturing earlier, and plastics and BPA are linked to early breast development. So what's unclear is largest pooled analysis found no consistent association. Causality isn't proven, and the effects vary chemical, dose, and timing. Critically, no Indian study has actually tested this in girls. The gap in a country with such heavy exposure is why this review is needed. My aim is to critically synthesize the evidence uh, on endocrine disrupting chemicals as drivers of early puberty and in adolescent girls, with specific emphasis on the Indian population, and identify priorities for research, clinical practice, and policies. The main guiding question is, do EDCs act as primary independent drivers of early puberty or as cofactors alongside nutrition, adiposity, and genetics? Briefly on methods, I included human studies in girls measuring EDC exposures or pubertal timing, systematic reviews, cohorts, and case controls from 2009-2025. I excluded male only and in vitro studies, case reports, and opinion pieces. I searched 5 databases: PubMed, Scopus, and Web of Science and Cochrane, MBAS, plus WHO and Endocrine Society statements. The Boolean strategy combined EDC terms with the puberty terms and an Indian filter. Screening narrowed roughly 980 records down to 16 key resources of synthesis. These are my key studies spanning the evidence hierarchy. The 2009 endocrine statement is the landmark. Wulzberg 2022 meta-analysis is the strongest synthesis. It found phthalates linked to earlier breast development, but no consistent pooled effect. Lee shows BPA and phthalate signals in Asian data. Kotla gives Indian cross-sectional data, and Bhattarai from Nepal found maternal chemical exposure triple the odds of early puberty. Normally, the brain GnRH pulse drives the puberty, pituitary, which drives the ovaries. EDCs can disturb every level. They prematurely switch on the GnRH and push LH and FSH and rise estradiol, driving early breast development. Chemically, BPA and DDT mimic estrogen. Phthalates and DDE block androgens, and PCBs and PBDAs disrupt thyroid hormones, and which also shapes pubertal timing. Why India specifically? Our exposure profile is unusually high and varied. Pesticides and DDE and DDT from malaria spraying and farming, BPA and phthalates from single-use plastics, reheated food, cosmetics, and IV tubing, PBDAs from informal e-waste recycling in Delhi and Mumbai, PCBs from old electrical equipment, and traditional sources like lead in kajal, mercury in skin creams. Exposures early, sustained, and multi-route. Grading the evidence, the consistent shows that the secular trend towards early puberty is real. Phthalates are linked to early breast development. Suggestive evidence shows that BPA and prenatal DDT signals mostly from Asian and case control studies. Conflicting data is the pool meta-analysis found no consistent association, and some chemicals like PCBs and PBDAs and can even delay puberty. So the mechanism is convincing, but the epidemiology is inconsistent. The link is real, not yet proven causal. The key gaps: no Indian study links measured EDC exposure to puberty. Real-world chemical mixtures and low doses are untested. Rural, tribal, and e-waste communities are unstudied, and there is no EDC guidelines or national biomonitoring. The evidence is mechanically strong, but limited to poor exposure measurement and confounded by the body fat. So what do we do? Clinically, take an exposure history in girls with early puberty, counsel families on simple usage like glass and steel over heated plastic. For public health, build awareness programs into school and RBSK programs and target high-risk cluster. For research, a prospective cohort measuring biomarkers and pubertal stage together. for national policy, national biomonitoring and FSSAI packaging standards, and careful DDT phase out. In, in summary, the link is biologically convincing but epidemiologically unconfirmed, suggestive, not definitive. India is an uniquely exposed yet had no almost data. That's a defining gap. And the single most important next step is Indian specific biomarker linked cohort study. Earlier exposure is sentinel of environmental health. Thank you.
What about the statistical, in the conclusion, you didn't mention that how many patients has got this. Statistical about it. Analysis of the.
Sir, for statistical analysis, the data is inconclusive because of the EDCs are various chemicals with different classes, and they have different bioavailability and half-life, sir. So DDT and BPS stays in has very low half-life. Like they will go out of the system within days, and PVDs and PVDs are like have very long half-life. They will stay in the system for many years. So because of the different exposures, timings, and different half-lives, the statistical analysis and meta-analysis, they can't be proven. They can't prove the causality. Like we have to do single marker to directly staging puberty, sir.
Okay.
Thank you.
Now I call upon Dr. Sachin Tripathi to present his paper.
Good morning, respected chairperson, judges, teachers, and my colleagues. I am Dr. Sachin Tripathi, PG Junior Resident 1 from JMCH Chhatrapati Sambhaji Nagar. Today I am going to present my free paper titled as Anxious Minds Behind the Smiles, Burden and Pattern of Anxiety Disorders Among School-Going Adolescents aged 10 to 16 years. So, around 1 in 7 is the among 10 to 19-year-olds experience a mental health disorder globally. Mental health disorders contribute to around 15% of the burden among illnesses occurring in adolescents. The leading causes are anxiety, depression, and behavioral disorders. This study was needed because most of the anxiety disorders are underdiagnosed. Parents usually dismiss these symptoms as weakness or underconfidence. There is low awareness among general population, which impacts the functionality of these students, which leads to drop in academic grades, and there is limited Indian data for this particular age group. The primary objective of my study was to study the prevalence of anxiety disorders among urban school-going adolescents age group 10 to 16 years. And my secondary objectives included to assess the type of anxiety disorders and the factors associated with it. Methodology, around 1003 students were screened from 5 public and private CBSE and state board schools during March 2023 to August 2024, and consent from parents and student assent was taken, and a cross-sectional observational study was conducted after IEC approval. Inclusion criteria was students, school-going adolescents aged 10 to 16 years. Exclusion criteria was the students who are not willing to participate, parents not giving consent, and incomplete questionnaire responses were not considered for my study. The study tool used was SCARED questionnaire. SCARED stands for Screening for Child Anxiety Related Emotional Disorders. It is a validated screening tool used globally, which assesses anxiety over 5 domains: panic or somatic disorder, separation anxiety disorder, social anxiety, school avoidance, and generalized anxiety disorder. We have to note that it is a screening tool and not a diagnostic tool. SCARED questionnaire, it contains around 41 questions, and the scoring is 0, 1 and 2, 0 being not true, 1 being somewhat true, and 2 being very true. and then the results are classified according to this table. So if we get the value more than 25, we say it as anxiety disorder may be present. If the sum total is more than 30, we can say that there is specific presence of anxiety disorder, and other subtypes as seen in the table. So the study flow was IEC approval was taken, school NOC was taken from the principals of participating schools, consent and assent from students and parents was taken, screening was done using SCARED questionnaire, and then analysis was done. Analysis includes first data is to be compiled from the questionnaire, and then descriptive statistics was used, that is frequencies and percentages for numbers, and for categorical variables like gender and age, Pearson's chi-square test was used, and p-value less than 0.05 was considered significant. Results of my study are as follows. Prevalence of anxiety in school-going children was possible anxiety spectrum was 34%. What it means that there was specific presence that is more than 30 if we get the responses, that is 16.15%, and more than 25 responses that is anxiety may be present is 18.84, which contributes to sum total of 34%, and 65% showed no presence of anxiety disorder. Subtypes, maximum was found to be separation anxiety disorder, followed by panic disorder, school avoidance, generalized anxiety disorder, and social anxiety. Demographic data was, in my study, upper middle class was present in maximum number since it was a urban setting and the schools were also from urban area. So upper middle class was around 62.91%, followed by upper class, lower middle class, upper lower class, and lower class as per modified Kuppuswamy scale. Age and gender-wise association, anxiety disorders showed significant association with early adolescence, that is 10 to 14 years of age group, and female showed more preponderance than males. Discussion, comparison with other Indian studies showed that in our study prevalence was least compared to the other Indian studies, but this tells us that there's a need for screening to be done in schools on regular basis because prevalence are found in almost all of the studies. Subtypes, when we see separation anxiety disorder was maximum in our study, and even in Anjali Joshi et al. Study showed separation anxiety disorder to be maximum. Strengths of my study, we have included a large sample size of around 1,300 adolescent students. It is a school-based design. Real urban adolescent population was used. SCARED is a validated screening tool used globally. Ethical framework was followed, and risk factor analysis was also done, that is age, gender, and socioeconomic status was also studied. Limitations of my study are, it is a cross-sectional design, so we cannot comment on causality or temporality. And since it is a screening tool, we'll need a further psychiatric evaluation for diagnosis. To conclude, 16.15% had specific presence of anxiety disorder on SCARED. Separation anxiety was the most common subtype, and early adolescence, female gender, and upper middle socioeconomic class showed significant associated factors. Recommendations based on my study, parents should recognize anxiety as distress and not weakness or poor discipline. Schools should have periodic anxiety screenings. Counseling cells should be set up for referral and support services. Pediatric linkage should be done where students who show positive screening should be referred to pediatricians who can then finally associate global Indian programs like RKSK and AFHCs for these children. These are some of my key references. Thank you.
Yes, it was very good paper. But just I want to ask what scale or test you have applied for the causes of anxiety?
Causes of?
Anxiety.
SCARED tool screen.
SCARED tool is for the diagnosis of anxiety.
Yes, sir.
But for the causes you mentioned that early adolescence or whatever the causes you told. So what was the test applied for the causes?
Sir, by chi-square test only, since it is a categorical variable.
So what questionnaire did you give for the causes?
Sir,
because that SCARED doesn't have that causes things. So,
sir, we are not saying that early adolescent is the cause of anxiety disorder per se. We are just saying that in our study, we found out that early adolescent age group was significantly associated with our study.
But for that association, what was the format you must have said, given some format.
Sir, under the same questionnaire only, we found out that adolescents from 10 to 14 years of age group had more association of anxiety disorder.
Okay. Okay.
Okay, thank you, sir.
Now I call upon Dr. Sharmin Munshi to present her paper.
Good morning. Good morning, judges, faculty members, and my colleagues. I am Dr. Sharmin Zaki Ahmed Munshi, Junior Resident from the Department of Pediatrics, Government Medical College, Chhatrapati Sambhaji Nagar. Today, I will be presenting my topic on impact of adolescent fubbing on emotional dysregulation and academic engagement. It is a cross-sectional analytical study. Fubbing is a combination of two words, phone and snubbing, in which one person ignores the other person during the face-to-face interaction while using a smartphone. This behavior is closely linked to peer exclusion, depression, anxiety, FOMO, and social media validation. Due to the rise in smartphone usage among the adolescent, there is a rising concern of fubbing in adolescents. Prevalence of fubbing is around 77% in American adolescents, while it is around 87% in the adolescents in China. In India, there is limited study about fubbing, so we thought of conducting this study. My primary objective of the study was to assess the impact of adolescent fubbing on emotional dysregulation, psychological distress, and academic engagement among the adolescents. The secondary objective of the study was to evaluate the prevalence of adolescent fubbing using the adolescent fubbing scale. We conducted a cross-sectional analytical study during the period of June to November 2025 in the setting tertiary care hospital of Government Medical College, Chhatrapati Sambhaji Nagar, which included school and college-going adolescents between age 10 to 19 years. The study included adolescents between age 10 to 19 years which had access to smartphones. We excluded adolescents which were diagnosed with developmental disorders and severe mental health conditions, and also parents and adolescents who refused to give the consent. According to the prevalence of around 77%, we calculated a sample size of around 300. All college-going students were included between 10 to 19 years of age. We obtained the approval from the ethics community. NOC was obtained from the principals of the school and colleges. Parents were informed during the parents-teacher meeting, and a set of questionnaire was prepared in the form of Google form for which the links were shared on the social media. The questionnaire includes study tools which are adolescent fubbing scale, PHQ for psychological distress, emotional dysregulation, which consists of difficulty in emotional regulation scale, strength and difficulty questionnaire, and student engagement and school questionnaire. The data was analyzed using IBM SSP statistic version 26, and we used the following statistical methods. Results. Among the 300 adolescents, the mean age was around 14.8 plus 3.3 years, in which the male to female ratio was around 1.16:1. Regarding the mobile phone ownership, 50% adolescents reported not having their mobile phones, 61 adolescents live in the nuclear family, and 70% of them did not have their separate rooms. There was highly significant association was observed between the age and the adolescent fubbing scale. Fubbing addiction of more than 40 score was seen rarely in middle and early and adolescents, but notably higher in the late adolescent group. 64% of the adolescents show fubbing behavior, while 4.3% showed fubbing addiction. A strong positive correlation was seen with psychological distress, including depression and anxiety, according to the PHQ-4 total score. Emotional dysregulation was strongly associated with fubbing, with significant correlation Fubbing also showed significant positive correlation with behavioral difficulties. A moderate negative correlation was found with school engagement. Our study was also similar according to the international literature, with key findings suggested of adolescent fubbing is associated with depression, anxiety, emotional dysregulation, and reduced school engagement. The strength of my study was that the key research gap was covered by investigating the adolescent fubbing. Research focused on emotional behavior and behavioral outcomes, including anxiety, emotional dysregulation, and academic disengagement. Limitations of my study that it was a cross-sectional design that could not establish the causation of the relationship, and only the correlation was proven. Reliance on self-reporting, and the sample was restricted to school, college-going young students. The conclusion of my study that the total adolescent fubbing score showed strong positive correlation with depression, anxiety, emotional dysregulation, and a moderate negative correlation with the school engagement. The prevalence of fubbing amongst the adolescent was around 64%, with 4.33% meeting the criteria of fubbing addiction with score more than 40. This suggests that fubbing primarily impacts the internalizing factor, anxiety, emotion, dysregulation, and motivated academic engagement. These are the key references for my study. Thank you.
Which pubbing scale you have used? Which pubbing scale you have used?
I use the adolescent pubbing scale for my primarily adolescent pubbing scale, which consists of set of 10 questionnaires, and on the basis of 5-point Likert scale, the score was calculated. If the score exceeds more than 20, it is regarded as a fubbing behavior. If the score exceeds more than 40, we will regard as a fubbing addiction.
And what about incidence of fubbing in early, mid, and late adolescence?
Pardon, sir?
What about incidence of fubbing in early, mid, and late adolescence? Have you classified them?
The incidence was less in early and middle-aged adolescents, but it was comparatively more in late adolescents. Due to
We request the judges to discuss among themselves to arrive at winners. The prizes and certificates will be given during the valedictory function towards the end of the scientific program. Posters are displayed in the area adjacent to the hall, and the display time is between 10 a.m. to 11 a.m. There are few important announcements. This is an earnest request to all the speakers and sessions in charge to finish the topic in the allotted time. There will be a warning bell or buzzer 2 minutes before, followed by a final buzzer at the end. It is a humble request to all the attendees not to record the role play. For online attendees, role play will be available only in the audio format. Now, I will request Dr. Dinesh Saroj to take over.
Yes. Just actually, I want one comment on that anxious minds, because that is very important topic, and the incidence is rising of anxiety. So just I want to add that he can also do scared for parents, because that is available. And scared for parents can be compared with that child's scared test. That is one thing. And the another thing is that MKC's test, the screening questionnaire is available for the causative factors. So that can be used as a test for causative factor. That's all.
Another study which can be done is specific age and the sexual maturity. Whether there is any correlation between early bloomers and late bloomers and their sexual maturity scale, whether they are correlatable. Because we always try to say that they are hormone dependent things. And that is where that study also, if somebody can do it, but that will be more extensive because they will have to do a sexual maturity scale also. Thank you.
Thank you. Thank you, sir. Dr. Dinesh.
Good morning, everybody. Now we begin our next session, which is on nutrition. Fuel their future. Nutrition is the foundation of adolescent health. For this session, I invite session in charge, Dr. Renul Boralkar, Madam, Secretary MAHA AHP 2026-27 from Sambhaji Nagar, and chairpersons, Dr. Priyanka Parikh, nutritionist from MGM Medical College, Kamote, and Dr. Shilpak Shirsagar, Associate Professor, Government Medical College, Chhatrapati Sambhaji Nagar, to conduct the session.
Good morning all. I request the chairperson to be on the dais. There is a role play? After? Okay, great. So, respected dignitaries on the dais and our dear friends and delegates, I, Dr. Renu Boralkar, Secretary MAHA AHP 2627, on behalf of MAHA AHP, I would like to welcome you all and also MAHA AHAcon 2026. So, I would like to call upon our first speaker, Dr. Ratna Sharma ma'am. She will give us the inputs on tackling anemia in adolescent. Dr. Ratna Sharma madam is a pediatric hemato-oncologist in Mumbai, and she is the director of Bone Marrow Transplant Center, Borivali. Ma'am, you are...
Printer is not working. Printer आपको work नहीं कर रहा.
Dinesh, kindly let us know when the skit will be. Okay, thank you. Dr. Priyanka, please come on the stage. Yeah, welcome ma'am. Your time is 15 minutes.
Yeah. So time is 15 minutes and I'm before time by more than 15 minutes, right? So I'm not sure whether the
but
audience...
still it is 15 minutes only.
Yeah, I'm not sure whether the audience is ready for this talk before 9 o'clock, but thank you everyone. And the topic given to me is tackling anemia in adolescents, and I would like to thank the team of the organizers over here who have given me this opportunity to review the topic and share my views with all of you today. I hope the talk helps in making a difference and helps all of you to tackle anemia in adolescents as the topic is. Greetings from my center, which is the CTC PHO BMT Center. I'm not sure how many of you all have heard about it. It's in Borivali. You all are welcome to visit it. It's basically a hemonc and transplant center in Borivali, founder director being Dr. Manglani. This is the current team over there. And if you come that side, you're most welcome. So coming to the topic, why are we discussing this topic? What are the challenges? Is there something new about this topic? And can we change things? And can we make a difference? That is the most important thing. At the end of 15 minutes, I hope all of you are motivated to make a difference while dealing with this huge task. And is there anything new and different that can be done? Since long we have been talking about it, knowing about what is being done in our country, but we know the impact is not significant so far. So not in a big way about statistics, but yes, certain figures you have to know in this country. And when I say you have to know, by the end of this day, don't forget the first talk. The population of our country is 143 crores. So remember that, okay? The world population is 8.3 billion. Remember that too, okay? And 2 billion people are anemic. So all of you will remember that 2 billion people out of 8.3 billion people are anemic, and we are probably one of the patient of anemia, or we would be dealing with anemia. So we can't escape anemia, any one of us, okay? India, as it shows over here, India is all red. That means we have about 40,000 to 45,000 people out of 1 lakh who are anemic. What does that mean? In this audience, maybe of 50 today, 25 would be having a hemoglobin which is less than acceptable. So are adolescents going to be different? So we look at India, what is happening to adolescents? We always talk about under 5 children as pediatricians, but today I will stick to adolescents and only adolescents, okay? So adolescent girls, 59.1% as per as NFH survey, the National Family Health Survey number 5, which was completed in 2021. Among boys, it is 31%. Okay? If you look at the states other than Meghalaya, Nagaland, and Kerala, no one else is spared. Okay? Rest of it all are red and totally red, and out of that, adolescent girls are 59% of the adolescent girl population. So the Indian scenario, highest burden, we all know, and we have talked about it often, under 5, 67%. Things have not changed. Then comes the second major burden, why we are here and talking today, that is adolescent population, and out of which adolescent girls is about 59%, okay? So what do we conclude? That anemia falls during late childhood, but rises again during adolescence, and especially among girls about the age of 12 years. So as I told you, remember certain figures, even at the end of the day, though this is the first talk, 1.43 billion Indian population, 0.25 crore out of the 143 crore, that is 250 to 260 million are adolescent population, 17 to 18%, India's future workforce. This crowd knows it better than me because all of you are into adolescent medicine, and adolescent girls are about 8 to 9%. So 120 to 125 million are girls, and therefore we are talking of these girls, around 60% are anemic, okay? So it's a double burden, highest prevalence in children under 5, and then a resurgence in adolescents. And why are we allowing this resurgence? Are we all responsible for it or no? We have been pediatricians to be first to begin with, right? We are dealing with anemia in under 5. We are letting it come down in the age group before adolescence. Then why are we allowing it to rise when it comes to adolescent group? The same patients are following up with us, right? Do we see a change in the trend of patients? They may jump from one pediatrician to other, but they remain with pediatricians and adolescent medicine, and we are the ones who are responsible for the state of anemia in our country. So sadly, it's a regressive trajectory for India. We thought we would do better, but we have done worse. Unfortunately, that is the story. We thought that we will bring down to 36% in girls and 11% in adolescent boys. But what has happened? We have gone up in the last 5 years to 59%. Is it shocking? You can participate. Is it shocking or no? Yes, it is, okay? And this is going to affect the physical, cognitive, and reproductive health of the youngsters, which is a rapidly maturating cohort, and we need them as the task force and the working force of our country. They will take care of the nation, and they will take care of us. It was 54% in 2015 to 16 survey. It's 59%. We have not got better. We have got worse, okay? It was an illusion of progress for all those who were working in the field of anemia. They thought that the percentage of mild anemia was coming down, but they didn't realize that 41% became 26, but moderate became 12 to 30. That means the mild entered the moderate. So we made situation worse, not in terms of just the prevalence of anemia, but also moving from mild to moderate. So we are in a big problem, and we have to realize this. The national surge, if you all know, we have 28 states and 8 union territories, except for 7 states and 3 union territories. Everywhere else, it was a rising prevalence. Only these 10 areas had a dropping prevalence, and this is what I'm talking of is adolescent anemia. The observation, the state level policy dramatically overrides the national trend. That means the states which worked hard did better. The states which implemented the policy did better. It did not depend on what was happening at the national level. The whole nation was not moving in one direction. There were 10 territories which were moving in a different direction or a desired direction. What did Kerala do? Kerala, it came down from 36 to 33, and Andaman Nicobar and Lakshadweep had a success story, whereas the worst states were Jammu, Kashmir and Assam. We all talked about the Anemia Mukt Bharat for so many years, which was launched in 2018, but we forget that we are dealing with anemia since 1970 when it comes to policy, okay? The policies were put in place since 1970, and we are 2026 today, okay? We had the National Nutrition Anemia Prophylaxis Program. Those seniors over here would know it when it was launched, and they must have worked on it. Then came the NIPI program. We all were there for a part of it, National Iron Plus Initiative. And then came the Anemia Mukt Bharat. So Anemia Mukt Bharat is new under Poshan Abhiyan, but it has its predecessors, and we have not been able to achieve before, so we launched this as 6x6x6 strategy. Lot of disturbance. I mean, either listen or be part of it, because I want all of you to be initiated to the aspect of
Hello,
anemia.
please all be seated.
I know it's the first session and some settling issues, but
Yeah,
that's
it's
okay.
disturbing the speaker.
And we have started before time too. So Anemia Mukt Bharat 6x6x6 strategy. It was launched with the idea that we would do better than the previous two programs. We knew that we were not doing good, but do we need another program now? Because we have not done well with Anemia Mukt Bharat. Have we understood the Anemia Mukt Bharat? 6 beneficiaries, 6 interventions, 6 institutions, everyone is writing about it, the students are writing in exams, the examiners are checking the papers. Are we implementing it in practice? Have we understood that every component of it is important? Look at the target 6 beneficiaries. There were adolescent girls and boys mentioned very specifically over there. How many of us are giving iron prophylaxis to this adolescent population? How many of us are deworming them adequately all the time? Okay? If you look at the dashboard of Anemia Mukt Bharat, you should visit it, because only 47 lakh population or health personnel have visited the dashboard. Looking at the number of doctors, nurses, health professionals in our country, it's a very minimally, approached dashboard, but you should go through this dashboard. And what does this dashboard tell us? It tells us that India, the adolescent cover has been only 11.9%. That means out of the huge population of around 250 million adolescents, only 11% could be targeted with this program. And look at where Maharashtra is, 2.6%. And if you go deeper into the dashboard, you can get the states of Maharashtra, you can get the districts of Maharashtra. And let me tell you, Mumbai, Raigad, Thane are not doing well. They are doing dismally when it comes to adolescent cover for iron prophylaxis. Are we getting better? So this dashboard gives you year-wise, quarterly and month-wise. So I scanned. It gave me the opportunity, this talk, to look at the latest statistics. And what I saw was that gradually we have gone up in our coverage. And in April 2026, the cover for adolescents was 27%. We are doing beautifully when it comes to pregnant women, lactating women, and other women category, okay? But we are doing dismally when it comes to adolescents. And adolescents are with us, and they are going to be the future mothers. So we have to know that we have to ensure that they get what they need. If you look at this bar diagram and this section of the bar diagram, we have finally started getting better when it comes to covering the adolescents. From 32 million, we have touched 59 million adolescents. We have a target of how much? 250 million, okay? I hope you all remember the figures that I told you at the start, okay? So Anemia Mukt Bharat, it tells you very simply that 10 to 19 years age group should get the blue tablet, which is the iron folic acid supplement, 60 milligram of elemental iron just once a week. Now raise your hands, how many of you are prescribing it to the adolescents? Raise your hand, please. Once a week. How many hands went up? 1, 2, 3, 4. I have 15 minutes, so I can be quick in counting. So about 4 or 5 in this full audience. The house is not full, but if we look at the people here, very few percentages. And why are we depriving them of something that they have been advised to take? Okay? And are they not aware of it themselves? Yes. Are we aware of it? Yes. So where is the lag? The lag is from our side. Okay? So do we remember that hemoglobin levels have to be 12 and 13? What is 12 and 13 figure over here? 12 for females. Anything less than 12 for females. I've just put the figures to make it very prominent with nothing else. You have to remember that any girl with less than 12 is anemic. Any boy who's less than 13 is anemic. Don't let a report of 10, 11 pass out. Will you be able to accept a report of 10.5, 11? No, you shouldn't, okay? So that is what we are trying to tell. We know that the infrastructure biology, unimproved sanitation is not in our hand, but it increases the inflammation in the gut, increases the hepcidin, and therefore decreases the iron absorption. The WASH policy, water, sanitation, and hygiene is necessary. We can advocate it to our patients, but we can't implement it for them, okay? So anemia is an infrastructural symptom, beautifully given. The demographic matters, it matters over here. The rural population, uneducated, economically backward, are suffering more. The crisis is more in girls, the adolescent girls, okay? It endangers future maternal health. You have to know that, okay? The common causes: rapid growth, puberty, menstrual blood loss, diet low in iron-rich food, vitamin deficiencies, chronic illnesses or infections in this age group, and sometimes trait phenomena which gets missed throughout the childhood, or thalassemia trait or sickle cell trait could be, a cause of anemia. Symptoms you all know, I will not ponder on it, but you have to know that it can cause persistent tiredness, reduced physical activity, reduced mental performances, and therefore all this needs to be picked up. When you have patients coming with these symptoms, don't ignore, treat them with iron, and then put them on prophylaxis. The school attendance definitely suffers, and it is well proven in many articles. It affects growth, impairs cognitive performance, and endangers future maternal health, as I told you. The recommendations are clearly given, though it was a pediatric recommendation, but it was meant for children and adolescents. The Adolescent Nutrition Society was part of it. 4 authors from the state of Maharashtra. Yeah, I started early, so give me just 1 minute. The cutoffs are very simple. You have to, put this up on your clinic wall and have it available so that you can treat the patients when the time comes. And don't forget to put them on prophylaxis after completing the treatment. I will not read out the indices or the values, but they are simplified in this article. And all of you need to go through this article. October 2022 came when COVID was happening. We worked during the COVID time online to bring out this article, and now it is a standard of reference throughout the country and surrounding countries over here. Evaluation of non-responders, yes, you can evaluate them and find the cause and treat it and give IV iron if required only for what is mentioned in green over here. The action plan, give iron-rich food. So when it comes to tackling, give iron-rich food, give supplements as per Anemia Mukt Bharat plan, give therapeutic iron when it is indicated, B12 and folate when required, and treat the underlying condition. The eradication, as we know, is bottlenecked by poverty, food insecurity, and health illiteracy, which is not in our hand, but we can make a difference by giving them at least the iron prophylaxis. It was reversible in these states, or they brought in, the trend was showing a reversal because of the efforts they individually put, but Lakshadweep made it, it ensured that AMB program was implemented. They brought it down from 61% to 32%. Last 2 slides. So the cascade is basically a lot of socioeconomic determinants are there in the cascade, which finally result in decreased erythrocyte production or loss. They are fundamental determinants: economy, geography, ecology, climate. There are other things like education, health policies, cultural norms, and there are indeterminate determinants like food insecurity, poor quality of sanitation, and other things. Where can you make a difference? You can make a difference with health policies. If you have reached that level where your voice is heard, you can give them supplements, ensure that they have good health, and you can give them micronutrients through the AMB program. You can take care of acute inflammations quickly. You can work on chronic diseases when they come to you, and you can also pick up hemoglobinopathies if they are the cause of anemia. I'm sure we all will be able to make a difference if we do all that. So just to tell you how to tackle it, tackling means you test them, treat them, talk to them about anemia and anemia prophylaxis, and all be part of the anemia camp, which all of you are doing already. So with this, I would like to thank my team, acknowledge my team members, my center, and a big thank you to the organizers for giving this beautiful picture of all adolescents who look healthy and non-anemic here. And best wishes for the monsoon. Hope we have a good and adequate monsoon. Thank you.
Thank you so much, ma'am, for excellent inputs on tackling anemia in an adolescent. So our next speaker, I would like to invite Dr. Kinjwadekar, sir.
Thank you.
Now I would like to invite Dr. Upendra Kinjwadekar, sir. Your talk is on vitamin deficiencies. It is 10 minutes, sir. Dr. Kinjwadekar, we know him as our excellent orator and Central IAP President 2023 from Navi Mumbai. If anyone have question for ma'am, they can ask personally to her on this anemia tackling.
सर कुठलं तुमचं इथे बघा
4-1.
1-1 में देख 1 पे एक मिनट इसलिए तुमने बोला था इसमें
Good morning, friends. At the outset, let me thank Dr. Chitra Madam, Dr. Vaishali, and in the august presence of Sushma Madam, Piyalidi, Shamikda. It's a wonderful opportunity to with all of you, AHA champions. And the topic assigned to me is lacking vitamins. And I'm going to focus only on adolescents, though deficiencies of vitamins itself is a vast topic. But I'm sure that in a given stipulated time, I would be doing some justice that all of us in day-to-day practice, in which way can we concentrate on which subset of patients which are going to present to us with some of the vitamin deficiency. So without further ado, let me just straight away start with first case. There is a 13-year-old boy brought to our office by parents that noted swelling in her feet and ankles along with increased somnolence over past few weeks without a preceding illness. Because of long-standing avoidant restrictive food intake disorder, she's consuming only cow milk, banana, and some potato chips. She's very thin, severely malnourished. She has nystagmus, gait ataxia, diminished patellar reflexes. Now, levels of which of the following substances is the best way to order the confirm the cause of her neurologic symptoms? It's open to you. What would you do? Ascorbic acid, biotin, erythrocyte transketolase activity coefficient, phosphorus, or vitamin D? So it is number C, the erythrocyte transketolase activity coefficient, which is a wonderful marker for our first vitamin B1, that is thiamine deficiency. Remember that. And why should an adolescent become thiamine deficient? Very important to understand. Thiamine is often ignored, but it's so important for energy and neurological function of a child. RDAs are very less. Only adolescents with eating and restrictive food intake disorders are going to have problems. Those with anorexia nervosa, bulimia, and whatnot. Wernicke's encephalopathy is an extreme manifestation. Very, very, yes, we see dry, wet, which is a cardiac manifestation, usually is not seen commonly in adolescent age group, and the classic triad of confusion, ophthalmoplegia, ataxia plus peripheral neuropathy. And of course, remember that ETKAC is the marker for thiamine. Thiamine, friends, you know that it's available in nuts and beans, it's available in peas, it's available in spinach, it's commonly available, but only when this is a presentation that eating restrictive food intake disorder, they are the ones going to be thiamine deficient. Those who are practicing neonatology, I would just add on one sentence that if the mother is consuming betel nuts, this child will come with severe thiamine deficiency, and they're going to present with uncontrolled lactic acidosis along with encephalopathy. If a child comes to you or NICU with this presentation, a trial of 100 milligram of thiamine would be worthwhile. Let's move on to the next one. A 17-year-old with Crohn's disease has come with fatigue along with numbness and tingling. Some paresthesias are happening, and consumes a vegetarian diet. That's okay, but still, you know that we have to have something different also, but no abdominal symptoms. He had a resection of 30 centimeters of terminal ileum at initial diagnosis because of intestinal obstruction. The child is pale with some soft abdomen, and you see that hemoglobin is 10 with MCV of 62. Dr. Ratna is sitting here. She would say, why would MCV be 62? Which of the following therapies would be most appropriate? Should we recommend gluten-free, IM-B12, intravenous ascorbic acid, or folic acid supplement? And the answer would be, so it has to be intramuscular B12 injection. We have always been talking about megaloblastic anemia as a presentation, but we have often forgotten the neurological manifestations of B12, and which are irreversible if you don't treat them in time. So that's why it is important. This child, a Crohn's disease, it's a terminal ileum, which is where the B12 absorption takes place. You have removed 30 centimeters, you have IL Crohn's disease, and these are the patients which are going to come to us. And that's why this child is also anemic, so he needs to have cyanocobalamin. So spotting deficiencies in B12, neurological integrity, we always focus only on hematological manifestation, but let's remember, and of course methylmalonic acid testing would be also, if the B12 is normal, you can go for that. So these are the absorption obstacles, and when I talk about B12, I have to come and talk about B9 also, that's a folic acid. There again we talk about neural tube defect. It's important, essential. Every adolescent should be full of, and then of course periconception, folic acid supplementation, we are going to recommend that. But before that, remember that if you have a medication interference, child is taking anti-seizure medications, methotrexate, they increase the utilization, and these children are going to be deficient in folic acid. And last but not the least, most important, if the child, before giving B12, if we give folic acid, we are going to suppress the hematological manifestations, and the neurological manifestations would continue. So that's extremely detrimental. So B12 first, followed by folic acid. Let's move on. This is about B12. We have already talked about it. And this is about B9. Let's move on to the next case. During annual checkup of a 17-year-old boy, you see the health assessment, you have seen his home, you have seen his environment, education, activity, drugs, sex, and of course suicide. And the patient tells you he smokes every day. After providing counseling for smoking cessation, which he declines, you recommend supplementation of which one for this child? B1, B9, B12, C, or E? And the answer would be, somebody did murmur. Yes, it is vitamin C. Remember, extremely important. These patients are coming to us. Adolescents with smoking, males and females both, are not uncommon. Just because of smoking, you are nicotine vaping. I was just in UK a couple of weeks ago and saw 60-70% of were vaping. All young adolescents, vaping has gone up like anything. It may come here, but we have smoking also there. 35 to 40%. We know vitamin C is so very essential. It's an antioxidant collagen defense of the body, and these smokers will definitely be deficient. If the child is smoking, of course, you are adolescent health experts, you are going to talk about stopping smoking, but remember, this cannot be forgotten. So vitamin C for all those who are smoking. The next one, you are seeing a 14-year-old boy. This is all not uncommon now. Rheumatological conditions, patient taking biologicals, taking steroids are going to come to us. This is his third course of steroids in last 18 months. Mother brings up concerns about bone health. Which of the following is most appropriate for assessing his vitamin D status? We are going to do 125, 25 OSD, ionized calcium, or PTH. And the answer would be, of course, all of us do 25 OSD. Vitamin D deficiency. Friends, we have recommendation of giving it to every newborn, and we stop at 1 year of age. But remember, the second subset, adolescent also need, and that's up to 600 is the international requirement for adolescent. So let's give it. And of course, it's for more, the obese children will have it more. So in a nutshell, we talked about water soluble, we talked about fat soluble. A is important again. The autistic children, ADHD children, those are again restrictive behavior. They are going to have vitamin A deficiency. D is very important. But which are the patients, if you ask Dr. Upendra, we should concentrate for these deficiencies. They are the one with celiac, Crohn's, cystic fibrosis, anorexia nervosa, selective eating, anticonvulsants, and glucocorticoids. They are going to be deficient. Of course, E and K, not much to bother because your normal diet, plants, nuts, seeds, and leafy vegetables are going to give you adequate amount of the. And K, we talk about it, hemorrhagic disease of newborn, but in adolescent, we don't have to much bother about K. And of course, obesity. How can I not talk about nutrition and not talk about obesity? What is happening in obesity? Look at this. Empty calorie, all of us know, consuming a lot of calories, but no micronutrients. So I just can't stop at vitamin level. I have to talk about something beyond that also. High energy needs, no vitamins and minerals, risk of fat dieting. Then he goes on, or she goes on the other extreme and starts doing unscientific, restrictive weight loss methods, eliminating critical food groups. That is what is happening. And physiological, biological barriers, chronic inflammation, increased metabolic. Obesity is continuously a hyperinflammatory state. Remember that. Hepcidin, one of the hormones produced by liver, these are all causing so much of inflammation, and that's the reason for this. The metabolic demand increases and gut microbiota gets completely altered. All of us are talking about this. We are talking about neonatal age group, but remember, obese children are also deficient. So let's take care of their micronutrient deficiencies also. I'm not going to talk about iron because I read the program. I knew Ratna would be doing a fantastic job, which she did. So iron, zinc are also equally important. Iodine deficiency, not very, but when I went through one Indian paper, 20 to 65% still goiter prevalence. If you have an adolescent with goiter, delayed sexual maturation, impaired cognitive development, especially a girl, and those, I recommend from every forum to have millets, but if your diet is only millets, then they are going to have deficiency of iodine. So always ensure that and of course, urinary iodine excretion, we don't do it. It's done for the research laboratories. But the Indian landscape also shows that we do have iodine deficiency. Don't ever forget choline. We have not talked about this. This is neither a vitamin nor a mineral, but very important constituent of our food. It does so many things. I don't want to highlight all those. Of course, you can see that. But your choline, folate, B12, and methionine are all interlinked. And then if the availability of metabolism of one is disturbed, there are changes in others. And choline deficiency, friends, we are talking about folic acid in neural tube defects, but it is also choline. It's cleft lip choline, Down syndrome choline. So ensure, and very simple dietary sources, egg yolk, meat, fish, legumes, nuts, and milk. No great demand is required, but ensure that the child has some of these food groups to ensure that the child is not choline deficient. And finally, she talked about Anemia Mukt Bharat. But I came across this wonderful paper which is published a couple of months ago, multiple micronutrient deficiency among adolescent girls with normal nutritional status. Mind you, the BMI is normal, weight and height are normal, but still this child has multiple micronutrient deficiencies. This is published in Tamil Nadu, and what it shows, thanks to AI, the entire paper I could convert it into a single slide. This is the entire paper, and that's just because of AI I could do that. Hidden hunger beyond iron deficiency in adolescent girls, we are talking about 80% of them who would have normal BMI would also have some micronutrient deficiency. Failure of iron only focus. We have so much of supplementation program, but there is a critical gap. 22.3% girls reported consuming half of their received supplements. They don't even have it. 61.8% were participating in deworming program. And of course, we have to broaden the nutritional lens. We have to go beyond iron. I think government has also understood that. First it was vitamin A, then iron. We cannot just hold on to one nutrient. It has to be all the nutrients together. And of course, everybody has now understood that school is a primary focus, which we are doing. And through Sankalp Sampurna Swasthya, we try to enlighten and empower these adolescents that they should know what I should consume and what is healthy, what is not unhealthy. And finally, I cannot end without this disturbing slide. 2026 publication. Let me concentrate. India is different with MAHA. This is a MAHA AHA, and you can see the indicators. We have BMI less than 18, 15 to 49. So we have late adolescents, 12% urban. So rural, you have less BMI, And talk about urban, and you have the BMI 40 and 41%. So 40 to 41% of our adolescents have BMI which is high, more than 25. Friends, it's a wake-up call for all of us in Maharashtra that we have to work on this, and it cannot happen without we counseling them. And one simple slide, if you show everywhere, this is what we did in Sankalp Sampurna Swasthya. And let me tell you that two of the main persons, we have Dr. More over here, and of course Dr. Chitra Kulkarni. A big round of applause to her. She herself went to 100 Jilla Parishad schools. Mind you, not hi-fi schools, Jilla Parishad schools, and enlighten these adolescents. What we want to tell them, half of your food plate has to be vegetables and fruits. You would not be vitamin deficient. And couple it with iron, nuts and seeds, that's it. Half of food plate. We are all supposed to have 400 grams of vegetables. I'm sure none of the adults are also consuming just 100 grams of fruits, but we are not having that. And of course, rest of the things. If this one simple message is given to all the adolescents across, I'm sure we would not be witnessing such deficiencies in our adolescents. I'm sure all of us are talking about it. Adolescent health experts, wherever given opportunity, are working on it. But let's continue our efforts and try to change these figures. They're extremely horrible. 40% is not acceptable. Obese children in Maharashtra, 15 to 49 years of age. Thank you so much for your patient hearing, and thank you all for giving this opportunity.
Thank you so much, sir. Very engrossing topic. In a short, fast-forward way, you have done it. And so we know that the vitamin deficiencies, they are vital, not iron, vitamin A. As you said, you have to see for choline and everything. Thank you so much, sir.
Thank you.
Now we will take over the skit role play.
Yeah, so I invite the performers of the skit, Anna and Mia on the stage. Director, Dr. Rajendra Chandorkar. Scriptwriter, Dr. Vaijayanti Afle. Actors are Dr. Ajay Kohli, Dr. Nisha Satai, Dr. Prajakta Radke, Dr. Rajendra Chandorkar, Dr. Sanjeevani More, Dr. Santosh Kangule, Dr. Upendra Sugvekar, Dr. Vaijayanti Afle, Dr. Vaishali Shirsetti. Over to you all. Dr. Ujjwala Gavli as counselor.
चलो अब इनकी बर्थडे पार्टी तो हो गई। बर्थडे पार्टी होने के बाद अब शनया घर में आ गई है। शनया की माँ मिसेस गोयल वो बहुत ही एंशियस और वरीड है इसके जंक फूड कंजम्पशन से। जब से वो 11th क्लास में गई है उसका टिफ़िन का सब रूटीन डिस्टर्ब हो गया है। अब देखते हैं इनमें क्या डायलॉग होता है।
मैम तो मेरे पीछे ही पड़ी रहती है बार बार स्कॉलर बैच के लिए। अब मैम को कल बोल देना मुझे इस साल एंजॉय करना है। अपनी फ्रेंड्स के साथ पार्टी नहीं करूँगी तो कब करूँगी? सब ठीक है, पहले मैडम से मिलते रहते हैं। चलो मैडम के पास जाएंगे।
अब मिसेस गोयल और शनया प्रिंसिपल मैडम को मिलने जाते हैं। अब देखते हैं प्रिंसिपल मैडम से उनकी क्या डिस्कशन होती है।
हाँ मैडम, आपने बुलाया था इसलिए आ गए। यस यस, नमस्ते मिसेस गोयल। एक्चुअली लास्ट यूनिट टेस्ट में शनाया का रिजल्ट बहुत ही अच्छा आया है। मैं उसको स्कॉलर बैच में लेना चाहती हूँ, बट आजकल आई डोंट नो उसका ना फोकस नहीं है क्लास में, काफ़ी कम हो गया है।
हाँ, मैं भी उसको टिफ़िन देती हूँ लेकिन वो लेकर जाती ही नहीं, कुछ प्रॉब्लम हो गया शायद उसको।
मैं टिफिन लेके जाती हूँ तो सब फ्रेंड्स मुझे चिढ़ाते हैं।
अच्छा, ओह दैट मीन्स इट्स केस ऑफ बुलिंग। ओके, मैं इसके ऊपर ध्यान देती हूँ। आप एक बात करिएगा, इसको काउंसलर के पास लेके जाइएगा और आप भी घर पे इसको स्कॉलर बैच के लिए ये करिएगा।
डेफिनेटली मैडम, आप हमें बता दीजिए, हम जाएंगे उनके पास।
और काउंसलर को मिलने के बाद मुझे प्लीज़ आप मिलेगा।
डेफिनेटली, यस।
बाय।
यस, थैंक यू।
यहाँ आपने देखा कि टीचर का रोल कितना इम्पॉर्टेंट है। प्रिंसिपल मैडम ने बुलिंग की बात जो है वो अच्छी तरह से नोट कर दी है और जंक फूड के लिए भी वो बहुत अवेयर है और काउंसलर के पास शनाया को भेज रही है। तो अभी शनाया और मिसेस गोयल काउंसलर के पास जाते हैं, तो वहाँ देखते हैं हम आगे सीन कैसा होता है।
गुड मॉर्निंग मैडम।
गुड मॉर्निंग मैम। गुड मॉर्निंग, बैठिए। गुड मॉर्निंग शनाया, बैठिए।
मैडम, माई सेल्फ मिसेस गोयल। कल हम प्रिंसिपल मैडम से मिले थे, उन्होंने आपसे मिलने को बोला था।
हाँ, प्रिंसिपल मैडम का मुझे फ़ोन आया था, शनाया का बारे में बोल रहे थे। शनाया बेटा, तुम्हें अपने डाइट पर ध्यान देना होगा।
बट मैडम, मेरे फ्रेंड्स पार्टी प्लान करते हैं तो मैं मना नहीं कर पाती हूँ, तो उस बहाने जंक फूड खाना हो जाता है। और टिफिन लेके जाती हूँ तो सब चिढ़ाते हैं और फिर मुझे फोमो होने लगता है।
वो तो ठीक है बेटा, बट तुम्हें अपने डाइट का डिसिप्लिन रखना पड़ेगा। डाइट के लिए तुम्हें अपनी सेहत अच्छी रखनी पड़ेगी। तो डाइट के बारे में मैं तुम्हें थोड़ी चीज़ें बताऊंगी।
मैडम, मैं आपसे रिक्वेस्ट करूंगी कि आप मुझे एक लिस्ट दे दीजिए, उसके हिसाब से मैं इसके डाइट का प्लान करूंगी और उसके हिसाब से इसको टिफ़िन दे दूंगी। आप दीजिए।
ठीक है शनाया, देखो तुम्हें सिर्फ 2 चीज़ों का ख्याल रखना है। एक तो तुम्हें जंक फूड खाना कम करना है और तुम्हारे लिए जो अच्छा सेहतमंद घर का खाना है वही तुम्हें लेके जाना है। जो तुम्हें चिढ़ा रहे हैं उनको इग्नोर करना है, ये बातें तुम समझ लेना। दूसरी बात, तुम्हारे फ्रेंड्स के साथ तुम मज़े कर सकती हो, सेलिब्रेशंस कर सकती हो, पर उस वक्त तुम्हें जंक फूड खाना बंद करना है। ये 2 चीज़ें तुम्हारे लिए, तुम्हारे सेहत के लिए बहुत महत्वपूर्ण है, क्योंकि हम सब जानते हैं कि स्वस्थ पोषण ही अपने बेहतर जीवन की एक चाबी है।
तो यहाँ हमने देखा कि शनाया को धीरे धीरे समझ में आ रहा है कि वो कहाँ उसकी मिस्टेक हो रही है। अभी और 3-4 काउंसलिंग सेशन में वो पूरी बात समझ में आ जाएगी। तो टीचर, पेरेंट्स और एडोलेसेंट काउंसलर ये एडोलेसेंट के पिलर्स है और वो उन्होंने अच्छी तरह से गाइड किया तो कोई भी एडोलेसेंट राइट न्यूट्रिशन की पाथ पर जा सकता है।
Presentation and thank you so much. Clap for them, please. So as this is a part of the nutrition session, the skit was related to it. Now I will call upon respected Sushma Desai ma'am, our next speaker. She is our esteemed faculty and she will touch upon the metabolic syndromes that are silently creeping into the lives of our adolescents. Madam is the current chairperson IAP AHA from Surat, Gujarat. Welcome ma'am to Maharashtra.
Thank you, Dr. Renu, for that kind words of introduction. And I would first thank my previous speakers and the role players for making my job so easy, particularly Dr. Upendra ji. I mean, that was a kind of verbal tsunami, but very well articulated. So I'm so very thankful to all of you, and I'm thankful to the organizers for giving me this opportunity to interact with my Maharashtra family. इतना टाइम कट कर देना, अब मैं चालू करूंगी.
Starts now, ma'am.
But presentation is not there. Okay, so friends, with the rising, urbanization, sedentary lifestyle, faulty dietary pattern, lack of physical exercise, and so much and so going on, happening in the adolescent's life, there is a rising prevalence of obesity, and that was so alarming now we have seen. With that, our adolescents and youth are entering into a serious, dangerous zone of metabolic derangements. And we are going to talk about the Indian aspects of that serious zone, the metabolic syndrome. Okay? Could you do it? So basically, we will be talking about the Indian cutoffs, the definitions pertaining to Indian children. There are a specific criteria set up for the Indian adolescents, and we are going to discuss about only Indian aspect of metabolic syndrome. This is just to sensitize all of you, and I'm not going to go into details of all that pathophysiology and very much in-depth discussion on the management part and other stuff. I just wanted to, sensitize you guys about certain Indian data, Indian cutoffs, and so that we can keep our antennas open when we are handling our adolescents in office practice. We can start early screening, because prevention is the only measure I would like to say. ये है ना? Okay. Yeah, thank you. So, okay. So, let's start with this case, which is so typical we see in our day-to-day practice. A 14-year-old Auburn boy who was brought by the parents for the routine checkup because they wanted to get him admitted in a boarding school. And this child has a completely sedentary lifestyle, more than 5 hours on screen time and practically no physical activity, with a family history of diabetes in father at a very young age. So why do we bother about this case? India, as we all know, is an epicenter of diabetes and atherosclerotic cardiovascular disease. We, the Indians, our children, they are thin, fat individuals with a very, very high visceral fat, around 20% more than whites. And this makes us highly vulnerable to the chronic inflammation and insulin resistance, with chances of type 2 diabetes and atherosclerotic cardiovascular disease at a very young age and at a comparatively low BMI. So this is where we have to put in our efforts. So what is actually a metabolic syndrome? It is a cluster of cardiometabolic risk factors, which includes the insulin resistance, which is depicted by central obesity, the dysglycemia, dyslipidemia, and hypertension, with an increased risk of type 2 diabetes and cardiovascular disease at an earlier age. Now, why are we calling it a silent epidemic? We all know it. The term silent reflects its hidden nature. We are missing these cases here and there in our OPD, and the epidemic means there is an alarmingly rising prevalence. You can see the statistical data. There is a 3-fold rise in the incidence of metabolic syndrome during past 14 years. And the urban children, as Dr. Upendra also, depicted at a very, very high risk, and the children with an obesity, which is so high as 40% has a 35 to 45% higher chance of metabolic syndrome. So now, IDF for the age of 10 to 16 is universally accepted criteria. These are the cutoffs for the Indian children. For central obesity, I would like to emphasize here, not to go for BMI, but for the waist circumference. If the waist height ratio is more than 0.5, it is quite suggestive of central obesity, which is what we have to diagnose. And any waist circumference using the Indian chart, if it goes beyond 90, that is a criteria. Of course, fasting insulin more than 100. And the triglycerides, here we have to focus on the age criteria rather than those, adult criteria which is mentioned in the laboratory report. For the age 10 to 15, it's more than or equal to 110. And beyond 15, it is, more than 130. But the alarming stage is more than 90. Here we have to check the children. Of course, low HDL is a very characteristic of Indian children, below 40 for boys and below 45 for girls. These are the cutoffs, and we have to keep in our mind. Rather than keeping that blanket statement of more than 130/85, it is better to have the hypertension charts with us, and any pressure level beyond 90 for the age, sex, and height is to be considered. Any adolescent meeting more than or equal to 3 criteria are at a risk of metabolic syndrome. So why, what are the India-specific factors? The most important being, as I said, we are thin fat people, and that the higher visceral fat coupled with the genetic susceptibility for the higher risk of type 2 diabetes at a younger age, faulty dietary pattern, those kachori, samosa, fast food and all that. And of course, the sedentary lifestyles are the triggering factors. So there is a clear, why are we talking about adolescence? Because there is a physiological insulin resistance during adolescence, during TANA stage 2 to 4. And if this is coupled with obesity, faulty diet and faulty lifestyle, that pushes the adolescent practically to the serious consequences of metabolic syndrome. Also, the growth hormone, IGF-1 and the sex steroids, they all modulate the insulin sensitivity, and that is why we have to be very careful when dealing with the adolescents. Now, what are the core mechanisms? I'm not going to go into depth of this thing, but as I said, the insulin resistance is the key factor, which is triggered by the visceral fat and the genetic and epigenetic. Here we have to be very, very, sensitive about the history taking, the history of gestational diabetes, which pushes the fetus to the hyperglycemic environment since the beginning. And that makes him more vulnerable to the insulin resistance in later life. So the maternal hypergestational glycemia, low birth weight with a catch-up growth, peripubertal catch-up weight gain, these all are the factors we need to identify. Dyslipidemia, we are very characteristically, we have a low HDL, particularly the adolescents, and normal or higher LDL. This makes us more vulnerable to atherosclerosis and the hepatic steatosis, which is steatosis, which is the very sensitive marker of metabolic syndrome in adolescents. So, now, so what are the cutoffs? Basically, 3 things we have to keep in our mind. All the adolescents who visit our clinic, we need to have the hypertension, the blood pressure measured. We should not skip this thing. Second thing, for plotting the growth chart should include plotting the waist circumference, and waist height ratio is to be plotted. For the age, for the higher BMI, the Indian cutoff we know 23 is the overweight. So for a higher BMI, overweight or obese children above 8, even though we do not put diagnosis of metabolic syndrome in the children below 10, but from the 8 onwards, those with a higher risk factors and obesity or overweight, we used to start screening. And what is the screening toolkit? It is apart from the waist circumference, BMI, and anthropometry, there is, of course, we have to fasting glucose, lipid profile, and we have to use certain very specific profile like non-HDL, LDL profile. That is very, very important. So these are the cutoffs, and these are the investigations. At least we have to be worried about, and we have to think about the risk, high risk factors, and we have to screen the high risk adolescents at an earlier age. So. Okay, so what is the specialist toolkit? Here, there are some plus markers. As I said, non-HDL cholesterol is a more sensitive marker. That is total cholesterol minus HDL. That's considered as a more sensitive marker for the atherosclerotic cardiovascular disease. ALT is another very sensitive marker for the hepatic steatosis, and that is a hepatic sign of metabolic syndrome, and that is why we are, labeling now as a non-alcoholic fatty liver disease. We are making it a metabolically dysfunctional associated fatty liver disease. Serum uric acid, some of the studies are available. It is another very sensitive marker which we can use as an early detector. And there are certain studies, but it is not included in the diagnostic toolkit. Now, what are the risk factors? Okay, what are the high risk cases? Of course, the childhood obesity and overweight with the family history of diabetes, early onset cardiovascular disease, PCOS, those with a birth history, as I said, the low birth weight with catch-up growth and peripubertal weight gain, and the maternal gestational diabetes. Of course, the lifestyle makes a lot of difference, so we have to take the history regarding lifestyle disease and the features of obstructive sleep apnea. They are all the indicators of some of the metabolic derangements. On physical examination, the acanthosis nigricans is now considered as a very sensitive marker. We have to keep in our mind, if it is there, we have to think of insulin resistance than anything else before let him go out. Of course, waist to height ratio, hepatomegaly, and PCOS signs, that is hyperandrogenism, are the. Okay, so now our index case, which I investigated this case, on anthropometry, his BMI is beyond 95th percentile, and his waist circumference was more than 90th percentile with a more than 0.5 height to weight ratio. Blood pressure was quite high for his age, and he had physically, acanthosis nigricans. These are the investigative results. Fasting glucose was more than 108, triglyceride 186, HDL 36, and LDL 185. The hemoglobin A1C is 6.5. What is your diagnosis? What is your diagnosis? This child is obese, meeting all the biochemical criteria. This is a child of metabolic syndrome. Now, there is a diagnostic paradox. Here I want to draw your attention. This is another child. Same, probably he came in a day or two after that boy visited. This child is a 13-year-old urban boy with a BMI 22.1. He has a waist to height, but the waist to height ratio is 0.54, which is higher. His physical findings had acanthosis nigricans and blood pressure, which was higher, more than 90th percentile for his age. And labs were quite suggestive of metabolic derangement. What will be your diagnosis in this case? This is not an obese child, neither an overweight one. What do you call him? He is a clear case of metabolic syndrome. So this is where we have to keep our antennas up, right? What are the management principles? Lifestyle, lifestyle, and lifestyle. That is the mainstay of therapy. We all know, why it is skipping? Okay, so we all know about 5-2-1-0, 5 or more servings of the fibers, the fruits and veggies, less than 2 hours of screen time, at least 1 hour of vigorous exercise for adolescents and children, and 0 sugary drink. The pharmacotherapy has a really very, limited role in the management of metabolic syndrome in adolescents. But some of the cases, like those who have a history of type 2 diabetes with obesity not responding to a very strictly observed lifestyle management, they need metformin, and that gives a good results. Even those cases who have a high-risk family history and those who are entering into danger zone of obesity, sometimes we have to think over it. But the first trial will be lifestyle modification. Of course, dyslipidemia with triglyceride more than 500 and LDL more than 990. Statins are given in selected cases with a regular follow-up and check. Hypertension has to be, mild to moderate. Lifestyle gives a good result. Moderate to severe, sometimes we have to add in antihypertensive as per the hypertension guidelines. Of course, we definitely should go for the nutritional supplements. Family-based intervention is extremely important. Family diet, family media plan, and family
2 minutes
exercise.
remaining.
Yeah. So this is very important. And what is our role? The most important, I would say, keep cutoffs in your mind. Identify the high-risk cases. Add waist circumference in your anthropometric measurement and spread awareness in the community like Dr. Chitra did a wonderful job. So the concluding thoughts are, screen all the high-risk cases. Keep waist circumference and waist to hip ratio in your mind. Plotting the growth chart is a very, very important thing which we should start observing. Measure the blood pressure in all the adolescents who are visiting our clinic. Spread a word in the community that I would like to tell all of you more and more, 100 times and more than that. Insulin resistance is mostly, depicted by the acanthosis nigricans. Don't miss this sign. Sometimes adolescent may not have acanthosis nigricans over the neck. They may have in the groin area, hidden acanthosis nigricans. We should not miss if the cases are high-risk cases. And of course, family-based approach is most important. Friends, we are not fighting obesity. We are fighting genetics and epigenetic environment. And there we have to keep our antennas open, screen the children at high risk, and keep the vigilance over there. Lifestyle, lifestyle, and lifestyle. Thank you so much.
Thank you, madam, for an excellent presentation.
And of course,
Thank you, ma'am. And you have highlighted very beautifully the 5210 metabolic problem. And now we thank you, and please have a seat. Now, dear friends, we will have a message by our National CIAP President, Dr. Neelam Mohan Madam. It is a video which is recorded and sent by her in the morning. So we'll display it now. Yeah. Yeah. Do you want mine?
Because that is the most important reason for the cortisol, melatonin, leptin, ghrelin factors coming into the metabolic syndrome. Let's start focusing on sleep also at our every visit.
Point
Thank
well
you so
taken,
much.
ma'am. Thank you so much for your input.
Greetings to the MAHA AHacon, which is the annual Maharashtra Conference of Adolescent Health Academy 2026. And I'm happy to see that the AHA Raigad branch, in association with IAP Raigad and the MGM Medical College, is organizing this on 14th of June. Thank you so much, Dr. Monty, for inviting me, and Chitra for inviting me. Would have loved to be there, but as you all know, that there was a meeting in IJPP too, and as the president, I had to be, there. But so kind of you to have accepted to have my talk digitally. And the title is Longevity versus Quality of Life in Adolescent, which I have given this title to Dr. Monty when he first connected me. And thank you for accepting it. And I don't need to introduce what you all know, that right now I'm wearing the hat of a policy health, and I'm trying to do more work in policy and pediatrics rather than my core field, which is gastroenterology, hepatology, and transplants. Yes, we've done great in India and reduced the child mortality rate, down by 21. As you can see in the recent numbers are still, the IMR is going down, and under 5 is going down. But I want to highlight that when I talk about the vaccination coverage, we do not have any statistic to talk about the adolescent vaccine report in India. And I've noticed that it is the weakest link in the immunization chain. And that is going to be an issue because we are talking about the quality also in children. So these baby children are going to be predisposed to infections, and I'm very happy that the government of India has taken HPV rolling, and maybe many adolescents may thus come and they may get the catch-up vaccination if they've missed. Looking at the adolescents' malnutrition and anemia statistics, we all know that nearly 59% of adolescent girls, 15 to 19 are anemic, and adolescent boy 31% if I take between the 15 to 19. So that's a huge population of 73 million. But if I look into the other statistics in adolescents, still chronic undernutrition is 1 in 3 in under 5 children, but it progresses even into adolescent with 27%, and low thinness is in 25%. But what we are understanding is the statistics gradually is increasing of overweight and obesity, and in some metropolitan cities it has gone up to 8% and more of obesity, 8 to 10. And if I take the entire adolescent group, it is close to 1 in 3 adolescents who are anemic. And if I look into the less than 5 years, it is 67% of them. Why I call the pediatrics in India at crossroad now is while we are trying to talk about the infectious diseases which have not gone, still we see pneumonias and diarrheas and TB and viral hepatitis A, but we have a newer diseases which have come, which is the non-communicable diseases in the form of hypertension, fatty liver disease, MASLD, chronic kidney disease, and mental health issues beside that. And we are underestimating pollution because 1.79 children in India died due to pollution-related issues under 5, and globally almost 5.9 million newborns were affected, had deaths related to pollution, its effect on the mother and prematurity and etc. So these are the environment and stress factors. So India stands at a very unique junction presently. The GI disorders which we are seeing, we've understood what is the little brain in the gut, and we are seeing a lot of the mental health issues, and related to that, the brain and gut issues to talk in detail is beyond the scope of this talk. But just to highlight, 1 in 7 adolescents is having mental health problems, but the truth is 80% have a treatment gap and they're not recognized. And what I'm going to be doing, we will talk about it, hearing disability in India is also pretty high because of the overuse of noise pollution. Global screen time in children in India is turning out to be probably highest in the world, with around 4 hours a day. And excessive screen is seen in 83% of the school children. Less than 30% of the adolescents meet the physical activity guidelines. And even in the schools, only 1 in 5 have the daily physical activity, which is only 20%. So overall, schools and otherwise, it is going down. And pollution and its effect, like in Delhi, 30% there was lower lung function in children's school as compared to South India. And I've given you the statistics about the prematurity, mental death, and 1.7 lakh death in children related to pollution, increase in asthma, the turnover rates, and India is 66 of the world's 100 most polluted, and if I take 22 report, we were 21 of the 30. So even in the last 25, we are 2/3 of the world's most polluted countries. India comes in that. So we know that the risk of NCDs is increasing. With 77% of the deaths reported is going to be due to NCD, and we now understand that it is the pediatric fatty liver disease or pediatric obesity which leads to increase in life, because it is a progressive condition, and the impact is in the liver, and then affects the insulin resistance subsequently and the diabetes and all, but the first hit is the liver. And when I talk about the quality of life, this is what I wanted to talk about, quality. It's not about survival, but thrival. We are having fatty liver disease seen in 35% of the obese children, and we have anemia, more than in the adolescent teens. I've given you the data. So many adolescents, girls that are anemic, and they have chronic heart disease because they're underdiagnosed. They end up, progressively, and the brunt of kidney disease and heart disease comes in the adolescent because they are missed in the screening in early age, because we don't have a habit of checking blood pressures also of children, and the neurodevelopmental disorders, etc., which can progress and have an impact in the adolescent age group. Why I'm showing this slide is we know that breastfeeding protects the future NCD and improves the educational attainment and future earning capacity, and our breastfeeding rates can still be improved, because still we are struggling close to around, the latest statistics is 56%. But when I spoke to the ministry 3 days back, they said that because they had to take 6 months, it came to 66, but exclusive breastfeeding, if they took first 4 months, they were much higher than the NFHS data. I mean, that's the explanation they were giving, but they, because mothers started working, and so till 4 months, still the rates were better than earlier, was what I was told. So what is the role of a pediatrician? It's not only about a good clinician. You have to look into holistic care, preventive health. You have to talk about advocacy about nutrition, lifestyle. You have to be doing a lot of awareness and education, and Raigad branch, I must compliment you. I think you spend a lot of time into all these activities. Kudos to the entire team who's doing that. And of course, you need to update yourself and be a good role model and take care of yourself during this. Don't forget that growth monitoring is a basic service. It's not a luxury. Every adolescent that we talk about must have a growth chart, and you have to be the guardian of the organ health, and therefore you need to detect overweight and fatty liver disease. You need to detect congenital heart disease and asthma, pollution related disease. Take environment history in your history taking. You need to prevent the progression from AKI to chronic disease, because AKI is common due to dehydration, infection, drugs, etc. We don't look into this. We don't check the BPs, and they end up with the chronic disease. Let us prioritize about the mental health, adolescent health. And so anchor vaccination to every visit to the screening also. So even when the children can young to you, do ensure that you screen them for developmental issues and school going children, mental health issues, and build the trust around them. And as I said, you need to be very holistic beyond your clinic into advocates, educators, and policy influencers, community. So you can ask me, Madam, you're speaking so much, but what is the role, what are you doing for IAP? So my role as the president of Indian Academy of Pediatrics, what am I supposed to do? I need to empower the pediatrician, I need to educate the parents and community, and I need to influence the policy. So I need to tell you all that I want to talk about survival to thriving generations, holistic and care. So I wanted to focus on moving from hospital into community and illness to wellness, survival to thrival. So the programs that have been undertaken this year have been a lot into talking about the Viksit Bharat. In the
Last
sense,
2 minutes.
we have at least 18 modules that we created, which are only for the public health issues. So I have looked into the nutrition, which are going to be 200 workshops. A to Z 100 workshops is launched already, and the TOT is today also the second day. And for infection, that was ID Mountain, 3 years. I put aside 1 CR into the greater data, and we have provided you with a free statistician. We provided you with the app called IAP Care, which is for the parents too, where they can just do a 24-hour dietary recall by showing the food or talking into it, and they will get the total calories, protein, so that the doctor can see what they're eating and then advise it. And then we came out. In the community, we came out with empowering the nursing. So it's an action plan, which is the social empowering the nurses this year. And for the school health, I seek your support, which is called the OGIS, IAP OGIS School Health Program. In continuation with SSS, this is a little forward which talks about the OGIS Poshan and OGIS Manas, and how we can go and talk to the teachers. And there's going to be a handset. All those who are interested can directly send a mail to central office, to me, to connect. We are going to launch it in this month. So you can connect to that, and the slides, everything will be shared with you. All the data will be put into it. And I'm expecting that we should be able to do a good work in that too. So thank you for inviting me over, and best wishes.
Thank you
to
so much,
all.
ma'am.
Together we can work for a brighter future of India. And I have been a public health voice. Those who are not following me can just check my name. It's Dr. Neelamohan.
Round of applause for ma'am, please. Thank you so much.
1.25, but a total
Yeah.
public health issues where I'm not projecting myself into liver transplants or anything public health.
Good morning,
With
everyone.
this mission I'm
I
doing,
would like to
thank you
give
so
thanks
much,
to all the
and best
speakers
wishes to all
for
of you.
giving us wonderful insight about the nutritional status among the adolescent population in India. Yes, in India, adolescent population is facing dual burden of malnutrition. Here, the undernutrition, the micronutrient deficiency, anemia is prevalent, and also the overweight and obesity is prevalent. So for that, to prevent and control these problems, comprehensive intervention is very much essential. By the help of this comprehensive intervention programs, we can prevent, control the malnutrition among the adolescent population. Thank you so much.
At the outset, I would like to thank all the organizers to give us the opportunity to chair these talks in the morning, which are very important and very enlightening also, because we face these issues in our day-to-day practice, in day-to-day Indo patients also. I thank you once again, everyone, for giving in the inputs, and all the speakers and the skit players, all the role play skit players will come outside. We'll have a felicitation program in the porch outside. Thank you.
With this, we have come to the end of the nutrition session. I request all faculties, chairpersons, session in charge, and members of role play to proceed for the felicitation outside. Thank you for the wonderful session. Now we proceed to the next, that is mental health. I invite the performers of Grey Sky on the stage. Director Dr. Rajendra Chandorkar, script writer Ms. Sonali Gujarati. Actors are Dr. Ajay Kohli, Dr. Chitra Kulkarni, Dr. Rajendra Chandorkar, Dr. Sanjeevani More, Dr. Santosh Kangule, Ms. Sonali Gujarati, Dr. Ujwala Gavli, Dr. Upendra Sukhvekar, Dr. Vikas More. Over to you all.
जायचं मध्ये बोलायचं परत यायचं साईडला असं करायचं असं करावं लागेल.
हे नेक्स्ट आहे हे बॅक आहे हे करू का
कहानी है आर्यन की। बाहर से सब ठीक है लेकिन अंदर से बिल्कुल टूटा हुआ।
मैं कुछ नहीं करता, पढ़ाई करता हूँ तो उसमें भी कुछ ठीक नहीं कर पाता। मेरी मम्मी पापा कभी खुश नहीं होते। मुझे तो लोगों से मिलने के लिए डर लगता है, शर्म आती है, इसलिए मैं अकेले में रहता हूँ। मुझे तो लगता है कि मुझे मर ही जाना चाहिए। सबकी जिंदगी इतनी अच्छी है, फिर मेरी क्यों नहीं? ऊपर से तो मैं रोज हंसता हूँ, लेकिन अंदर से रोज रोता हूँ, रोज रोता हूँ।
क्या है ये? सबके बच्चे विदेश जा रहे हैं, अच्छा कमा रहे हैं, अपने माँ बाप को मदद कर रहे हैं, और तुम कुछ नहीं कर सकते।
माँ मैं कोशिश कर रहा हूँ।
कहाँ? कौन सी कोशिश? अपना रिजल्ट तो 0 है। इस बार मुझे रिजल्ट चाहिए, रिजल्ट।
अरे माँ मैं मशीन थोड़ी ना हूँ, अरे मुझे भी दर्द होता है।
वो मुझे कुछ नहीं पता, रिजल्ट ला के दो।
तुम्हारे नहीं हर दिन ताने देना, तुलना करना, मुझे लगता है मुझ में ही कुछ कमी है। मैं कोशिश कर रहा हूँ माँ, सच में कर रहा हूँ।
दिखाओ फिर।
बच्चों को बार बार उनके ऊपर दबाव देना, उनको प्रेशराइज करना, हर बच्चे की रफ्तार अलग होती है, उसका रास्ता अलग हो सकता है। लेकिन जब दुनिया सवाल पूछती है तो कहाँ देखेगा वो? सबसे अपनी सुरक्षित जगह पर, वो है उसका घर। लेकिन जब उसके घर से ही सवाल उठते हैं तो कहाँ जाए?
अरे देखो देखो, ये आर्यन की रील बन गई। अरे बंडू वाली, देखो वो वायरल हो गई है। कितने लाइक्स आ गए? देख देख कितने लाइक्स आए। कमेंट रिपोर्ट, ओ क्या बात है। अरे उसको अब सब पता चल जाएगा। तो क्या पगलापन बढ़ जाएगा और क्या हो जाएगा। सब कहते हैं इग्नोर करो, पर कैसे इग्नोर करूं? जब हर नोटिफिकेशन मुझे याद दिला रहा है कि मैं बेकार हूँ, मैं लूजर हूँ। तू जा, आगे तेरा कुछ नहीं होने वाला है। वैसे भी तेरे मार्क बहुत बेकार है, तुझे तो शर्म आनी चाहिए। लूजर।
हम इस दुनिया में ऑनलाइन ज़िंदगी जी रहे हैं। यहाँ पर शब्द सिर्फ शब्द नहीं रहते, हर शब्द किसी का दिल तोड़ सकता है। कोई एक लाइक, कोई शेयर, कोई मीम किसकी दुनिया उजाड़ सकता है, उसको हताश बना सकता है।
अगर मैं चला जाऊं तो ये सब शोर बंद हो जाए, ये सब शोर चलाना बंद हो जाए। ये दर्द, ये डर, ये ताने, ये तुलना, सब हमेशा के लिए बंद हो जाएगा। मुझे माफ कर देना, मैं तुझको मजबूत नहीं कर पाया।
अरे ये क्या चल रहा है? ना फोन उठा रहे हो, ना मैसेज का जवाब दे रहे हो, क्या कर रहे हो तुम?
कभी मैं थक गया हूँ, मैं थक गया हूँ, वो उसको साबित करते करते थक गया, मैं थक गया हूँ।
इसका तो सॉल्यूशन आ रहे हैं, आप अकेले नहीं हो, चलो मेरे साथ चलो।
अंधेरा चाहे कितना भी गहरा हो, कितना भी गहरा हो, लेकिन किसी का हाथ थामने से शायद कोई रास्ता खुल सकता है। तो ऐसे में हमको मदद देनी चाहिए। हो सकता है कोई नया दरवाज़ा खुल जाए।
क्या हुआ? क्यों इतने परेशान हो?
मैं जिंदगी में कुछ नहीं कर पाया, न पढ़ाई ढंग से कर पाया, न मम्मी पापा खुश कर पाया। उनका तो बस एक ही सपना था कि आगे बढ़ूं, मैं तरक्की करूं, लेकिन वो भी पूरा नहीं कर पाया। मेरे दोस्त मेरा मजाक उड़ा, मैं लूजर हूं, मैं फेलियर हूं, मैं टोटल फेलियर हूं।
ऐसा मत कहो आर्यन, आप जो महसूस कर रहे हो ये कमजोरी नहीं है, शायद आप डिप्रेशन से जा रहे हो। डिप्रेशन एक मानसिक बीमारी है जिसका सही इलाज संभव है।
क्या मैं फिर से मुस्कुरा पाऊंगा?
हाँ बिल्कुल, डिप्रेशन का इलाज संभव है, सही इलाज संभव है। अगर अच्छी मदद, घर वालों का साथ और इलाज अगर मिल जाए आपको, तो आप डिप्रेशन से डेफिनेटली बाहर निकल सकते हो। पॉजिटिव सोचो।
इसका मतलब मैं फिर से अपनी जिंदगी अच्छी तरह से
बिल्कुल बिल्कुल जी पाओगे।
मदद मांगना कमज़ोरी नहीं है। क्या वो कमज़ोरी है? वो एक साहस है, वो एक साहस है। तो अगर आप या आप में से कोई और ऐसा ही कुछ परसीव कर रहा है तो बात करिए, मदद लीजिए। क्योंकि बोलते हैं ना, बाबू मोशाय, हर अंधेरी रात के बाद एक सुबह ज़रूर होती है।
बस इतना याद रखना, हर किसी के जज्बात दिखाई नहीं देते, पर महसूस तो जरूर कर सकते हो।
इस सोशल मीडिया की चमक में हम ये असली मुस्कान भूल रहे थे।
एक हग, एक मैसेज, एक कंधे पे का हाथ किसी की जान बचा सकता है।
आत्महत्या नहीं, आत्मनिर्भरता चुनो।
लाइफ खोना नहीं है, लाइफ चुनना है।
आत्महत्या समाधान नहीं है।
तो ऑनलाइन सहारा मत बनिए, प्लीज टेक केयर, बी वेल, लेकिन एक ऑफलाइन सहारा बनिए।
थैंक यू।
After this superb role play, I invite the session in charge, Dr. Jayant Pandrikar, Chairperson-elect Maharashtra AHA, President MAHA AHP 2021 from Amravati, EB Central AHA 2026, and Chairpersons, Dr. Sushma Kirtani, EB Central IAP 24-25, President IAP Goa State Chapter 2015-16, and Manjusha Sherkar, EB Maharashtra AHA 2026 from Chhatrapati Sambhaji Nagar to conduct the session.
Thank you, Dr. Linesh. Please give a big round of applause for this excellent speech. We all know this is the problem which teens are facing almost in every third home of India. Only thing they are overlooked. So it is time that we as a parents, we must look at them. So these all mental health issues which are very, very important, and we all know the commonest cause of morbidity and mortality in adolescence is the mental health issues. So this session is dedicated to mental health issues. I request Dr. Sushma Kirtani and Dr. Manjusha Sherkar to chair the session. And for this session, the first speaker we have Dr. Nishikant Kotwal from Nagpur. I invite him. He's a chairperson. He was chairperson of Maharashtra AHA in 2024. He's from Nagpur. Please, stage is yours.
जो अपने हम जो बात करते हैं ना, ये दुधारी तलवार रहती है। जब कुछ तलवार से लगता है तो उसको धागे से हम जोड़ सकते हैं, मगर जो शब्दों से होता है वो बहुत डिफिकल्ट होता है, और उसका नतीजा आपने देखा है। Whenever patient comes down, as an adolescent to your chamber, I would request all the PGs to please pay attention to this, because it is very difficult to take history of an adolescent. What is most important is that they don't open up, because they have basically a problem. They don't open up with you. So it is not a very typical thing, आपको क्या हो गया है, बुखार है क्या, कितने दिनों से है, क्या है. It is not important. First few minutes you are going to spend on rapport building with the adolescent, because that is going to open him up, and you are going to get the information why he is depressed, why he has a problem. Okay? So this is a wonderful history taking tool. Normally what we take history is by our Hutchison clinical methods and all, but this is slightly different. So it is an internationally recognized tool, a structured format for history taking, and during history taking only you get an assessment what the patient is suffering from, whether he is suffering from a mental disorder, behavioral problem, or adjustment problem. So we diagnose mental conditions, and here only we try to know whether he should be referred to somebody or you can deal with it. And it can always get good points so that we get guidance on the next sessions of counseling. Adolescents do not like a stereotype of thing. Please come here, sit here, and they would like a doctor to be friendly with him, but not very pally with him. Hi boss, please sit down. Don't do that, because that way they get withdrawn. Instead of that, show respect to them. Let them sit with you. Let them talk with you. They are uncomfortable in formal interview. What do you do? What are your plans? Because that everybody is asking them, whether in the house or whether in the class. We may not get all the information in one go. Like in newborn, many times we find a murmur after 6 weeks because the child is crying. Sometimes we come to know, "Arey, I had missed it. 8 months back se ye aa raha hai patient, but this is this." Because someday you know it. So this is the same thing. And it is essential to get information, but you may not get it in one go. Okay? Communication and rapport building are very much important. जैसे आपने वहाँ देखा है, Chitra, when she came, she talked in a very rude way with the boy, though she knew that the boy is suffering. Right? So, if we are saying, "Acha, kya hua tumhara? Drug lene lag gaye ho?" Even if they have come down for that purpose, you have to create a bond, a rapport, and that is only thing which would make him follow your advice. So do not jump to conclusion or judgmental, क्योंकि कभी कभी बच्चे यहाँ कान में डाल के आते हैं, हाफ पैंट में आएगा, कैसी भी आएगा, unkept में आएगा, but doesn't mean that is his real personality, because adolescents don't try to be judgmental by their appearance. Active listening is very important. Eye contact is very important. Your touch at appropriate time and appropriate places also is very important. Your posture is the key. As an counselor, your posture is the key. If you are relaxed, like, "Acha, kya ho gaya hai?" And then that child doesn't like it, because they want respect. And respect is shown by the posture also. Start with his achievement. This is one thing which has been added into the previous typical history taking that was heads. But unless and until we know his strength, unless and until we appreciate his strength, we cannot go to history taking. And that is why this S has been added, which is achievements, any award, any representation in the school, because all these would give you, supposing he's a sportsman and having representation, and recently he lost a match. So you know his mental condition, okay? And that is the time when you can say you are a very good player, but opponents also were very good. So try to know their weaknesses and likings, or what is he good at. Then in home, just ask, where do you stay? तुझे आई वडील कशी आहे? Directly don't ask them these questions, because direct questions will have only direct reactions which may not be very good. And ultimately in the counseling, you want to see that the whole family is happy and not that he is happy. So who stays in the house? Any ground around, because that way you will know whether he goes to out, whether he has some points where he expresses. Does he have a separate room? Important, because that is many times adolescent want privacy. Who is with him? And the last question is, whom does he call, especially when he has a problem or demands? A friend, mother, or father, or a sister, of course. In education, usually the question will not arise of employment except in street children. Which is your school? What do you like about your school? What you don't like about your school? Whether you particularly don't like a particular teacher, in spite of you getting good marks, whether the teacher expects more, and she always says, "Isse acha karna tha." Sometimes these words, instead of encouraging, can discourage. Is there anything which you don't like? As I said, have you thought about your career options? If he's 15, he may say he has opted, or he may say, my father wants to do it. And that is the point at which you know that he is not comfortable with his father's choice. Do you have apprehension about someone? Does anyone bully you? Okay? Because he may be scared of his father. Father may be beating him because he is not able to perform up to his expectation, and father sees his unfulfilled dreams to come true with this child. Any activities, does he take part in the sports? Then you get a chance to build a connection with him. Are you representing? Oh. And that time you may say that during your time you failed to represent, though you wanted to do it. I mean, that way he will know that he is doing something better than what you thought of. What you would love to do to relax. This is very important, because these are the ways you can, during counseling, they will help you. And do you think any of the activity is socially unacceptable? Because here we are indirectly touching drugs, bullying, sex, or criminal activities. Okay? Do you have any friends? You can't ask him, do you take drugs? He will never say yes. So Dr. R.G. Patil had once said that a child has come down to his clinic and he had cough, but then he could smell. So that time he said, after the interview, whether you smoke, because it could be the reason of your cough, right? Will you like to get some help from us? This is offering help and not asking him to take help. Remember, the adolescents will never like to be ordered. So the options have to come from them. Sex and relationship, you can indirectly ask that in these schools, whether this school is combined or single, whether you have friendships and all, and what are the types of friendships. Do not jump to sexual relationships. Do you have knowledge about boundaries in relationships? This is most important thing you have to ask them. Because, and then gradually you can tell them that in the relationship, a respect of the other person, the safety of the other person is most important in our life. And even if you like somebody, if these two things, if you show, whether it is a boy or a girl these days, then that would be longer lasting.
So last 2 minutes.
Yes. So self-harm, depression and self-image, do you like yourself? What is the point of your body which you don't like? Are you worried about self-image? Because this could be one of the reason of, because somebody may be saying, tu kasa distos, kai nahi hai. As Kinjwadekar said, that he is obese, fine. But don't create a depression in him so that his obesity increases. Do you anytime think of hurting yourself is again indicating to suicide. And do you get thoughts of ending life is a direct question. So the last is safety and abuse. With whom do you feel safe, comfortable, trust? Does anyone's presence makes you apprehensive? Because if you are being bullied, whenever the bully comes, you are withdrawn. So you have to ask him, does anyone put pressure to do things which you don't like? Is there anything wrong or harmful in your life which is happening? Do you express such thing to anybody? And do you have driven a car? Because then you can give at that time only advice. Driving a car at this particular time is illegal. Do you keep yourself safe? So the key points are, is easy way to know the adolescent's personality. And we know SWOT test. So whenever this particular history taking is strength, weakness, opportunities and threat. Once you have that analysis of all these, rest will be very important, very easy for you to do. This document is very important for medical legal purposes. Please remember, you will get complete information in 2 to 3 sittings. Thank you very much.
Thank you so much, respected Kotwal sir, for again having an eye-opener session on head screening, which is the basic but yet important primary tool to screen adolescents, to know their strengths and take a deep dive into their mental health. And as we all know, catch them early and refer them early is the key to adolescent health. And thank you for the excellent session. Thank you, sir.
Well, may I now request Dr. Shami Ghosh, our next speaker. Shami Ghosh is a Secretary of Central AHA, is from Kolkata.
A very good morning, and thank you to this august audience for having come on a Sunday morning to listen to all of us. A very, very warm thank you to Maharashtra Adolescent Health Academy, IIP Raigad, Dr. Chitra Kulkarni, Dr. Jayant Pandrikar, Dr. Vaishali, Dr. Neha Singh, and the rest of the team who have given us a fantastic hospitality ever since we've set foot here. So my topic today is part of our parenting. What is the purpose of bringing up our children? We are going to bring up children as historically demanded so that when we are not there, they should be able to survive independently. So it's not about khila pila ke bada karna hai. We have to also equip them with certain skills which will help them negotiate life. So why focus on adolescence? So bachcha janam leta hai, it's a completely dependent individual. We have to take them to their destination of becoming a able-bodied and mentally independent individual. Beach ka rasta is adolescence. There is change. There is rapid physical, emotional, and social change. The person has to break out of his shell, become independent, faced with a situation, be able to make decisions. He has to negotiate academic pressures. He has to integrate himself as part of society. And an added challenge in the modern day world, which we cannot shy away from, is the digital pressures. So, all in all, these life skills are here to help this adolescent successfully navigate life. And we as parents, we nearly are tackling 21% of our population to become successful adults. So WHO has defined them in a very, very, what should I say, utopian manner, that we have to teach them adaptive and positive behavior, which will help them to deal effectively with their day-to-day lives. The benefits are obviously the body doesn't exist without the mind. Unless and until your mind is controlling every aspect of your bodily functioning, you cannot function well. Nobody lives in splendid isolation. We have to nurture our relationships, whether it is within our family, within our community, or in society at large. We have to develop the necessary skills that should there be pitfalls, we may fall down, but we should be able to arise, awake, and develop resilience. And whatever decisions we take, not only should they be aimed at self-preservation, but for the larger good of humanity. And we should be responsible decision makers. So the top 10 core life skills recommended by WHO, a lot of you must have seen this slide in a lot of presentations. I'm not going to be reading out each one of them, but I will be enumerating the more important ones. So, दिमाग भेजा नहीं बनाना है, फ्राई नहीं करना है, उसको utilize करनी है. We have to develop our thinking skills. They should help us make good decisions, not stay somewhere in between. They should help us tackle a problem to be solved. They should help us in our improved cognitive abilities and help us in creative and critical thinking. And all of this comes into play when we are bombarded with information on the social media. Socially, like we said, nobody lives in splendid isolation. हमें एक दूसरे से बात करनी है. We should know how to talk. Not everybody is same. I may talk to you in one manner. I may talk to my seniors in another manner. But effectively, I have to communicate what I need to communicate. And we are not here to pity each other. We are here to understand that today, the situation in which my friend is, I can be in the same situation. Put myself in the other person's shoes and then try and talk to him. And that is called empathy. Emotional skills. Now, we always say that there is a time when parenting is a monologue. And as adolescence knocks on the door, it becomes more of a dialogue. Why? Because this little one has started developing emotions, and we have to teach them to be aware of themselves as human beings. We have to teach them that whatever temptations that they may encounter, how they're supposed to be coping with them. They might fall prey. They might become vulnerable, but let them audit themselves. Let them learn through their own experiences. Stress. You must have heard the terms excessive stress. You must have heard the term eustress. An optimum amount of stress is possibly necessary for all of us to perform. Me getting up on this stage, if I'm not focused on what I'm going to deliver, I will just be delivering something well below my potential. My very good friend Sameer Bhai is here. So, life skills in the digital age. This digital age has given us a lot. It is not something which we can really crib about. Today, what I'm speaking here is also available to someone who is sitting in some remote corner of the world. It has connected us, and yet this connectivity has its flip side. It can create pressures. It can cause cyberbullying. If there is a lack of human engagement, हम आपसे बात नहीं कर रहे हैं, मैं अकेले बैठा हुआ हूँ. What is available in front of me? It is my phone, as we saw in the skit, and this can lead to a lot of addictions. We are also talking about lack of thinking skills, and that can spread misinformation. As we have seen, it has led to riots. It has led to wrong information being spread. It has led to public health disasters. It has led to issues where vaccination campaigns have not been followed. So we need to develop these life skills at an individual level, because charity begins at home. Thank you. So how can we promote the life skills? There are three of us who are sitting on a pedestal. Parents, listen, listen, listen before you start speaking. Teachers, be interactive. Don't give sage advice. And health professionals, when we talk about counseling, please remember the word motivational counseling. It is a partnership. It is a partnership where the solution will come from the subject rather than yourself. And that is how you mentor who has come to you. Many practical activities can be done. Family discussions, student councils, community service, sports and team activities, debates and public speaking, journaling and reflection. Part of it is today, wherein we are spreading this awareness as to how to navigate life. So the key take-home messages are, they are teachable. They are learnable. You learn by mistakes also. Do not have this impression, kuch sikha denge, and my child is going to learn it the next day. Make sure whatever you do, you are not judgmental and you are not condemning the person, but you are trying to improve their mental health and their resilience. Encouragement. Kuch bhi acha kare. Whatever be the potential of the child, the person, all of us here, thoda award mil jaye, koi acha bol de, we are all very, very encouraged. And every adolescent, he deserves not one, two, three, but endless opportunities to develop. Thank you so much for your patience, and hope we are all helpful to our adolescents.
Thank you, Dr. Samik Ghosh, for this lovely presentation. To summarize it, we need to build confidence, we need to build competence and the character in our children. The adolescents are prone for, because the rapid growth, adolescents, they have rapid physical, mental and social growth, and parents, we have to develop, as a parent, develop the skills and make them independent to face the life. And this is the theme beyond this. WHO's 10 life skills were described well, sir, by you. And because of lack of time, maybe some examples could have been shared. Stories from Panchatantra and all are very good, which is actually showing them, teaching them. So most importantly, thinking skills, social skills, emotional skills are very important, and life skill in the present digital age to understand the pressure from the social media. This is important, and that is why this topic was very important for us to also learn social skills and teach our adolescents. Thank you so much, sir.
Well, life skills is the only modality of prevention and treatment the psychosocial diseases in the adolescents. Now, coming to last topic of this mental health issues, may I invite Dr. R.G. Patil from Nagpur, and he's going to discuss about the adolescent depression. Dr. R.G. Patil, please.
A very good morning. First of all, I would like to thank the organizing committee members of the IIP Raigad branch and the IIP Adolescent Health branch. Especially I thanks Dr. Chitra Kulkarni, chairperson, for inviting me to discuss this topic in detail. So this is very important topics, and it will take much more time, but I will try my level best to cover within 10 minutes. So what is a depression? Depression is a mental health disorder which consists of persistent low mood, loss of interest, loss of pressure, fatigue, poor concentration, sleep disturbance, and sometimes they feel suicidal tendency. And if it persists more than 2 weeks or 2 weeks, and it interferes, mind well, this is which interferes with daily lives like schools and relationships. So why it is important in adolescent to know the depressions? First of all of you know this constitutes about the 22% adolescent population, they constitute about 22%, and it is an economical and geographical force. Most of the adolescents during adolescence, there are hormonal changes they are taking place. If you don't treat them earlier, then it may lead to complications like substance abuse, smoking, and other. And even they cause pressure on the family if that adolescent is suffering from depressions. So, what is the prevalence of depression in India? One is, it may not be fit into one group, but there are multiple factors like study settings. Which study they are conducting, like it's a school health program or some community-based program or self-study. Screening tools, which screening tools they are using. Already in yesterday's workshop, it was discussed by Dr. Shubhda Khirwadkar madam. They have very nicely conducted yesterday's program, Dr. Abhijit and other team. Then it varies regarding the urban and rural population. The prevalence of depression differs from urban and rural population, and what is the age group? Most of the adolescent age group, in late adolescent, the incidence of depression is much more, and socio-economic groups, from which the adolescent is brought up from the social economic groups, whether it has been seen that the prevalence of depression is very high in the low socio-economic group because of the economical conditions. Now, this is the estimation, like 10 to 25%. Average of adolescent, there is a figure like 18 to 20%. 1 in 5 adolescents in India, they are depressed. This is the very higher in prevalence in females. School-based studies shows that urban versus school, 20 to 30%, and rural schools is 10 to 20%. So this is the age-wise criteria. It has been seen that earlier the age, the prevalence of depression is very less. If you go late adolescent, the depression is much more. So what are the causes of depression in adolescents? They are like genetics. And most important is family, environmental factors you must be knowing. If the family there is a discord in the family, parental pressure, parental conflicts, substance abuse, bereavement, sexual abuse, or some understanding in between the families. If the family member is suffering from the chronic illnesses like diabetes, hypertension, autoimmune arthritis, stress, either it may be intrinsic or external factors, gender and hormonal, and others like sexual abuse or parental pressures. So, these are the clinical features of the depressed adolescents. Like he feels like a low mood, or he is irritated, he is not showing interest, there is loss of appetite or gain in the weight, worthlessness, thoughts of private suicides, missing from home without information, scholastic performance, they are decline or absenteeism, or social isolation and poor concentration. These are the clinical features. So there is a key difference between the adult depression and adolescent depression. One is that there is instead of sadness, there is a irritation, then decline in the school performance, and there is a what you call psychosomatic problems like headache and stomachache. So, as such, there is no investigations like blood investigation where we can diagnose depression. So, we'll have to ask detailed history, PHQ to PHQ. I know Dr. Preeti Galgali, when she was a chairperson, she has conducted a very nice program how to identify the depressed or anxiety children in the school. Madam is there. So I know Nagpur was the first school which conducted the program, like screening tools. We'll have to identify in the school only, then we'll have to report to the headmaster, then we'll have to report the health professional. It was a good module that we have prepared, even Dr. Geeta Patil, Himabindu madam was there. So we conducted such program. We have screened the adolescents who are suffering from the depression. So most important is there are other screening tools like feeling mood and emotions, or other like children depression therapy, Center for Epidemiology Survey, then Reynolds depression therapy, coaches depression therapy. But by this history, we can go by the detailed history and PHQ2 and PHQ9. Already it has been discussed yesterday how to go for this study, and you can go through the digital media to know this PHQ2 and PHQ9. So DSM-5, if there are symptoms more than 5 in the DSM-5 criteria, then we can diagnose depressions. Now these are some points like depressed mood indicated subjective report, or observation by others, loss of interest, significant loss of interest, or loss of weight, sleep disturbances, psychometric changes, tiredness, essence of worthlessness, impaired ability to think, recurrent thoughts of death, that is very important, and suicidal tendencies. So, as a pediatrician or a professional, you should be alert when to refer these patients. When the adolescent were showing the suicidal tendencies or suicidal ideation, psychosomatic problems, no parental support, or if there is a scholastic decline or substance abuse. So it is better to refer this patient to the professionals. These are the red flag signs for the depressions. Now, instead of treating the patients of depression, we will have to conduct the preventive strategies. Like already discussed by Dr. Shamik Ghosh, there should be a family support, that is very important. Communication, positive parenting, life skill training. We should treat the adolescent, life skills training, like how to cope up with the stress, strain, emotional, interpersonal relationship, and others. Mental health problem. It's a raw area.
Sir, last 2 minutes for you.
Okay, we don't discuss the mental health problem, stress management, and healthy social media use. Now, treatment is detailed history, cognitive behavioral therapy, IPT, and pharmacotherapy. Pharmacotherapy drugs we are using fluoxetine and others. So this is a very applicable for the adolescents, to some extent to all of us also. Identify when the suffering becomes a pattern. When you replace why this is happening to me with what is this trying to teach me, everything shifts. This makes the change, the shift from victim to seeker. Thank you. So I want to discuss whenever you are treating these patients of depressions, mild or moderate, it is better to keep the follow-up this patient because we want to rule out what are the, is there any drug reactions, how is improving. You will have to contact the school also, the parents also, then only the treatment becomes successful. Thank you.
Thank you, Dr. Patil, for this lovely and short presentation. Although this topic is vast, it is very difficult to finish in 10 minutes. Actually, the adolescent prevalence of adolescent depression is 10 to 25%. Higher the age, in late adolescence, it is higher. And most important, the difference between the adolescent depression and the adult depression is irritability, psychosomatic symptoms, decreased school performance are the presenting features. PHQ-2 and PHQ-9 are the two screening tests which are very, if the PHQ-2 is positive, then you go to the PHQ-9. This is very good. Red flag signs like suicidal ideation and tendencies has to be looked at. And the preventive strategies of correcting their stress or life skill education, which Dr. Shamik already told, management of the stress and parental involvement is also very important to manage this. Thank you very much.
Thank you, sir. MKC sir always used to say, तुम इतना जो मुस्कुरा रही हो, क्या गम है जितको छुपा रही हो. Actually, इधर हंसने वाला बच्चा, stable बच्चा, his mind is really stable. So your lecture was really eye-opener, sir. Thank you so much.
Well, we come to the end of this session on mental health, and I must thank first of all the actors of the skit, and I must thank all the speakers, Dr. Nishikant Kotwal sir, Dr. R.G. Patil sir, and Dr. Shamik Pai. At the same time, I thank our chairpersons also, and now I hand over mic to the MOCs. Thank you very much.
Thank you. Now I request all respected faculties, session in charge, chairpersons and members of role play to proceed outside for felicitation. There are a few announcements here. I request all to sign the attendance sheet carefully. Please check your details. MMC number, WhatsApp number, email address. It is important because we will be emailing the e-certificate. No hard copy will be given. Posters have been displayed outside the hall. Dr. Kamlakar Devghare sir is the judge, and lunch time is 12 to 2:30. There will be no separate lunch break. Now I hand over mic to Dr. Shantala to conduct the next session. I revise, lunch time is 1 to 2:30. Sorry, 3:30.
Good afternoon, everyone. I invite the performers of the skit Man Sairat Logic Chivat to please proceed onto the stage. The director is Dr. Shruti Kalkekar, scriptwriter is Dr. Kalyani Patra. The ensemble includes Dr. Samok Shahane, Kalyani Patra, Rajul Patel, and Shruti Kalkekar. Again, a kind request not to record the skits and the role plays.
Good morning, everyone. We are delighted to present our role play. Good morning, everyone. We are delighted to present our role play, Man Sairat Logic Chivat. The play is directed by Dr. Shruti Kalkekar. Script is written by Dr. Kalyani Patra and will be narrated by me, Dr. Asmita Patil. तो आइए देखते हैं मन सैराट लॉजिक चिवाट. एक इंग्लिश मीडियम स्कूल और क्लास 7 के बच्चे. व्हाट्सएप ग्रुप, इंस्टा अकाउंट्स तो है ही, लेकिन एक सवाल आजकल बहुत कॉमन है. तेरा अभी तक कोई बॉयफ्रेंड नहीं है? ये कहानी है 12 साल के आरोही की। घर में प्यार तो बहुत था, लेकिन एक बात वो 6 महीने तक छुपाती रही। और ये कहानी सिर्फ आरोही की नहीं है, ये कहानी हर उस घर की है जहाँ पे इमोशनल सेफ्टी कम है।
गाइस देखो, आदित्य ने सिमरन को प्रपोज किया, रील भी डाली।
वाओ
वाओ कूल यार। ए आरोही, तेरा कोई है?
नहीं यार, अभी तक तो नहीं।
सीरियसली? क्लास 7 में भी नो बॉयफ्रेंड?
रोहन तुझे पसंद करता है।
हाँ पता है। देख, सबका कोई ना कोई है। अगर ग्रुप में तुझे रहना है तो थोड़ा सोशली नॉर्मल लगना पड़ेगा।
ठीक है, मैं बात कर लूंगी उससे।
आरोही, तूने मन से बोला या प्रेशर में बोला?
उस रात एक हाय आया, फिर चैट शुरू हुई, होमवर्क शेयरिंग, लेट नाइट मैसेजेस, और धीरे धीरे आरोही को पता ही नहीं चला कि वो रिलेशनशिप में आ गई थी। एंड देन 6 months passed. Scene now shifts to Sharma's house. When Arohi's mother sees Arohi's phone, reads the messages, gets concerned and shows these messages to her husband. The role of Rajesh, father, is played by Dr. Rajul, and role of mother, Meena, is played by Dr. Shruti.
ये सब कब से चल रहा है?
स्क्रॉल ऊपर करो, 6 महीने से।
ये रोहन कौन है?
ओह माय गॉड, पापा वो
ये
तो
मिस यू, कांट वेट टू सी यू। ये क्या है?
मुझे डर लग रहा था पापा।
ये क्या है? हमने क्या कमी रखी थी? तुमको सब कुछ दिया, बट तुम पे ट्रस्ट भी किया, और उसका मतलब ये?
और मुझे लगता था मेरी बेटी मुझे सब शेयर करती है। मुझे लगा आप दोनों मुझे अलग नजरों से देखोगे।
बट तुम हमसे क्यों डर रही थी?
राजेश, मुझे लगता है अपनी बेटी हमसे डर रही है।
दिस इज टू मच।
कल एक एडोलसेंट स्पेशलिस्ट है डॉक्टर अनन्या,
लेट्स सी,
उनसे मिलते हैं।
ठीक है, लेट्स सी।
फिर जमती है डॉक्टर के महफिल। नेक्स्ट डे द शर्मा फैमिली मीट्स एडोलेसेंट एक्सपर्ट डॉक्टर अनन्या. The role is played by Dr. Kalyani. Let us see how the first session goes.
डॉक्टर, उसे समझा दीजिए।
बस बोल दीजिए, ये एज नहीं है।
एक मिनट, आप पहले शांत हो जाइए। आज हम किसकी क्या गलती है से नहीं, किसने क्या फील किया से स्टार्ट करेंगे। आरोही, आप मुझे पहले से बताओ।
वो क्या था ना, स्कूल में टीज करते थे, सिंगल है तो बोरिंग है, तो मुझे लगा मैं नहीं सुनूंगी तो मुझे ग्रुप से निकाल देंगे।
और रोहन?
रोहन पहले तो अच्छा लगता था, लेकिन बाद में मुझे बहुत अनकंफर्टेबल फील हो रहा था।
कभी मम्मी पापा को बताने का मन किया?
हाँ, बहुत बार, लेकिन मुझे डर लगता था पापा गुस्सा करेंगे, मम्मी हर्ट हो जाएगी।
देखिए मिस्टर एंड मिसेस शर्मा, आरोही ने सिर्फ रिलेशनशिप नहीं छुपाया, उसने अपना फियर, अपना कन्फ्यूजन छुपाया। और जब बच्चे कन्फ्यूजन लेके घर नहीं आ पाते तो वो अकेले डिसीजन लेते हैं, जो बहुत बार रिस्की होता है।
पर डॉक्टर, 12 साल की उम्र में रिलेशनशिप, टू मच।
देखिए, क्यूरियोसिटी, अटैचमेंट इस एज के लिए अनकॉमन नहीं है। फीलिंग्स नॉर्मल हो सकती हैं, लेकिन प्रॉब्लम कन्फ्यूजन और प्रेशर है।
मुझे लगता है हम फेल हो गए।
नहीं, आप फेल नहीं हुए, आप बस वरीड पेरेंट हो। और इस मोमेंट पे हमें पनिशमेंट से ज़्यादा अंडरस्टैंडिंग ज़रूरी है। और मैं आरोही से कुछ देर अकेले में बात करना चाहूँगी।
ओके।
आरोही बेटा, यहाँ पे आप सेफ हो, मैं आपको जज नहीं करूँगी।
मुझे तो बहुत सैड फील हो रहा है डॉक्टर।
आई कैन अंडरस्टैंड, बट कुछ इम्पॉर्टेंट सवाल है। किसी ने आपको फोर्स किया, किसी ने आपको अनकंफर्टेबल टच किया, प्राइवेट फोटोज मांगे या थ्रेटन किया?
नहीं डॉक्टर।
थैंक यू फॉर शेयरिंग दैट। अब मुझे बताओ, आपको ग्रुप से बाहर होने का डर ज़्यादा था या रोहन पसंद था?
मुझे तो अकेले पढ़ने का डर था।
समझ सकती हूँ, इस एज में बहुत बार स्पेशल फील होना, ये फीलिंग उस पर्सन से ज़्यादा अच्छी लगती है। और इसी वजह से आपकी जो इमोशनल डेवलपमेंट है वो बस लर्निंग फेज में है और इमोशंस बहुत इंटेंस लगते हैं, है ना, और एक्साइटमेंट के साथ साथ एंग्जाइटी और प्रेशर आ जाता है।
हाँ, मुझे बहुत प्रेशर फील होता था कि ये ऑनलाइन क्यों नहीं है, ये मैसेज को रिप्लाई क्यों नहीं कर रहा है।
एग्जैक्टली और इसी वजह से आपको सपोर्ट की ज़रूरत है। आज के सेशन में हमने आपको ये फील कराया कि आप अकेले नहीं हो।
थैंक यू डॉक्टर।
पेरेंट्स रीजॉइन फॉर द काउंसलिंग।
आइए मिस्टर मिसेस शर्मा, बच्चे बहुत बार गलत इंटेंशन से नहीं बट इमोशनल ओवरवेल्म होके डिसीजन लेते हैं और आरोही के साथ वही हुआ।
और हमें लगा वो हमसे दूर हो रही है।
समझ सकती हूँ, लेकिन एडोलेसेंस करेक्शन से ज़्यादा कनेक्शन में बिलीव करते हैं और आज हमने सिर्फ तूफान शांत किया है। अगले सेशन में हम फीलिंग्स और बाउंड्रीज की बात करेंगे।
ओके डॉक्टर, थैंक यू।
आज के सेशन में आरोही के मन की बात तो जान ली, पेरेंट्स को काम डाउन भी किया,
पिक्चर बाकी है,
लेकिन नेक्स्ट सेशन में हम समझेंगे कि पेरेंट्स को हाउ डू दे अंडरस्टैंड रिलेशनशिप। लेट अस मूव टू डे 2 ऑफ काउंसलिंग।
हेलो आरोही, हाउ आर यू फीलिंग नाउ?
हाय डॉक्टर, मच बेटर।
दैट्स ग्रेट। आज हम रिलेशनशिप की और बाउंड्रीज की बात करेंगे। फीलिंग्स गलत नहीं होते, लेकिन फीलिंग्स को हैंडल करना सीखना ज़रूरी है। और हेल्दी रिलेशनशिप में कांस्टेंट फियर नहीं होता। जिंदगी सिर्फ एक इंसान के अराउंड नहीं घूमती। स्कूल, स्टडीज, स्लीप, फैमिली, ये सब ज़रूरी होता है।
हाँ, मेरे स्टडीज़ भी अफेक्ट होने लगे तो अभी तो।
राइट और जब कांस्टेंट एंग्जाइटी हो किसी रिलेशनशिप में, उसका मतलब वो हेल्दी नहीं है।
तो मूवीज़ जैसे नहीं होते रिलेशनशिप्स?
मोस्टली मूवीज जैसे नहीं होते। और रियल फ्रेंडशिप कभी तुम्हारा टेस्ट नहीं लेते, प्रेशर नहीं क्रिएट करते।
हाँ, काव्या ने भी मुझे फोर्स तो नहीं किया था।
एग्जैक्टली क्योंकि सेफ फ्रेंड्स तुम्हें डिसीजन लेने की चॉइस देते हैं, है ना। और ऑनलाइन रिलेशनशिप में तो और चैलेंजेस है। आपको लगता है कि हमारे चैट्स प्राइवेट है, लेकिन स्क्रीनशॉट परमानेंट हो सकते हैं। तुम्हारे प्राइवेट फोटोज, इंफॉर्मेशन, पासवर्ड, ये सब शेयर करते टाइम बहुत केयरफुल होना पड़ता है। इसीलिए जब भी कभी भी तुम अनकंफर्टेबल फील करो, ज़रूरी है तुम पेरेंट्स की या ट्रस्टेड अडल्ट्स की हेल्प लो।
थैंक यू सो मच डॉक्टर।
मिस्टर मिसेस शर्मा, मैं आपसे सिर्फ 3 चीज़ें कहूँगी। फर्स्ट एंड फॉरमोस्ट, जब भी बच्चा कोई डिफ़िकल्ट बात करे, पहले सिर्फ सुनिए, लेक्चर मत दीजिए। सेकंड, तुमने ऐसा क्यों किया की जगह आप क्या फील कर रहे थे, आपके दिमाग में क्या चल रहा था, ये पूछिए। और तीसरा, हर हफ्ते 20 मिनट नॉन जजमेंटल कन्वर्सेशन टाइम, बिना फ़ोन, बिना टीवी। और आरोही बेटा, नेक्स्ट टाइम अगर आप कंफ्यूज हो तो पेरेंट्स की या किसी ट्रस्टेड अडल्ट की हेल्प ज़रूर लेना, क्योंकि हेल्प मांगना स्ट्रेंथ है, वीकनेस नहीं।
थैंक यू सो मच डॉक्टर। सॉरी पापा, सॉरी मामा। आगे से मैं रोहन के बारे में आपसे डिस्कस करूंगी।
सो नेक्स्ट टाइम डर लगे तो बेटा हमारे पास ही आना।
और हम भी तो सीख ही रहे ना बेटा।
Dear colleagues, this story is not about bad children, it is about developmental vulnerability. Between ages 11 and 14, peer approval becomes emotionally powerful.
Our role is not to shame curiosity, but our role is create emotional safety, teach healthy relationship skills, strengthen communication, identify distress early, and guide families before crisis develops.
रिलेशनशिप स्किल्स भी सीखे जाते हैं, जैसे रिस्पेक्ट, बाउंड्रीज, सेल्फ वर्थ, इमोशनल रेगुलेशन। ये एक एडोलेसेंट को हेल्दी रिलेशनशिप्स कैसे डेवलप करना, ये सिखाते हैं।
और ओपन पेरेंटिंग ये नहीं है कि आप कहो कि हम बच्चे की सुनते हैं। ओपन पेरेंटिंग ये है कि बच्चा इमोशनली क्या एक्सपीरियंस करता है। और बहुत बार एडोलेसेंट हेल्थ का सबसे पावरफुल प्रिस्क्रिप्शन एक नॉन जजमेंटल कन्वर्सेशन हो सकता है।
प्रेम हो या प्रेशर,
हमेशा लॉजिक की बात करो।
थैंक यू।
Wonderful, ladies. I got a call from Aditya Dhar looking for Durandar 3 cast, and I think we have all of them here. I now invite session in charge Dr. Kalyani Patra, Chairperson AHA Navi Mumbai, and Chairpersons Dr. Ram Bharat, Treasurer MAHA AHA 2027 from Chandrapur, and Dr. Ujjwala Gavli, Associate Professor, Bharati Vidyapeeth Medical College, Sangli.
Thank you, ma'am. As we have witnessed in this role play, that relationship have deep influence on adolescents' emotional world. From breakups, rejection, betrayal, they can leave emotional scars to them. Also, there is increasing trend of risky sexual behaviors. So to address this important but sensitive issue, I invite our first expert from Hyderabad, Dr. Hima Bindu Singh. Ma'am is past chairperson Central AHA. Welcome, ma'am.
Very good morning. Thank the IAP Raigad and AHA Raigad and MAHA AHA chapter to inaugurate this conference at such a wonderful place. Thank you, Chitra. Thank you, everybody. Yeah, our Central AHA team is also here. And the topic is very, very interesting, right? We just seen the role play, relationships. We all love to be in relationships, yes or no? Yes, right? Is it at any age? Yes. Adolescence का ज़्यादा risk होता है, you मानते हैं कि नहीं? Yes. And we all know, as we are all, I think, sitting here, we're all doing adolescent counseling, adolescent work for since long time. So we understand they are at more risk. So it's a risky business. I don't know who coined this term. You know, risky business. Yes, I completely agree. Can I have these pointers? Yeah. So, I mean, talking in 10 minutes about this risky business is a little bit risky, but then I will try. You know, we don't have this mic chahiye, cordless. So, risky sexual, we are understanding the risk, consequences, and prevention. Yeah. So, just to introduce quickly, we all know that's a transition stage, and now pre-teens are Sushma ji ka favorite topic. So it's not just 10 years, from maybe 7, 8 years, we all know puberty triggers in. And 8 saal se shuru karna hai. Ya pehle I should say sexuality talk should start maybe at 3 years also. We all know as pediatricians, good touch, bad touch, parts of the body, ये सब तो सिखाते हैं. तो उसी में धीरे-धीरे से I think we should not get into that. I'm going to do a sexuality counseling or talk immediately at 10 or 8 years. So pehle se, you know, becoming little open communication, talking about parts of the body, these things we can somehow we can introduce the topic quite early. But this phase is very, very challenging, but it's also important. We want to make them, at least we have to keep them safe. And we all understand there are a lot of changes during this time. They're physically growing before they're mentally maturing. That is the more risk. Physical growth ho gaya. Their menses start ho jate hain. The boys also having ejaculations. So they are sperms, they are ovulating, but we never tell them, you know, how to keep themselves safe. Prevent pregnancy. We all know the risk. But we never talk about this. Pediatricians are very comfortable taking height and weights. Next, immunization. Nutrition talk bhi subah se sun rahe, we are comfortable. But are we comfortable talking about, you know, the other aspects of life which are very, very important, especially at this age? So we should come out of it now. Now, we pediatricians should feel, we need to be first comfortable talking about the sexual development, how the adolescent should handle. We all know about the hormones. They are kicking in, yeah, they are not, you know, what they can do. हम उनको बोलते हैं ये नहीं करना है, इस एज में ये पढ़ाई का एज है, ये मत करो, ये क्या कर रही हो, distractions are happening. They are, the estrogens, testosterone is kicking, hormonal dance ho raha hai, you know. And then we tell them, the attractions happen. I'm sure, please remember your own teenage. You know what happened with your age. Didn't you get attracted to anybody? Yes? Upen first admitted, thank you, to be honest. Huh? You know, and we still get it even now. But then maybe at that age, it is, we have these crushes, we have the relationship issues, so nothing, we should not be judgmental. First, accept it is normal development of that child. Rapid development is happening. The secondary sexual characters are developing, breast enlargement, all this is happening. They're looking a little bit different, more attractive, sexually attractive. And the boys also, emissions, and they don't know how to handle all these changes. We never talk to them about these changes. Emotional, things are happening, sexual urges are happening. But the risk is these 5 things. I'm just going to highlight only these 5. Unwanted, unprotected physical intimacy can lead to a lot of things. One of is sexually transmitted infections. We pediatricians, did we ever talk about this topic? STIs? वो खाली gynecologist बात करती हैं या कोई और? But हम लोग क्यों नहीं बात करते हैं? Don't you know that your own children, now we have all promised, IAP promised long back in 2000 कि हम 19 years तक देखभाल करेंगे. फिर अभी 20 साल हो गया है. अभी pediatricians still we are not comfortable. IAP has given a commitment for adults and health long back. And even now, 20 years have gone, still we never speak about STIs. Don't you know that we all accept and realize they are very sexually active. It's not 10 or 20%, we don't have a proper data. It's increasing also with the social media exposure, parents are not yet ready to talk, teachers are not yet completely empowered. Where are they getting this knowledge? But we are leaving this area. Pediatricians, please, I request all of us to start talking about sexuality, the STIs, unwanted pregnancies. I think most of us running some centers. I was running a Yuva center at Nilofer Hospital. I saw 12, 13 years, many of them getting pregnant, unwanted, they don't know. Actually, when we go a little probe, bolte hain ki, I didn't know that ye physical intimacy, this is called intercourse, and they don't know that intercourse will lead to pregnancy. Then we start smiling and laughing. अरे बड़े smart हैं, क्या नहीं पता उनको automatic सब कुछ पता होता है, क्या बोलना है इस उम्र में? Many of the parents also feel कि क्या बोलना, हम तो हमारे ज़माने में तो ऐसे ही सीख लिए, या ऐसे कैसे पता है? Only flowers were touching, birds were, these are the movies that time, but now the movies are very aggressive and pornographic also, I should say. So then, you see the last, that was very melodious and those type. But अभी तो कितना exposure हो रहा है? Just there's nothing related to emotions, just sex. And these things, when these are there, they get attracted, they want to explore. Unwanted pregnancies are increasing. Why? This is preventable. Is it not? Yes or no? ये तो बिल्कुल preventable है. Just थोड़ा educate करो, थोड़ा बता दो कि भाई पहले तो abstinence ही बोलो, अगर नहीं हो सकता है, because they never plan, कभी-कभी ऐसे ही हो जाता है, and accidentally. At least safety, protection के बारे में बात करो. Why are we still conservative? I think it's been 20 years. We have to break this. I know there were a lot of resistance to talk about these topics in schools and colleges, but now I think they're a little open. So let us take the opportunity to talk about all this. Cyberbullying, online grooming, blackmailing, other things are happening. Online sexual activity is also happening. Abuse is happening, we have seen still. Though we talk about gender equality and all those things, but 4 or 5 boys coming and overpowering physically a girl, this is quite common still. Why are we not rearing our boys properly? कि आपको ये sex क्या मजा मिल रहा है? Just in 2-3 minutes by force, and even killing the child. Is it a pleasurable activity? Should be, or giving-taking relationship जो अभी बताए हैं? What is the, why are we going to physical intimacy? What is the boundaries, or what these things? How to respect? At least first human being तो है. Forget about girl and boy. पहले तो first is she or he is another human being. Didn't we teach them कि take consent before touching anybody? Or we say, Indian culture में तो taking consent was पहले से था, फिर कहाँ गायब हो गया? When we do the sexual activity and rapes, क्यों boys को हम नहीं बोलते हैं, girls को हम बोलते हैं खाली अम्पायर करो, बचाओ बेटी पढ़ाओ? But Naval Kishore was my, during my tenure as a CHA chairperson, I did push that, and I think it's very important to groom our boys. Then mental health issues, yes, it is related. There are rapes, there are suppose it sometimes happens, all this thing, they feel guilty. Our guilt say, sometimes in some of the conservative families, they say कि बस हमारा वो क्या चल गया, घर का, इज्जत चल गई, and I can't face the society. There's so much of mental pressure on the child, and they may commit suicide. They do commit suicides to just run away and escape. So these things, depression, shame, and suicidal tendencies are very common. These are the risk factors with the risky business. Now, core components, yes, we have to handle these core components. As adolescent experts, advocates, I should say, unprotected sex, इसके बारे में ज़रूर बात करना है. Sexual activity हम नहीं promote कर रहे हैं, but we have to talk about, taking safety precautions and with consent, all those things. Then consistent lack of condom, they don't know how to use condoms also. कहाँ मिलता है? They feel shy to even take it and purchase it. And even for the girls, it's not only for the boys, there are barriers for the girls also. The girl should be empowered. She should not leave all this safety thing only on the boy. It's her body. It is her right to be safe. So we have to talk about all these things, and we have to talk that, you have to prevent the STIs, which is preventable. And multiple partners, you never know. It's not that they only have one. It's very, very common now, just talk to any adolescent boy and girl, they're just moving on. It is, I've just spoken to the schools, colleges. I'm also in a medical college as a administrator. It is okay for them nowadays to have 1, 2, 3, 4 partners, and they move on. It हमारे जैसे पुराने ज़माने के नहीं है to hang on to one person for lifelong, So that is a trending, you cannot be judgmental here. What is right and wrong? It requires a big debate. Now engaging with these partners, it is, we need to talk about that also. And what are the problems? And early sexual abuse happening. They want to just explore. इनको सब कुछ हम पहले से suppress करते हैं, ये मत करो, वो मत करो. Table के नीचे क्या है, वही जानना चाहते हैं. This is a child behavior. Curiosity is part of our children. वो part of development है. So they want to explore. अगर जितना मना करेंगे, उतना वो explore करने की उनकी चाहत रहेगी. So it is better to be open and talk about it. Initiating at a young age can often lead to a lot of problems. And as we said, yes, they are very inconsistent also. In case we even tell them protection के बारे में, they cannot be, consistent रहना उनको मुश्किल हो जाता है. Infertility, बाद में long-term risk भी बताना है about PIDs and all that. Now, then added problem is their substance. And we know about date rapes, drinks, parties. And whenever they are under substance abuse, they may lose even that little judgmental capacity they have. We all understand they do not have the judgmental, the frontal, prefrontal is not yet completely mature. So वो नहीं decide कर सकते what is right and wrong and all those things. Judgmental issues are there. और भी impair हो जाता है when they are under substance influence. Alcohol, recreational drugs, was so common. देखा ना party में not just cake and those junk foods. It's always with drinks. And even girls, please don't be judgmental कि खाली boys drink करते हैं. आजकल सब कुछ common है, vaping, alcohol, nothing, no gender discrimination there. Everybody is drinking. Then there's a reduced inhibition with these drugs. We all understand, and they can be under some influence, and they can be raped. Anything can happen. So this also we have to keep in mind. Coming to this STIs, it is not just infection. I have to talk HIV/AIDS. So we all know there's a documentation at least. I should thank this program. At least because of HIV/AIDS program, हमने openly sexuality के बारे में अंदर we have just gone in. Otherwise, it was very difficult in India. And we all know about HPV and other things, but in बच्चों को ये बताना है, STIs कैसे होता है, what are the common STIs, chlamydia, all those things, and how to protect. So we have to tell them about protection, as I said, and early detection and treatment. Yeah? Then unwanted pregnancy, इसके बारे में, we have to talk to them how prevalent it is and what they can do. They can actually, when the parents come again, somebody said, yes, safe space is a house. But वो parents के साथ बातें नहीं साथ मैं pregnant हो गई, क्या करेंगे, एक चाटा मारेंगे, तो फिर क्या करें, then why, again they go for abortions, throwing away the child here and there, कभी-कभी तो बढ़ भी जाता है pregnancy, बोलते ही नहीं है, 5th month तक, 6th month तक, जब वो थोड़ा सा घूमने लगता है, then you all know, when vomiting, our pediatricians should think about this also. Only, कभी gastroscopy भी करा देते हैं, but they don't think of pregnancy. We have to talk about, then first thing is make them feel comfortable. It's okay. It's okay. Sexual exposure या कुछ एक बार sexual intercourse हो गया doesn't mean the heavens will fall. It's okay. Nobody's bothered about virginity anyway nowadays. So why are we bothering? So okay, so हो गया, but you don't want to carry on the pregnancy, we should help the adolescent. We are there always to help and being non-judgmental. Please help them and please take care of the consequences of unsafe abortions. And we know about other things, mental health issues, school dropouts, उनके पूरे career ही खराब हो जाता है. There's a society, there's stigma still there. So we have to handle all this, help not only adults in the family also. We have to counsel the parents को उसको कैसे handle करना है. Let us all be close to the adolescent. The boys disappear most of the time. It's only the girl and the family has to face all this. So what are the various solutions?
Ma'am, sorry ma'am, 2 minutes.
1 minute, 2 minutes? Okay. Comprehensive sexuality education कितना important है? उनको ये पता नहीं, you may think that parts of the body बोलने से enough, no. You have to tell them about intercourse, you have to tell them you are ovulating, there are sperms, there is a physical intimacy, pregnancy हो सकता है, ये comprehensive knowledge नहीं है उनके पास. I have done a study on this. वो ये नहीं मालूम कि intercourse will lead to pregnancy. इसलिए comprehensive knowledge बताना बहुत important है. And about contraceptives, even emergency contraception के बारे में भी knowledge देने में कोई बुरी बात नहीं है. Okay. And of course we have to have youth-friendly clinics where people are non-judgmental. And where are the centers? I hardly can find. They are only doing awareness, capacity building, but the centers has to be established. Government is doing a lot, but then we need to help them. So these are protective factors. School mein, they spend a lot of time. They should have youth class. They should be connectedness, family support. Then they should be feeling safe actually. The parents can help them to make them feel safe. They should be somewhere where can then access for barriers. And consistent use ke baare mein bhi baat karna hai. And STI testing. Centers, we have in government mein to hai, Suraksha centers, but nobody is using it, especially adolescents don't go there. Now we have to talk about online sexual this thing. We all know about it. I think somebody else will cover. And they are really exposed. Photos dalte hain, likes, dislikes, Why they have to put there, I don't know. Every day they have to post something, So this is again another digital addiction. And then they want likes and all that. So this can be misused, we all know that. And then only online dating will start ho jata hai, and you know that they're morphing something, and wo koi jo hai buddha aadmi ho sakta hai, but then he'll behave like a young fellow. Then physically they also try to have, they come together, then they'll realize that sab kuch bahut aage badh jata hai jab tak. So we have to talk about all this, cyber safety and then date rapes, as I already said. So please, when you tell our girls and boys, especially the girls, ki koi bhi drink मतलब रह गया है तो not consume that, and be safe, be always in group, and all those things. I'll just, because lack of time, I'll move forward. Mental health issues, there it is definitely related with sexual activity. Risky business, again the same, whatever the risky sexual behavior can lead to mental health issues, depression, suicidal tendencies, and we know the reasons. We have to give them support. Yeah. So legal context, did we ever tell adolescents कि आप 18 तक आप sex नहीं कर सकते हैं? कितने ये जो भी है अपने acts are there, nobody knows about it, our children don't know. So please बोलना चाहिए उनको, crucial to tell them about all these things. And it is the last slide. It is time to stop this risky business. I would like to recommend these key actions. First key action is sexuality, comprehensive sexuality education. इसको एकदम mission mode में ले जाना है schools, colleges में. And I said can start at 3 years itself. The basic age appropriate information can be given, scaled up for both the genders. It's not enough to talk only for the girls कि बेटा तुम ठीक से कपड़े पहनो, रात में मत जाओ, all those things. But boys को भी education करना बहुत ज़रूरी है. Open communication, very very important. Parents से पहले start होना है घर से. Parents have to be empowered and educated how to do the open communication in a very comfortable way. Conversation should be very comfortable. Start with body changes and boundaries and sexuality, all those things. Healthcare advocates should become first empowered. Capacity building के बाद next step is implementation. हमने capacity building इतने workshops कर रहे हैं. Implementation कितना हो रहा है? Please, let us go enter into implementation mode and proactively take up these topics and become real healthcare advocates for the youth on sexuality also. Then we should start building youth clinics or adolescent clinics, both in the government and the private sector. Dedicated, not just mix up, at least they should be dedicated youth clinics. Extremely important to establish the centers, because कहाँ जाएंगे फिर? आप बार-बार स्कूल जाएंगे, बट उसको कभी-कभी दिल बोलेगा कि आपके पास आने के लिए. कहाँ पर है? यूथ फ्रेंडली, प्राइवेसी के साथ, कॉन्फिडेंशियलिटी के साथ, फ्रेंडली एनवायरनमेंट के साथ हम लोग यूथ के एंड एडोलसेंट्स को कहाँ पे हम लोग we are establishing these clinics. Please, I request you on behalf of AHA also, if Sushma permits me, and of course an individual, one person can do so much in our area. Everybody does it. You all can address all this. Risky business can be stopped on our country. Thank you, and protect our adolescents. Thank you.
Thank you, ma'am, for this insightful talk and exploring this risky behavior topic so well. and giving a word of guidance to even our healthcare professionals, because we all know that healthy adolescents will go into healthy adults, and that's our future generation. Thank you.
Thank you, ma'am, for the insightful talk. Now we move towards our next section. Let's understand what are the consequences of risky behavior, and more importantly, how we need to guide our adolescents about prevention. To address this important issue, I invite Dr. Sucheta Kinswadkar. Ma'am is a past president, Navi Mumbai Obs-Gynae Society. Over to you, ma'am.
Good morning, everyone. So till my presentation is loaded, I just thought, let me ask you one question. If you find in your adolescent 18-year-old boy visiting your house from hostel, A, a packet of cigarette, and B, a pack of condom, you'll be shocked, you'll be surprised, or maybe you'll be relieved. I want the answer at the end of my talk. I thank organizers for including this particular talk. Though initially when Dr. Chitra called me and told me that I have to speak about STI and contraception, we gynec feel this is a very boring topic. I said, pediatrician के सामने मुझे क्या बोलना है, क्या ही बोलना है. But then at the end I thought that yes, pediatricians definitely have a role to play for this, especially after listening to Dr. Hima's talk. Well, the world figures are quite disturbing. There are 1 million of new STI every day across the world. But is it a problem worth considering for India? Because we have high ethical and moral values. Unsafe means only premarital, that's what we consider. But look at this particular study conducted in South India. The mean age of coital debut was 21 for male and 18 for females, and you could see that 78% of young people were unmarried, and this was studied only during 6 months in 2015, and records of more than 1,000 young adolescents attending STI clinic was studied. So yes, even we need to consider this particular topic, and I'm going to talk about STI, contraception, and role of pediatricians in this, and I'm not going to talk about legalities and POSCO because that's the next talk. So friends, sex is a pleasurable act, but however, it comes with side effects. STI and pregnancy. And pregnancy with its own subset of complications when it's unwanted, unintended pregnancy, abortion complications, and even pregnant complications when the pregnancy is at early age. So why STI we need to consider, especially in adolescent population, and they are at risk for two things. One thing is biology. We know that cervix is still covered with columnar epithelium and not yet completely transformed to stratified squamous epithelium, and hence there is a low mucosal resistance. And this is a perfect ground for easy catching of infection of Neisseria, gonorrhea, or even, for that matter, HPV. So biology is one thing, and secondly, adolescent sexual behavior. We know that the limbic system and prefrontal cortex are two important control things in our brain. And limbic system, it's like impulsive action or learned memory. And prefrontal cortex, it is responsible for impulse control, risk judgment, risk assessment, and decision making. And the brain is undergoing remodeling till the age of 25. And hence, the age 18 to 25, they don't think of risk, it's always impulsive behavior. Adolescents think STI and pregnancies can happen to someone else, not to me. So the perceived risk is also very less. And on top of that, number of social factors like early marriage, lack of structural power to the girls to negotiate safe sex, extreme social stigma surrounding premarital sex, and online exposure and peer pressure. So all these is a perfect ground for transmission and spreading of STI. Well, this is not a microbiology class, but I'm sure all of you are aware that these are the organisms responsible for sexually transmitted infections. Chlamydia, gonorrhea, syphilis, bacteria, then viruses, HPV, herpes, HIV, and for that matter, even Hep B, and trichomoniasis is a parasite. So all of them are infections spreading mainly through sexual contact. Many a times earlier infections are asymptomatic and hence they even spread, and hence many of them they don't seek a medical advice because they are asymptomatic. But sometimes symptoms can be like pain while urinating, some abdominal pain, pain while having sex, some discharge, rash on private parts, sudden urge of voiding, that is urethritis. So all these symptoms can be there. At times, painful sores or blisters in genital or oral area will create a suspicion. Now, if left untreated, it has a whole lot of complications like reproductive health complications, pregnancy and neonatal complications, increased vulnerability to other infections because presence of these infections will be, that girl will be more vulnerable for even contracting HIV. Then chronic pain and inflammation, so on and so forth. How can we treat them? We have to treat symptomatic adolescents. There's no need immediately to investigate or prove the lab diagnosis because the NACO guidelines also tell us that diagnosis and treatment can be initiated at day 1. There is no role currently as a routine screening of sexually active adolescents in any of our pediatric clinics, though government or the public hospitals, they do have separate adolescent clinics for the same. This is NACO guidelines, like 8 particular kits, and the kit contains the first day dose or the entire course of that particular infection. Like non-herpetic ulcers, syphilis, we know that it is benzathine penicillin drug of choice plus azithromycin, herpes acyclovir, urethritis cervicitis, that is Neisseria gonorrhea and chlamydia, azithromycin and cefixime single dose. So this is the treatment guideline available on internet, and everyone can have one starter pack in their own clinic. While talking about contraception, contraception is preventing pregnancy. And this contraception information and education, I think all adolescents must have, that can be a part of sex education. हम फर्स्ट एड बताते हैं, इसका मतलब ये नहीं कि हाथ हम आग में डालते हैं, but they should know कि जलने पर क्या करना चाहिए. So like that, they should be aware what is contraception and what is postcoital or the emergency contraception. And at times, even we need to understand our own beliefs needed to be changed. For that matter, for adolescents and young adults, it's only long-acting reversible contraception, and that is of choice. Earlier we used to say IUCD, that is contraceptive device, copper T and all is only for Paris women. जिनको पहले बच्चा हो चुका है उनके लिए copper T है for spacing. But now WHO or even FOXY, we recommend that even IUCD can be used even in a nulliparous woman or adolescent or a girl. There is no contraindication for that, and the reason being it's set and forget. Compliance of oral contraceptive pills at a younger age is very poor. Daily taking one pill every day is not possible at times with most of sexually active girls, and hence probably long-acting reversible contraception, we need to change our own perception. Depo-Provera, that is DMPA, it's another available long-acting reversible contraception. It's 150 milligram of Depo-Provera. It's a Depo preparation, and one injection is to be taken every 3 months. This is Jana Hitartha. Everybody should be knowing and aware of this. Now, having said that, emergency contraception also is very important, and the beauty lies if it is taken within 24 hours of unprotected sex, then the efficacy or effectiveness will be almost 99%. But emergency contraception is not the only solution. Once it can be advised, administered maybe second time, but then if one knows that the girl or boy is sexually active, then it's better to have long-acting contraception. Emergency is only emergency, it cannot be a routine. And yes, all these contraceptives will protect and prevent pregnancy, but that will not help in preventing STI, where condom is very, very important. So if you're not married, if you're sexually active, you don't plan pregnancy, you want protection from STI, then there has to be dual protection. Use condom for the boy and long-acting contraceptive for the girl, for safety of both of them. Now, having said all this, what's the role of pediatricians? What you all can do, because till now, even everybody used to think this is a gynec domain. We know, like, refer to a gynecologist, but no. You people have long-term established rapport, not only with your patients, that is adolescents, but even with their parents. So you can bridge the gap between clinical care and education, provide non-judgmental, accurate, and confidential guidance. But remember, set aside a private one-to-one time with the adolescent during checkups. Even if he or she may come with some other symptom, but I think this is an opportunity, window of opportunity to assess what child is aware of all this about and then give education. Normalize conversation. Include sexual history in your routine history. When young patients come with the mother, I ask them, obviously they come with pregnancy, visiting a gynecologist, and not married. When she comes with the mother, I cannot ask in front of mother, are you married, unmarried, sexually active? So ये married, unmarried से young adolescents को बहुत गुस्सा आता है. But if you ask them, are you sexually active, that is more acceptable question to them. If you can't ask that in front of their parents, while examining, yes, you get at least that much privacy. So, we have to include and incorporate sexual history in our routine checkups, especially with adolescents. Remember, we belong to the older generation, and we have to remember ourselves that we have to stop lecture mode. झूठ मत बोलो, नेहमी खरं बोला. It's very easy to say right from childhood. But everyone knows what to take from that. So just don't teach them, start teaching them morality and all that stuff. They are sexually active, then you have to give them proper information. And our job is very important because media and all these Insta and WhatsApp universities, they give random and whatever remedies for all this. So act as a reliable filter for the vast and often inaccurate sexual health information available on internet. You all are providing preventive care by administering vaccines like HPV vaccine, Hep B for that matter. Screening may be routine screening or a opportunistic risk-based screening. Contraceptive services provide counseling on a full range of contraceptive options. Facilitate referrals to appropriate specialists, especially if pregnancy, then maybe gynec or the mental health professional. Be a resource for parents, helping them navigate the challenges of talking to their own children about these topics, and offer strategies for maintaining open line communications, reinforcing family values, and supporting the teens' health and well-being. I thank organizers once again and thank audience for patient hearing. Thank you so much. Each one has to answer. So who will be shocked and who will be relieved? So nobody will be shocked at finding a pack of cigarette and a pack of condom. But I think it's the concern, and you will go ahead and teach them about the side effects of smoking and health hazards because of smoking, so on and so forth. But with condom, probably you know that your child is sexually active, but he knows what is safe sex. But this opportunity one can take and extend little more information about POXO, about respecting the females and other values. Thank you.
Thank you, madam, for highlighting on such a crucial, vital and very less discussed topic. Madam explained about biology, adolescent behavior and social behaviors, means role of both nature as well as nurture. But at the same time, madam explained with proper awareness, parental guidance, adolescent can be made in making healthier decision and avoiding risky behavior. And at the end, thanks to madam for take-home message of including sexuality history in pediatric practice. Thank you, madam.
Thank you, ma'am. Thank you, Dr. Ram Bharat, for your comment. We all know now the protecting adolescent requires awareness of legal safeguards which are available to them. To understand the provisions of POXO Act, which was designed to protect children against sexual abuse and exploitation, I invite Dr. Hemant Gangolia. Sir is a law graduate and a pediatrician and also Secretary of Medico Legal Chapter of IAP. Over to you, sir.
सर्वांना माझा नमस्कार आणि thank you Dr. Kalyani for that introduction. So, ignorance of the act starts with the pronunciation. बरेच medical fraternity म्हणतात POXO, कोण म्हणतात POSCO. So it is a POXO. The second thing is that we as a human tendency, we have always have taking the shortcuts. So we rely on the WhatsApp University, WhatsApp information or messages transporting. What I am going to say you, please read the act word by word in spirit and all that important documents which one should read word by word. I will not going to, I am just going to narrate which every, and I am going to share this PDF so you can just click the link and you will get the PDF. POXO Act 2012, then Protection of Children from Sexual Offences Amendment 2019, then as it present in the Lok Sabha, then Protection of Children from Sexual Rules 2020. These are the guidelines and protocol from Ministry of Health, Family Welfare, which should be read. Then there is another important document, answers to frequently asked questions by medical professionals during medical examination of survivors and accused of sexual violence. It shows n number of cases, how to go about it. So this is a link for, this is again from, this is an important group. I will not just, I cancel group, which website, which has lots of information of all types of abuses. And so, Protection of Child from Sexual Offense Act 2012, so it is a POXO. लैंगिक अपराधों से बालकों का संरक्षण अधिनियम 2012, लैंगिक गुन्ह्यापासून बालकांचे संरक्षण कायदा 2012. POXO Act has 9 chapters, 46 sections implemented on Children's Day on 2012, 14 November. And what is 16/12/2012? Anybody can say? 16/12/2012 was the Nirbhaya case Kand. And therefore, it was amendments were made in 2019 and POXO rule 2020. In short, victim is always below 18 years, no gender. It is a gender, not a gender unbiased act. And accused, no gender, no age limit. Victim consent is not of importance. Mutual consent in act is not taken as a, is not valid. So this is the act which was passed, and this defines child. Child means age below 18 years. This is the POCSO Act. What are the aims of objectives? Protect children, punish perpetrators, provide friendly courts, as well as ensure child's right to the privacy and safety. So these are the four principles, aims and objectives of POCSO Act. So there are, in short, there are 5 types of offenses. First one, penetrative sexual assault. Then there is a sexual assault. Then there is a sexual harassment. Then there is a use of child for pornography. And last offense is the abatement of doing all these things. So these 5 offenses, to respect to these 5 offenses, we have punishments, and this all is covered in section 13, from section 3 to 18. Then, neglecting child abuse can land you in jail. Under POCSO Act, it's a mandatory to report crime against children. So what is the section 19 of POCSO Act says? It is a section which says any person who believes that there is sexual abuse has to report to the, or it has to be reported. To whom? Police, Superintendent's Juvenile Police Unit, or Child Welfare Committee. And if not reported, section 21 says there's a punishment. If it is for individual, it is a 6 months, and if it is done by the organization, which may be school, jails, these police officers, officials, then hospitals, where it can done, there is a punishment up to 1 year for the person who is in charge of that institution. So what is the challenge? Challenge is mandatory reporting. We are very reluctant to report. We have a fear of in the mind of ours regarding police. So we have to report. So this is Childline Helpline 1098. Another is 1112. What it is? It's an emergency telephonic helpline which helps link between the situation of abuse, neglect with rehabilitation services. This is another one NGO. It is from Navi Mumbai, NGO ARPAN, who also helps in this reporting. And so police, what is the responsibility of police? Police are the responsible protectors of children. Police has to make all arrangements for legal procedures and medical treatment. So what are the basic safeguards? What is known as a friendly court? In friendly court, child should have a trust and confidence that person will accompany. Special courts, so there should be no aggressive questioning. Identity of child should not be revealed. Evidence of child to be taken within 30 days and trial to be completed within 1 year. And the key word is child-friendly court is there. What is the role of pediatrician? Already madam has explained in her previous talk. Our key responsibility is early diagnosis. Provide comprehensive treatment and accurate medical documentation. These are the 3 key role of pediatrician. This is one important slide everybody should remember. There's a coordination or correlation between section 200 Bharatiya Nyaya Sanhita and 397, which is Bharatiya Nagarik Suraksha Sanhita, all passed in 2023 on July 1st, that is a Doctor's Day. And what it says, section 397 of BNSS says, all hospitals, may be public, private, run by central government, state government, local bodies, should provide immediately first aid and the medical treatment free of cost to the victims under the section 64, 65, 66, 7, 68, 70, 71 of the Sexual Offense Against Women and Child, and 120 of BNS section 2023, and sections of 4, 6, 8, 10 of the POCSO Act 2010 shall give immediate first aid without free of cost. So we have not and informed the police. That is the message from the section 200 BNS and section 397 BNSS. So there are some tricky cases. We will not go in the detail. What I want to say, sometimes mothers bring the child with a genital bleeding, and mothers say we don't want to inform police what we should do. And when they say they don't want to treatment. The second case where there is a dysuria and pediatricians notice redness and child start crying, the mother is knowing who is the culprit, but they don't want to reveal what to do in that. Then there is another 4 or 5 years ago coming up with injury to the parts and shock, and parents not willing for treatment, going to another doctor. So whether previous doctor has to report, the following doctor has to report. That has to be understood. And then the question is, 15 years old girl, a young girl coming with a boyfriend and have the urinary pregnancy is positive, what to do in this case? And sometimes they go away without taking the treatment. And so these are some of the cases. I don't want to detail and discuss. We don't have time for it. But these are the tricky cases. The word is we have to be vigilant and to be mindful. And therefore, the bottom line is inform police, mandatory. We are reporting and not complaining. Why we have the fear in the back of the mind? We think that we are making complaint. It is not complaint. It is informing police. And that we should be able to counsel across the table to the parents that we are just informing. Then you and police have to decide what to do. Our job as a medical fraternity, as a doctor, we have to report the case to the how to inform. You can inform on phone, but basically you should give in writing on your letterhead to be reported. And whether police takes action is not your job. And we should get the signature of them that we have given them informed.
So
With that, I thank you very much. Thank you very much.
Hello. Thank you, Dr. Hemant Gangolia, sir, for giving us this beautiful topic on, talk on POXO and making us aware of our responsibility towards the adolescents, keeping them safe, informed, and also prepared for the implications if they are not following the risky behavior. Thank you.
Thank you for the comment. So today's discussion reminds us adolescents do not just need information. They need understanding, guidance, emotional safety, and trusted adult who listen without judgment. I thank all the experts for wonderful discussion. Thank you.
Thank you very much. I request you all to proceed for felicitation. Our next session is Reels and Feels. For this, I invite the performers of Savli Online on the stage. The director and scriptwriter is Dr. Shubhada Kirwadkar, and the actors are Drs. Abhijit Bharadwaj, Dinesh Saroj, Linesh Yavalkar, Swati Wagmare, and Yash Banet. Another important announcement, kindly confirm your MMC details with the front desk so that you can avail your MMC credit hours. And again, lunch is between 1 to 3. There is no dedicated time slot. You can proceed as you want. Thank you.
After a barrage of role plays that you have seen and wonderful talks that you have witnessed, now let us watch an interesting role play. It's a multilingual role play, Mera Bharat Mahan, and therefore we have our Nagpur Adolescent Health Academy team. Maya, an adolescent played by Dr. Swati Wagmare. Meena Deshmukh is playing the mother. Dr. Linesh Yavalkar is playing the father, and Maya is in her home at the dining table and is talking with her parents. Let the play begin.
माया, पुढच्या आठवड्यात तुमच्या शाळेमध्ये वक्तृत्व स्पर्धा आहे ना? तुझी तयारी कशी चालू आहे?
का ग? तू गेल्या महिनाभरापासून तयारी करत होतीस आणि बेटा तू जेवतही नाही. काय झालं? तू थांब बरं माया, तुझा फोन दाखव आधी. गेल्या 2-3 दिवसापासून तू काहीतरी तुझं बिनसलेलं आहे. अहो अहो हे बघा, हिचं सोशल मीडिया अकाउंट, याच्यामध्ये हिचा फोटो आहे आणि कसा तो किती विचित्र आहे, मॉर्फ केलेला दिसतोय आणि किती घाणेरड्या कॉमेंट्स आहेत त्याच्यावर.
याची आपल्याला कंप्लेंट करावं लागेल, तक्रार टाकावं लागेल.
हो ना, बिचारी आपली माया.
With this problem identified by the parents that Maya has some issues online, they have now reported to the school principal, and now let's watch the scene in principal's room in the school. The principal is played by Dr. Yash Banai.
Please have a seat, Mr. and Mrs. Kelkar. Maya, your parents have shown me the screenshots. It is really concerning. Good, Mr. and Mrs. Kelkar, that you have saved the screenshot and shared with us. We are really concerned about you. Maya, this will be taken care of.
But, sir, what is the use now? All my friends have seen all those photos and they are laughing at me. I know. I am not going to come to school. Never.
See, Maya, what your father is saying is absolutely right. Our school has zero tolerance policy against these type of attitude and these bullying. We have already identified few students, and disciplinary action has been taken against them, and even their parents have been informed. But we are more concerned about you. Maya, do you remember Dr. Arya, the adolescent counselor who came for time management teaching? Mr. and Mrs. Kelkar, I'll be booking an appointment with him. Please take Maya to them. We need some serious counseling.
So now the parents take an appointment with a pediatrician counselor, Dr. Arya, who has already visited the school, and Maya is familiar with him. After giving the basics of counseling like welcoming the adolescent, building rapport, and asking the parents to wait outside, he now counsels Maya for the issue she is having online, the bullying, and also gives her some tips. Let us watch the scene in Dr. Arya's clinic.
Hello, Maya. माया, क्या आपको पता है इंटरनेट एक लाउड स्पीकर की तरह होता है जहाँ छोटी सी बात भी बहुत बड़ी लगने लगती है. आपके इतने अच्छे अच्छे क्वालिटीज़ है, क्या उन्हें पता भी है? असली माया तो केवल आपके करीबी लोग ही जानते हैं. बाकी लोग तो बस केवल छोटी सी बात को बड़ा इशू बनाकर मज़ा लेते रहते हैं.
पर डॉक्टर, जब स्कूल के इतने सारे बच्चे मेरे उस गंदे से फोटो के पोस्ट को लाइक करते हैं तो मुझे बहुत बुरा लगता है. मुझे रोना आ जाता है, मैं डिस्टर्ब हो जाती हूँ डॉक्टर.
माया, लोग फोटो को लाइक करते हैं क्योंकि वो सोचते ही नहीं हैं. आपकी जो फोटो है वो आपका वैल्यू डिसाइड नहीं करती. लोग क्या सोचते हैं, हम उन्हें इतना इम्पोर्टेंस क्यों दें? उनसे हमें कोई लेना देना नहीं. चलो हम एक डिजिटल डिटॉक्स प्लान बनाते हैं, उन लोगों को अपनी दुनिया से हटा देते हैं. आप क्या सोचती हैं?
पर डॉक्टर, आई फील वेरी लोनली.
माया, आप अकेली नहीं हैं. आपके टीचर्स, आपके पेरेंट्स सभी आपके साथ हैं. चलो हम इस फेज से बाहर निकलते हैं.
ओके सर.
So after this counseling session with Dr. Arya, he gave some more sessions to Maya, and he gave anticipatory guidance regarding how to be safe online, how she should handle her emotion. He also gave her some life skills that Dr. Shamik has narrated in the morning. And by, Maya has come out of the crisis. He also gave her some techniques of relaxation, like deep breathing, 5, 4, 3, 2, 1 mindfulness, and Maya is a changed person now. Now let us watch Maya, a changed person in her home.
माया, डॉक्टर आर्यांचा फोन आला होता माहितीये, ते तुझी विचारपूस करत होते. कसं वाटते बाळा आता तुला?
खूप छान आई. आता ना मी माझे ते सोशल मीडियाचे ॲप्स जे आहेत ते डिलीट करून टाकले आणि जसे आपले सायबर एक्सपर्ट आहेत निशिकांत काका त्यांनी सांगितल्याप्रमाणे मी ते ॲप्स रिइन्स्टॉल करताना माझे प्रायव्हसी सेटिंग्सही बदलून टाकलेले आहेत. आता मला कळलंय की स्वतःला सायबर सेफ कसं ठेवायचं.
व्हेरी गुड, व्हेरी गुड.
आता मला शांत झोप येते.
वा वा, आम्हाला तुझा अभिमान आहे माया. तू या प्रसंगाचा संकटाचा किती छान सामना केलास.
बाबा, उद्या मला मुख्याध्यापकांनी शाळेत सायबर सुरक्षेवर बोलायला बोलवलेलं आहे. आधी मला खूप भीती वाटत होती आई, पण आता मी विचार करते मी बोललं पाहिजे. जर सायबर बुली झालात तर काय काय करायला पाहिजे ते मी सगळ्यांना सांगू शकते. तर चला आई बाबा, आपण लक्षात घेऊया काय काय करायचं ते. बुली झालं तर बोला. आपल्या जवळच्या लोकांसोबत म्हणजे जसे आई वडील किंवा तुमचे शिक्षक यांच्यासोबत आपलं संकट शेअर करा.
If needed, take help of school, report to police and also cyber security.
बिना डरे धैर्य रखकर आपके चैट्स और मैसेजेस आपका प्रूफ है, उन्हें सेव करें, ऐप डिलीट करें, प्राइवेसी सेटिंग्स चेंज करें, ऐप्स अनसब्सक्राइब करें और बुली को ब्लॉक करें.
और अपने रियल मी को हमेशा जागरूक रखें. अपनी शर्म की भावनाएं, अपनी निराशा, अपनी जो भी इश्यूज़ हैं उनको अपने पेरेंट्स के साथ शेयर करें, अपने ट्रस्टेड एडल्ट्स के साथ शेयर करें और खुद के इमोशंस को हँडल करना सीखें.
कोणतीही पर्सनल गोष्ट कोणत्याही सोशल मीडियावर पोस्ट करताना कमीत कमी 10 वेळा विचार करावा.
रियल मी और रियल मी इसमें फर्क पहचाने और उसके अनुसार अपना बर्ताव रखे.
यासारखे अनेक गोष्टी मी माझ्या भाषणात सांगणार आहे. मी आणि माझ्यासारख्या मुलांनी सोशल मीडियावर आपले फोटो किंवा कुठलीही माहिती पोस्ट करताना खूप वेळा विचार करायला पाहिजे. त्याच्यातले धोके लक्षात घ्यायला पाहिजे आणि बुलिंगचा तगडा सामना करायला पाहिजे. जर आपण गप्प बसलो तर ते सायबर बुलिंग करणाऱ्यांचा धाडस वाढेल आणि मी ते कदापि होऊ देणार नाही.
छान. आय एम प्राऊड ऑफ यू बेटा. आता तू इतरांनाही चांगली दिशा दाखवू शकतेस.
हो आई. साथ हम हैं तो क्या गम है, चाहे तो हमारे बस में क्या नहीं, बस एक जरा साथ हो तेरा, बुली कोई हो लड़ भी तो लो, हम
Fantastic. Thank you so much. That's a real need of the hour talk. I now invite Dr. Sameer Shah. He's the executive board member of Central AHA 2526 from Vadodara. He's going to be talking to us about hooked and hurting due to social media, along with a small talk on cyberbullying. Thank you.
Hello. Hello. So good afternoon to all. And since morning, what we are learning, everything about the social media, and if you just go for the statistics of our today's all session, each and every session is saying something about the social media. So this is the 100% statistic what that is giving about the hooks and hurting. So how many of you are not hooked by social media? Not hooked by the social media. So, okay, And how many of are having some hurting because of social media? Right. So it is not about the adolescent, it's about us also. And social media, when we are discussing, it is always about not only of adolescent, but it about the adults also. And it's my privilege that I have to take one more session along with Dr. Swati Pave, my mentor, my all the things what I am doing in adolescent because of her only, and that is about the cyberbullying, invisible threats. And before I just start my presentation, this is a small message from her before we go for ahead. Audio, please.
I'm sure you're enjoying since yesterday the wonderful conference. I was looking forward to log in today and meet you at least remotely, but you all know my family health issues, so I'm not feeling up to logging and delivering a lecture. So I've requested Dr. Samit Shah to do this, and the organizers have kindly agreed. But it was suggested to me that at least I send a short message, which I readily agreed because I also want to be connected with you and interact. So thank you so much for having invited me. The topic is very contemporary, and I'm sure Sanjay will do an excellent job. And hope next AHA meeting I'll be able to come in person. So congratulations, Chitra Kulkarni, Neha Singh, and all of you. The academic program is wonderful, and I'm sure the local arrangements will be equally good, and you all are having a rocking time. Thank you, and Jai Maharashtra and Jai AHA. Bye.
So, with this, not at least we can save at least 5 to 7 minutes of the today's session. So that will become alignment for the organizers to make this so much late that was at presently going on. So today's session, the outline will be the scaling the problem, what the hooks and why they are hooked, what are the hurtings they are happening, the clinical framework, how we can act regarding that, and few takeaway message. So epidemic, if we see this digital epidemic in India in numbers, this is a very, very eye-opening that almost 7.3 hours of the India's average daily screen time, 68% of the adolescents spending more than 2 hours per day, 87.2 children exposed to screen time before the age of 3, and 4.76 billion global social media users representing almost 59% of the Earth's population. And out of that, 21.5% of the Indian school-going adolescents presenting with the moderate or problematic internet use, and 70% of the Indian adolescents between 15 to 19 experience some form of the cyberbullying. So all this epidemic is very, very, very important to understand why we are discussing this topic today. So let's discuss why they hook. And that will be start with our neurodevelopmental vulnerability, that including the immature prefrontal cortex, or what we are knowing before 25 years, it's not developed. At the same time, there is a hyperdopaminic center because of the excited mature amygdala, immature amygdala, that is making the overriding of that without break. There is an acceleration is going on. At the same time, curiosity and exploration will be very much high on this age, intense peer pressure, and of course 24/7 availability of devices. And lastly, what we all facing, that is the FOMO and FOBLO responses that will continuously hooking us to get a more than 2 hours per day or the more than 7 hours per day where we are, that what we have to find out. Again, because of, not only because of the continuous availability, but so many advantages of that technology that is making us so many things that hook, that including the global connectivity at any place, anywhere. Awareness and advocacy can be possible by the social media awareness campaign. Creativity and talent at high. You just see the presentation that what we can make nowadays. The technology that will give a good educational resources that is available anywhere, anytime, and that was the what making the compulsive use in the education. Networking and career counseling is very, very easily available because of the availability, and support community can be get when we really need something support and real base. It's not end with this thing about the digital awareness. Again, now AI is involved and that will give a personalized learning, academic support, creative innovation, mental health support, and of course digital skill development. And AI is added the hooking of ourselves in digital media. At the same time, we have to understand how it hurt ourselves. That including the so many physical health consequences that can be occurred, starting from the digital eye strain, that is the CVS, neck and thumb, texting thumb problem that can happen continuously because of the continuous writing on the digital media. Roadside accidents can be happen because of when unwanted call come and suddenly we take during the driving. Sleep disturbances, we all know about what the blue light is and how melatonin delay this sleep and ultimately making a sleep disturbances. Obesity, already Madam has discussed a lot, and one part of that is the cause is the social media overuse. But we also have to understand now EMF radiation, because of the continuously 10x more radiation can be exposed and affecting the mental development of the child, and we have to not miss that. That's what we have to understand. Psychological hurting is also equally important, that including the fear of the missing out or the fear of the being left out is one of the important cause what missing us and continuously hurting us to go for a compulsive use of the internet and social media. It ultimately lead to the out of box of the over our physical activity, and that lead to the anxiety and depression. Nomophobia is one of the very, very important terminology that what we are missing up. Suddenly, if we miss our phone just now and just found just behind that, it will give a good satisfaction, mobile yahi pe hai. So that is the thing. At the same time, doom scrolling give us a continuous training of our brain and mind to utilize our mind for a wrong messages that is coming continuously and giving us a threatening effect. Such type of the effect may lead to more and more problematic thing. Suicidal ideation and preventive perverted concepts are now at a peak because of only and only because so high use of the social media, easy availability of the pornography, and easy availability of the such ideation on the social media on tip of the tongue. That will lead to the ultimately problematic psychological impact. Being the clinician, we always look, our case study will help us to understand all this hook and hurting. So this is a case scenario, 16-year-old adolescent having a cheap complaint of the chronic neck pain, dry and burning eye, severe and daytime fatigue, late night social media use and continuous doom scrolling is there, poor academic performance and mood swing will there. So it will be the prolonged screen use, poor sleep hygiene and impacting this physical health, mental well-being and daily functioning of this child. Family concern, mainly parents report the continuous irritability, anger outbursts, separation anxiety and constant checking when the phone is removed from his hand. So here all the problem that is related with the overuse of the digital media. So what is the question? This is a just simple overuse or something more than that? What you are saying? Is it a just simple overuse that led to the all problem? No, right? So it is about the problematic internet use and why it is considered and how we define with the 5 C's. That is the coping mechanism. It is our using the internet as escaping the offline activity. At the same time, continuous craving and preoccupation with the online activity, compulsive persistent use, at least it should be in our hand. That is a compulsion to utilize our social media devices. Control loss, that will lose our inability, limit session duration. देखना है लेकिन कितने देर देखना है लिमिट नहीं कर पा रहा है. That is the control of the loss and ultimately consequences that lead to the what we are just discussed into the hurting. So all this will give the diagnosis of the problematic internet diagnostic loop. That's what we have to consider, and that's why this is the heads history is very, very important, and that is called the digitally augmented health assessment, that everybody has to involve in our own digital when we are screening for that including whether there is a device-free zone is there or not, does a drop in academic performance with a late night screen use, whether they are utilizing 2020 rule or doom scrolling is there or not, is the patient exhibiting the FOMO, FOBLO or other symptoms like digital continuous usage, or asking directly about the click clever or click safe code, whether they are knowing or not. So this health history, that including the home, education, activity, drug depression and safety, we have to involve in our health assessment. There are the few toolkits that is available that you can utilize in your own routine work, and that is the internet addiction test, that is a gold standard with a burden social media addiction scale. Problematic and risky internet screening scale is also available, and lastly, smartphone addiction scale of smart version is there. Now it's a time to click it out. These are the toolkit that you can utilize in your daily basis. Second, this QR code is the how you can go for your addiction score. It is a Kimberly online addiction scale. You can check your also or the 21-year age group of your patient also, and they will get the immediate scoring with that thing. Now we all understand what are the hooks and what are the hurting. So where our own role. So these are the 6-step management protocol that what we have to manage, that including the starting from the head assessment at screening, followed by the proper explanation of the what are the neuromechanism, what are the consequences, and what is the permanent digital footprint, that not only to the adolescent but their parents also, and we also have to understand that. We have to counsel them with a proper CBT counseling or identifying the underlying cause and treat that. We have to restrict the tech limit, that is the different screening tool and the scaling tool and the applications that is available, that including the Apple Screen Time, Google Family Link, and establishing the device-free zone. Replace with the all the physical activity and the other curriculum other than the social media engagement is very important, and refer we will move forward and we will see. So this is a pediatrician's toolkit for a parental counseling point, that is they have to go for WW approach. For the parents, they have to understand, they have to check whom they are meeting, adolescents, children, where they are going and what they are doing the online. There should be device-free zone in bedroom, dining and bathroom. Do not use the screen as emotional pacifier. There always will be the family media plan, because we have to understand they are modeling the parents, and family media plan works a lot. Be a digital role model is very, very important, and at the same time, Google Family Link and Apple Screen Time, you have to utilize a large when you are giving smartphone to your children. Balance of 1 hour outdoor activity plus 8 to 9 hours of the sleep that should not miss by anyone, and start the digital parenting at the birth, not at the time of the adolescent. That is a very important thing. What pediatricians we can do? We can also start our health assessment properly, just discuss, advise the age appropriate use based on the maturity and regulation to adolescent, warn about the permanent digital footprint, what they are doing online, cultivate a media literacy guideline we will discuss just now, take click, clever and click safe, that is a zip it, block it and flag it. That is a very, very important message we have to teach them in each and every our well clinic when they are visiting us. Discuss about the cyber bullying and what's response, where to respond. Prescribe the screen-free time, that include the 1 hour of pre-sleep at meal and at bedroom, and refer a severe case as and when required. This is our clinical guideline of the age-appropriate screen dosage, that what we can advise, and we can keep this even slide on our clinic in our waiting room. Most important thing, what everybody should understand, this is a digital framework we have to teach ourselves also and to our adolescent, that including the digital source credibility. That is very important. Each and everything what they are seeing or the watching, they can directly transfer to the other people. That should not happen. Credibility should be checked. They have to investigate with the multiple sources before posting anything. Guard your privacy is very, very important. Keep a proper privacy check in the thing. Just we had seen our role play. Interpret critically. That is the very important. Think before posting is the most important mnemonic that what we have to understand. Avoid the plagiarism because of the now the use of the AI. Everything is available on tip of the toe and everything will be just posted as it is. Don't do that thing and limit our screen time. This digital framework we have to teach to the parents and to the adolescent. That is important. And this slide is important to understand ourselves that the neurovulnerability window is between the starting from 0 to 10 and not at the age of the adolescent from starting of the 12. So we have to act fast from the every well-being clinic. We have to start about the giving our digital understanding and digital media literacy should be started from the beginning. And we have to divide our zone from left zone, central zone, and right zone. If start with the basic vulnerability, we have to give a proper education. Acute distress, what we are finding in central, we have to give a smart protocol for the cyberbullying. And if it will be very, very severe risk and harm, we have to refer timely. So this is the very important thing, that is our 6th step, when to refer the child in appropriate time. And this is about if the 5 seizures persist, we have to present a severe comorbidity. We have to refer a proper timely refer, help a lot to prevent the child to become the more culprit or maybe become the more user-friendly, device-friendly, media-friendly. One more case scenario, whether now you have to differentiate whether it is a problematic internet use or something else, right? 15-year-old adolescent brought to your clinic with a concern presented sudden decline in academic performance over the last 3 months. Refusal and reluctance to attend the school. Increased irritability and emotional outbursts. Withdrawal from the family activity and friends, and loss of the interest in the sports and hobbies. And what the parents report, every time a message arrives on the phone, our child becomes the anxious, angry, and upset. So what this will be? Cyberbullying. So now we have to understand this is not only the problematic internet use, it is all about the neurological problem, physiological problem, psychological problem, and functional problem that is directly attacking the brain, mind, and that will ultimately what we have to understand, that is the cyberbullying. Absolutely, yes. We have to understand the category-wise where the explosion is, whether it is the deception or the exploitation, or it will be direct harassment or direct harm. And accordingly, we have to act, because cyberbullying is ultimately a combination of all the what we are discussed in the problematic internet use, that including the neurological immaturity, continuously dopamine-driven platform, and anonymously accessibility of the device that ultimately lead to the cyberbullying crisis. And for that, what we have to understand where these problems are. It may be a behavioral shift, it may be a psychological indicators, or it may be the academic disruptions may be there. So this is a difference between the problematic internet use and active cyberbullying harassment, and we have to differentiate depending on what is the core pathology, what is the device relationship, whether it is the problem and fear and anxiety, and what is the emotional state are, and we have to differentiate and we have to act smart. Why? Because almost 70% of our Indian adolescents aged between 15 to 19 have experienced some cyberbullying is there. And we have to start with the stop, message block, keep up preservation of the evidence, never retaliate of that, and action of reporting and managing is very, very important. Just now we are having an excellent role play, so we are not discussing this in deep. So with this key message, I am ending, that is the problematic internet is a real 21.5%. Biological vulnerability because of the immature prefrontal cortex and dopamine dynamic drive the addiction, not adolescents, their own choice. Screen at every visit is our own pediatrician's role with the head's assessment of digital management, and digital parenting start from the birth. That is very, very important. and control the screen. Do not this screen control to you. And if anything happen, cybercrime helpline is there. That is the www.cybercrime.gov.in or 1930. Thank you. Thanks a lot.
Thank you very much, sir. Now I invite the actors in the skit Atta Maji Satakli. The director is Dr. Sangeeta Loda. Script writer is Dr. Swati Wagmare. And the actors are Drs. Deepashri Tatar, Manjusha Sherkar, Sangeeta Loda, and Swati Wagmare.
Hello friends, today we are playing a very interesting role play on anger management. Atta Maji Satakli. The characters in this role play are I, Dr. Sangeeta Lodha, narrator, Dr. Swati Wagmare, Dr. Prerana, adolescent practitioner, and she is script writer of this role play as well. Dr. Deepashri Tatar, Master Rudra. Mrs. Dr. Manjusha Sherkar, Mrs. Ragit, Rudrachi Ai, Dr. Amruta Durge, Mr. Ragit, Rudrache Vadil. दोघेही वर्किंग पॅरेंट्स कामाच्या तणावाने आई पण चिडचिडी. प्रशांत रुद्रचा मित्र शांत स्वभावाचा. सीन 1 रुद्राचे घर. रुद्र आत्ताच अभ्यास करायला बसला आहे. प्रशांत त्याला भेटायला येतो.
रुद्र ए काय करतोस? ए चल ना नोटबुक आणायला येतो का? अरे अभ्यास करतोय. ये ना चल ना 2 मिनिटात जाऊन येऊ. चालेल चल ना चल. अरे रुद्र हे काय? इतका वेळ अभ्यास मोबाईलवर असून तू आत्ताच अभ्यासाला बसलायस आणि आता त्याच्याबरोबर बाहेर चालला होता. 4 दिवसांवर परीक्षा आली आहे. कसा अभ्यास करायचा? आई तू सतत का माझ्या मागे असतेस? एका गोष्टीवर माझं लक्ष ठेवते. बारीक बारीक लक्ष ठेवतेस. मला स्पेस देत नाहीस. सारखं अभ्यास 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 नाही करायचा मला अभ्यास. म्हणजे काय? इतका वेळ आम्ही रात्रंदिवस कामं करतो. आई आणि बाबा आम्ही दोघे जण कष्ट करतो. तुला इतके चांगल्या शाळेत घातलंय आणि अभ्यास नाही करायचा. अभ्यास नाही केले तर मार्क्स कुठून येणार? परीक्षा 4 दिवसामध्ये. त्या यशला पाहिलंस का तू? कायम शाळेत पहिला नंबर आणि तुझा 4था 5वा परीक्षेला मला कंपेअर करत जा.
Scene 2. After 1 hour, Rudra returns home. Mr. and Mrs. Ragit are sitting in the room.
रुद्र आलास का? ये चल जेवायला बसूया आपण.
मला नाही जेवायचं.
म्हणजे काय? हे बघ रुद्र, आम्हाला कळतंय तू रागात आहेस. प्रत्येकाला राग येत असतो हेही माहिती आहे. पण हे काय, आजकाल तू अगदी छोट्या छोट्या गोष्टींवर चिडचिड करतोयस. आता मगाशी पाहिलं मी तुला येताना, त्या आपल्या ओरिओला लाथ मारून निघून गेलास. वस्तू फेकतो, शुल्लक गोष्ट, आणि इतका मोठा पराकोटीचा राग. हे काही बरं नाही आहे बरं.
मला नाही बोलायचं.
हे बघ रुद्र, आपण एक काम करूयात का? आपण याविषयी जरा बोलूयात काहीतरी तुझ्याशी, ठीक आहे?
रुद्र, हे बघ, मला कळतंय. ठीक आहे, तू जेव्हा शांत होशील तेव्हा ये, बोलूया आपण. ठीक आहे, आम्ही आहोत इथेच बाजूला.
सीन 3. थोड्या वेळाने शांत होऊन रुद्र रूममध्ये येतो आणि म्हणतो,
काय बोलायचं तुम्हा दोघांना?
रुद्र, हे बघ, बघतोय मी आजकाल तुझं आणि आईचं सतत काहीतरी वादावादी, सतत आर्ग्युमेंट्स, सतत भांडणं, घरातलं वातावरण बिघडतंय. मागच्या वेळी PTMला तुझ्या क्लास टीचर म्हणत होत्या की तू तिथे पण उलटी उत्तरं देतोस, चिडचिड होते तुझी. आणि फ्रेंड्सबरोबर आजकाल जरा जास्तच तू मैमे व्हायला लागली. बघ रुद्र, कसं आहे, याच्यामुळे तुझे रिलेशन्स बिघडत आहेत सगळ्यांशी. म्हणून मला असं वाटतं की आपण त्या डॉक्टर प्रेरणा त्यांना भेटायला जाऊया. आठवतात का तुला त्या? तुमच्या शाळेत मागच्या वेळी PTMच्या वेळी भावनांचं व्यवस्थापन खूप छान बोलल्या होत्या त्या याच्यावर. आठवलं?
पण मला नाही वाटत कोणाशी बोलायची माझी काही इच्छा नाही. मला काय कोणाशी भेटायची इच्छा नाही. पण तुम्ही म्हणतात तर येईन एकदा तुमच्या समाधानासाठी.
Scene 4. So, Mr. and Mrs. Ragit with Rudra go to Dr. Prerna, who is pediatrician and adolescent counselor. Dr. Prerna talked to Rudra after respectfully asking parents to wait outside. After ensuring confidentiality, she tries to identify causes of excessive anger in Rudra in the form of various triggers. And then she finds out that Rudra is being bullied in the school. So he is always irritated. After taking a session on how to deal with bullying, she also counseled parents on unconditionally supporting their child and managing their anger. In next session, she counseled Rudra on anger management. Dr. Prerna.
रुद्र, राग ही एक महत्त्वाची भावना आहे. राग येणं स्वाभाविक आहे. प्रत्येक मुलाला कोणत्या ना कोणत्या कारणांनी राग येतो. तुला कधी राग येतो?
खरं सांगू का डॉक्टर, मला खूप स्ट्रेस असतो. अभ्यासाचा स्ट्रेस असतो. आई, वडील, शिक्षक सर्वांचाच माझ्याकडून खूप अपेक्षा आहेत. आणि मला सारखी भीती वाटते की त्या अपेक्षा मी पूर्ण करू शकेल की नाही. आणि शिवाय आई मला वेळच देत नाही. माझी तुलना सगळ्यांशी करते. सारखं माझ्या अभ्यासाविषयी तिला खूप सारखं अभ्यासासाठी माझ्या मागे असते. आणि सगळ्यात महत्त्वाचं, मला समजूनच घेत नाही. म्हणून पण माझी सतत चिडचिड होते.
ते बरोबर आहे तुझं, पण सतत चिडचिड केल्यानं त्रास कोणाला होतो?
त्रास मला होतो, आईला पण होतो. मला हे सगळं कळतं. घरातलं सगळं वातावरण बिघडतंय. पण मी काय करू?
आई बाबा मला सांगत होते की तू तुमच्या पेट डॉगला पण मारतो, सगळी सामानाची फेकफाक करतो. तुझं हे वागणं बरोबर नाही. ॲक्च्युली तू राग एक्सप्रेस करायचा हा प्रकारच बरोबर नाही. ॲक्च्युली तू रागाला कंट्रोल करायला पाहिजे, पण रागच आता तुला कंट्रोल करायला लागलाय.
हो, हे समजतंय मला. माझं चुकतंय. पण मी काय करू डॉक्टर? तुम्ही मला मदत करा ना.
नक्कीच. तर आपण बघूया, जेव्हा तुला राग येतो तेव्हा तू काय करायला पाहिजे. जेव्हा तुला खूप राग येतो ना, त्यावेळेस तू पॉज टेक्निकचा उपयोग करायचा आहे.
व्हॉट इज दिस पॉज?
पॉज इज अन ॲक्रोनिम. त्याच्यातला P म्हणजे ॲक्च्युअल पॉज. तू जे काय करतो आहे, जो काय विचार करतो आहे, तो ताबडतोब थांबवायचा.
पण तो कसा थांबवायचा? त्याच्या काही टेक्निक्स आहेत. जसं की तू लांब श्वास घेऊ शकतो, उलटे पाढे मोजू शकतो 10 पासून 1 पर्यंत, किंवा एक ग्लास थंड पाणी पिऊ शकतो, किंवा तोंडावर पाण्याचा शिडकावा मारू शकतो.
ओके.
मग पुढचा
ए, पी नंतर ये, PAUSE.
येस. तर ए म्हणजे ॲक्नॉलेज. तुला राग येतोय, आता माझी सटकली, हे तू लक्षात घे. यू म्हणजे अंडरस्टँड. तुझ्या रागाचे काय कारण आहे ते समजून घे.
ओके.
एस म्हणजे स्लो डाऊन. जरा स्वतः विचार कर शांतपणे. आणि ई म्हणजे एंगेज प्रॉपरली सो दॅट यू कॅन एक्सप्रेस युअर सेल्फ. है ना? याच्याने काय होईल की पुढच्या व्यक्तीला हर्ट न करता तुला एक्सप्रेस करता येईल. आणि
हे सगळं तुम्ही सांगताय डॉक्टर, हे समजलं मला, पण हे सगळं केल्याने नक्की काय होईल?
तू रिॲक्ट न करता, इम्पल्सिव्हली रिॲक्ट न करता रिस्पॉन्ड करायला शिकायचं आहे. कारण म्हणतात ना, टू नेम इज इट्स टू टेम इट. तर म्हणून ह्या पॉज टेक्निकने काय होणार, एकाएकी जेव्हा आपल्याला खूप राग येतो तेव्हा आपलं थिंकिंग ब्रेन म्हणजे ॲमिगडेला हायजॅक होतो आणि आपण काही न विचार करता जे तोंडात येईल, जसं वाटेल तसं वागतो, जे तोंडात येईल ते बोलतो. पण आपल्याला जर 6 सेकंदाचा पण वेळ मिळाला ना, जे आपण पॉजनी करतो आहे, त्याच्यामुळे तुमचं थिंकिंग ब्रेन म्हणजेच प्री फ्रंटल कॉर्टेक्स हे ॲक्टिवेट होतं आणि तुम्ही व्यवस्थित विचार करून थोडंसं रिस्पॉन्स व्यवस्थितरित्या देऊ शकता, पुढच्या व्यक्तीला हर्ट न करता.
हो, कळलं डॉक्टर.
पण तुला हे लगेच जमेल असं नाही आहे. पण तू प्रयत्न केलास तर तुझ्या रागाची इंटेन्सिटी निश्चितच कमी होईल. कारण की अँगर लास्ट फॉर फ्यू मिनिट्स बट द डॅमेज इट कॅन कॉज मे लास्ट फॉर इयर्स.
हो, हे तर मला आत्ताच कळलंय की असा वर्षानुवर्षे राग राहू शकतो आणि त्याचं डॅमेज राहू शकतं. थँक्यू फॉर द इनपुट्स डॉक्टर.
तर तू प्रयत्न करशील अशी मला अपेक्षा आहे.
हो, नक्कीच डॉक्टर, नक्कीच प्रयत्न करेन.
ठीक आहे.
So this is one technique of controlling anger. We can teach them various other ways like maintaining anger thermometer, deep breathing technique, walking away, share with them anger story, the nail in the fence, or do a role play. Now scene 5. Counselor's clinic after 2 months.
चेंजेस झालेत आमच्या घरात.
मॅम 1 मिनिट.
वातावरण बरंच सुखकर झालंय. रुद्रच्या आईसुद्धा तुमचा सल्ला फॉलो करतायत.
व्हेरी गुड.
थँक्यू सो मच डॉक्टर. खरंच तुमचा जो सल्ला होता ना पॉजचा, तो अगदी आय ओपनिंग होता आमच्यासाठी. मी पण एक चांगलं पॉझिटिव्ह रोल मॉडेल होण्याचा प्रयत्न करत आहे. आणि विशेष म्हणजे रुद्र पण आता वेळोवेळी पॉज घेतोय आणि आपला राग आटोक्यात आणण्याचा प्रयत्न करतोय. थोडक्यात आमचं घर रिलॅक्स, सुखमय आणि पॉजमय झालंय. थँक्यू सो मच डॉक्टर.
आणि ह्याची किमया कशामुळे, पॅरेंट्स हे रोल मॉडेल असल्यामुळे मुलामध्ये इतका फास्ट बदल तुम्हाला दिसायला येतोय.
So friends, anger is a powerful energy. When controlled, it builds strength. But when uncontrolled, it destroys relationship. That's why anger management is crucial.
Thank you very much.
आणि मग हॅलो, रागावर विजय म्हणजे स्वतःवर नव्हे, इतरांवर नव्हे, तर स्वतःने स्वतःवर मिळवलेला विजय.
आणि काउन्सिलरचा सल्ला म्हणजे रियल विजन.
I now invite Dr. Uday Bodhankar sir, who is a renowned national and international faculty. He is the president of Commonwealth Association for Health and Disability UK, and he holds the record for still being the youngest CIAP president, and he looks quite dashing in his blue. The chairpersons are Dr. Ruchira Maheshwari Gupta, who is the Honorary Secretary General CIAP from Noida, and Dr. Veeranna Kotrashetty, who is the Professor and Head of Department Pediatrics, D.Y. Patil Medical College, Nehru.
Start. Yeah, good afternoon, all of you. At the outset, I would like to thank Chitra Kulkarni, Sushma Desai Madam, and all the committee of AHA MAHA AHacon for inviting me. After a long gap, I am presenting myself in AHA. After Hema Bindu invited me in Ahmedabad. Now, without wasting time, I think we will go ahead. The anger management which was presented by Dr. Lodha from Nashik was a wonderful skit, and even the Nagpur people presented was a wonderful skit to my knowledge. Now, you all know the anger issues are becoming common nowadays, not only adolescents but also senior citizens like we. So it is better how they can handle, how can they manage to tell on this. We have got two distinguished speakers. One is Dr. Shama Kulkarni, who is a senior pediatrician, adolescent health expert from Nashik, and we have Dr. Shailaja Mane, chairperson MAHA AHA, professor and head of department, D.Y. Patil Medical Pune. So kindly give big round of applause to them. Welcome, madam. I welcome my co-chairperson, Dr. Veeranna Kotrashetty, and I think we are waiting for Dr. Ruchira Maheshwari Gupta. I think she has come. She will soon join us. Yeah, please. Ide basa.
A very good afternoon to one and all. It's my honor and privilege to be here. I thank Dr. Chitra and entire team of organizers for wonderful conference. Thank you all the chairpersons. As pediatricians, we have noticed a significant change in the concerns brought to our clinics over the period of years. While physical health remains important, emotional and behavioral concerns are becoming increasingly common. And parents frequently tell us various things like, Doctor, my son is getting angry for smaller things. You have seen beautiful skit. Please give them big round of applause. They have set the ground for us wonderfully. So parents complain that that person, that boy or girl was not like this before, and getting upset and angry inappropriately for small things even. So to address about this, we are here, Dr. Shama Kulkarni madam and myself. So Shama madam, will you like to share any case?
Yes. In day-to-day practice, many times we find that parents come with the complaint that my child has anger issues. I can share one case. A 10-year-old boy was brought to the clinic by parents, and he had frequent anger episodes. He was stealing money. He was just throwing tantrums. He was throwing the things around and kicking here and there. He was very angry. And coming to health assessment, he was at home, it was nuclear family education. He was in 4th standard. Lifestyle was good eating habits, and no history of any drug or any other suicidal ideation. And now in case of anger, it's not the anger. Anger is just what we see, but we have to see beyond it, what is underlying. And in that case, the parents used to compare him with his friends, with his cousins, and that's why he was so much angry. So it was hurt, and not just only the anger.
Yes, but nowadays, we all know that schools are reporting increasingly various issues like emotional outbursts, peer conflicts, bullying, impulsive behavior, and even difficulties in emotional regulations. And if we look beyond our clinics, newspapers and media reports regularly are flooded with the stories of road rage, violence, cyberbullying, relationship conflicts, assaults following minor disagreements, self-harm, suicides, and even emotional distress, and it can lead to impulsive actions of various homicides even. So almost every week we come across reports of adolescents getting involved in physical fights over social media comments even. Samir had taken beautiful session. So students attacking classmates after arguments, violent reactions to academic stress, online bullying. There are so many even tragic incidents leading to self-harm and harms to other as well. So many of these incidents began with relatively minor triggers, even smaller disagreement, misunderstanding, teasing remarks or poor exam results as well, and even issues with social media posts as well. So poor anger management is not merely an emotional issue, but it is significant social, academic, psychological, and health issue leading to lifelong problems as well.
So what we are going to think about, learn about it is understanding anger. It's not just anger. The adolescent is angry, that's not enough. But why he is angry? We have to go into the depth, we have to enter into the peep inside the adolescent's world. Then we have to promote emotional literacy. They should understand their feeling. Then recognize the emotions behind anger. As we have seen in the case that the child was hurt and it was not just anger. So understand the consequences of the anger. We have to make the adolescent understand the consequences and how he should manage that anger. And then we have to learn healthy ways to express the anger. The anger is there. You are angry, I am angry. Everyone can be angry at one time. It's not that we can never be angry or our life can be devoid of anger. But if we are angry, we should be able to manage it constructively, positively, to get the best out of it.
Yes,
And
but why actually we have to focus on anger? That we have to understand. See, anger is a common emotional challenge, particularly during adolescence. And poorly managed anger can lead to various issues like at family level, at school level, your peers, friends, violence, aggression, and risk-taking behaviors even, including substance use. And it can lead to serious mental health consequences as well. So anger often represents it is a behavioral problem, and it can lead to academic decline, somatic complaints, and even family distress due to various issues.
so what is anger? Anger is the manifestation of many things. Like there is some threat, or there is some event, or there is some perceived threat, or the child is frustrated, or there is some injustice. The child feels that all the time somebody is given award and he is not receiving that award, he is not becoming first ranker, purposefully he is given some good mark, or he is rejected in the peers or rejected in the family, and he feels that he is a failure, and that leads to anger. So in fact anger is important purpose because that makes that person to understand that something wrong is going on, because there is some hurt, or he is ignored, or there is injustice or rejection, or some obstacles are there, and he has to take some action. This is the sign for that person. So it has to be there.
So physical pain indicates, it signals the physical injury. Similarly, anger indicates and signals emotional distress. We all have to understand that. So it is okay to become angry, but hurting others or by inappropriate time, person, place, and severity is not okay. So how we respond to anger is very important. It is like a fire. We can use it to cook some food or do something good, or it can burn the home even. So uncontrolled anger leads to aggression, violence, and its consequences obviously. And proper anger expression, it really needs courage, purpose, as it can lead to positive change. Like during our freedom fighting also, there were Bhagat Singh, Sukhdev, Rajguru, there are so many examples. So the question is whether we use this anger to build something, to do something constructively, or to destroy it.
So when we should be alarmed and we have to interfere, we have to guide the child. So when the anger leads to some verbal abuse, the child starts saying some bad words, child starts behaving in some wrong way, the child starts bullying somebody because of anger. The behavior is threatening that he is throwing the things, he is throwing mobile, he is throwing the books and his school bag and everything. There are physical fights with his friends, or there is destruction of the property, he is just breaking TV or something like that. Or there is danger of self-harm, he is injuring self, or there are suicidal thoughts, and there is violence. So those are the alarming signs, and we should interfere. So how it is going to affect unmanaged anger can lead to the disturbed relationship, it can lead to arguments and disturb family atmosphere, or it can change the physical health. There can be headaches or psychosomatic problems, or there is high blood pressure, sleep disturbances, disturbed digestive system, and all physical health is disturbed. Then emotional well-being is also disturbed. It can increase the stress, anxiety, sadness, and it lowers the self-confidence. So these are the many changes, and then we have to take action.
So, but why adolescents, even we as adults also become angry, but why adolescents are more vulnerable? Because already it was told in the skit that prefrontal cortex, CEO, is not still developed, and their emotional brain takes over the thinking brain, because still it is in the developing phase. It's like a turbo car with excellent engine, but it is not having brakes. So this is very important that we, as an adult, we have to understand that why they are गेटिंग मोर अँग्री यंग मॅन. अमिताभ बच्चन एका वेळेस तर खूप मोठं त्यांनी त्या काळामध्ये खूप अँग्री यंग मॅन फेमस होता.
So that the factors which contribute is academic pressure. The child might not be coping up with that studies, or the child might be having learning disability or something like that. There may be peer pressure. The friends are forcing him to smoke, or friends are making him to bunk the school, or they are giving wrong decisions. There can be family conflict. The child is pressurized, the child is compared with somebody. That's why the child is upset. Or unrealistic expectations from the family, as we have seen in Sangeeta's skit. It was beautifully presented. Then excessive criticism. Many times criticism is there. You cannot do this to us, as there are labels. Social media influences. Many times social media is influencing everyone's life very badly. Then cyberbullying, lack of sleep. Cyberbullying, child wants to just post, I'm here, I'm there, and then the cyberbullying starts. And underlying emotional distress is there. The child is emotionally upset. So anger is just iceberg, and there underneath it's fear, hurt, shame, loneliness, rejection. So many times anger is not the primary emotion, but we have to find out and peep inside the child's world.
Yes, it's the tip of the iceberg. So something is lying behind. So how to express anger in a healthy way or proper way is very important, and for that we need emotional literacy. It is the ability to identify, understand, express and manage our emotions in a healthy way. Because we have to acknowledge, we must acknowledge our own emotions, and we should learn to identify exactly what is that emotion, and we have to understand why that emotion came, exactly what happened because of that it came, and we have to learn to express in a proper way without hurting other person, and we have to learn how to manage it. So emotional literacy is very important, and it's okay to become angry, and we have to become aware of our own self emotions. That is very important part, and it is first step towards emotional regulation.
So 3 important steps which we should know, that identify why you are feeling angry. Am I feeling hurt? Am I feeling frustrated? Am I feeling disappointed because of something? And check in yourself which emotion is underlying this. So name your emotion is the first step. Then understand why you are feeling like that. So what was the trigger? What triggered this emotion? And it is what situation created this anger? What is really going on? and what do I need at the right now, what outcome do I want, and then express it. Express it assertively in a positive way and not suppressing it. I feel upset because this happened. So use I statement, be honest, and it's not about the feeling but handling the emotion. So name it to tame it. Name the emotion so that it will be tamed.
So we have already understood that amygdala takes hijack of our brain, and that's why they are not able to control the anger properly.
So psychomotor effect is, these are the physical signs: clenched fist, then muscles become contracted, there are increased body movements, tremors and sweating and all those things, throwing objects and slamming doors, and all these things start happening.
So already we have seen pause technique, 6-second pause technique, and it really breaks the cycle, and that time 6 seconds is very important when that hijack can be paused.
So we have seen that how the anger is expressed, and these are the destructive ways, but constructive ways, the one should calm down, assertive voice should be there, then setting the boundaries, respect yourself as well as others, then problem solving should be thought about, journaling, write down why you are angry, then seeking support and physical help.
So these are the do's and don'ts. What to do: recognize our triggers, practice deep breathing, use 6-second pause, express emotions respectfully, engage in regular physical activity because it leads to happy hormone release, maintain healthy sleep habits, it is very important, talk to trusted adults, focus on problem solving and develop emotional awareness. And these are the don'ts. We have already seen.
So social media's effect is very long lasting because it just doesn't end after school hours, it continues 24 hours.
So what is the role of parents and schools in emotional development? So we all should become role model.
Sorry ma'am, 15 minutes are up.
Yes, last one slide. So it is first, we have to become the proper role models, and because children and adolescents learn by seeing. Whatever we tell, it is less likely that they will follow, but whatever they see, it is more likely that they will follow. So respectful communication is very important, and we have to teach them how to do the conflict resolution in a constructive way, and supportive school and home environment is very important. Empathy, patience and respect, these are the things which are we have to follow, and we have to help them to follow, and consistent guidance is the key.
So anger is normal and violence is not. Anger, aggression and violence. So anger is normal. Learn to understand and manage the anger effectively. Develop emotional awareness and self-control. Practice 6-second technique and all assertive methods. Then build resilience and well-being. And managing emotions today prevents problems tomorrow. So 6 seconds of pause will prevent 6 hours of regret.
So the goal is not to eliminate the anger, but the goal is to understand it and express it in a proper way and appropriate way and manage it wisely. And develop the emotional literacy and emotional intelligence, empathy and self-regulation skills, which are all part of life skills education. Sir, ते दुर्गा मातेला कसं 10 हातामध्ये 10 आयुध असतात, तसे ते लाईफ स्किल प्रत्येक हे इम्पॉर्टंट आहे, आणि आपल्यालाही ॲडल्ट एजमध्ये इम्पॉर्टंट असतं. अँड वी आर हॅव्हिंग लाईफ स्किल्स एज्युकेशन प्रोग्राम थ्रू आकी अंडर द गायडन्स ऑफ डॉक्टर स्वाती भावे मॅडम, आणि त्यांचं अँगर मॅनेजमेंटचं बुकसुद्धा आहे. अँड टाईम आऊट टेक्निक हे एक फार इम्पॉर्टंट टेक्निक आहे. कोणीही चिडलं की आपण सगळे चिडलेलो आहोत, आता थोडा आपण टाइम आउट घेऊया, तुझा तुझ्या रूममध्ये, मी माझ्या रूममध्ये जाते आणि थोड्या वेळाने भेटूया.
सॉरी मॅम, वी आर रनिंग लेट.
थँक्यू.
Unmanaged emotions have lifelong consequences. So life skills education is the key. Thank you.
Thank you, Dr. Shailaja Mane, Kulkarni madam, for giving. The anger is okay, but hurting others is not okay. Building resilience is your message. I will request my co-chairperson to say a few words.
Well, anger is one of the common behavioral issues. As you said, it is because of the excessive maturity of the amygdala. And whatever the problems used to solve this is the reverse way, you try to mature the frontal cortex by understanding, admitting.
Yes.
So, before amygdala takes upper hand, better we promote a frontal cortex so that it suppresses the amygdala.
Yes.
Thank you.
Very well summarized, sir. Thank you.
I now request Dr. Uday Bodhankar sir to talk about underage driving, which is becoming more prevalent, sometimes with fatal consequences.
Thank you, Dr. Chitra, Dr. Mr. Ingre, Mr. Bhandakar for following with me with these slides. Though this topic is very new and important, I would like to finish in 10 minutes. This is regarding underage driving, parental liabilities. In this, we are going to see legal, social and safety perspective. Next slide, please. Next. अच्छा, यहाँ से करना पड़ेगा. So, बोलिए.
Yeah, actually I'm not able to stay for the inauguration, and because the flight, I have to leave. I wanted to thank each one of you, Dr. Chitra and everybody, all the elders here for giving me an opportunity to come to this place. And I remember Dr. Jayant was the first person to start the state conference concept, and you all are doing so well, all the very best. Thank you so much, sir. Thank you for giving an opportunity.
Thank you. Thank you, Hema Bindu. Always you have been source of inspiration to all in AHA, like Swati Bhai. Going ahead, in introduction, if I would like to say, one thing is underage driving means what? It is nothing but driving below legal age. It is a major public safety concern in India, and it leads to accidents, fatalities, leading to legal consequences. Now coming to legal driving age, I have recently updated myself. As you all know, 16 years, if it is there, then it is gearless two-wheelers with parent consent is important. If you go to age 18 years, it is only cars and motorcycle. If you go to 20 years, it is commercial vehicle. Now, we'll look into matter why underage driving leads to accident. You all know it is a lack of risk perception. There is no formal training to the teenage girl, peer pressure, thrill seeking, and helmet non-use, safety neglect. Now, why underage driving is dangerous? I think you all know very well. It is nothing but the immaturity and poor judgment of the teenage, risk-taking behavior by this teenage, lack of training and peer pressure. Now, you will be surprised why underage driving leads to accident. This is the evidence. You can see that recently, if you see youth crashes linked to overspeeding and violence, alcohol, more than 60%. Majority victims were male using two-wheelers. If you come to age pattern in accident, it is higher death has been found in young adults from 18 to 35 years. Teenagers also significantly affected. Under 18 group where more than 8% fatality. Now, this is very important take-home message for all of us, including parent, doctor. If you want to see traffic rule and fine for minors, you all know our own Nitin Gadkari. He is a minister since more than 12 years. So he has revised all the penalties. It is governed by Motor Vehicle Act, which was amended in 25, which are for strict provisions for juvenile driving as well as owner and parental authority. Now, if you would like to say, it is section 199A, which is key provision, which says parent or guardian has been held responsible for any of the crime committed by the teenager. It is also held that presumption of consent, negligence. It applies when minor commits offense. Parents are legally accountable under law. Now, what are the penalties which have been revised recently? 25,000 rupees is the fine. Imprisonment up to 3 years. Vehicle registration has been cancelled for 1 year. If it goes ahead continuing this, then minor may be barred from license up to 25 years. In addition, strict penalties have been enforced to deter violations. insurance, this is very important. Insurance implication, if you see that, insurance claim may be rejected because it is teenage driving. Financial burden will be there on parent. Compensation liability in accident. Now, coming to clinical public health perspective, if you see this, which are the common injuries which are happen to the teenage while driving. Head injury is the most fatal, polytrauma, long-term disability. In addition, economical impact will be there, loss of young productive life which has been calculated, huge healthcare burden, and national loss which is more than 90,000 crore has been said annually. What is our social responsibility if you want to touch on that? Parents, they should be as a role model, as many of the people here made a role skate. Early education on road safety is important. I have told Dr. Kotwal Dabatkar that what we role here, it should be shown to all schools, all the theaters, so that public awareness is there. Early education on road safety, discipline and supervision. Now, parental, after social responsibility, what is parental liability? These 5 ways to safer teen: no cell phones, no extra passenger, no speeding, no alcohol, no, always buckle, always have the helmet or always have the belt. Allowing minor to drive is the offense. Even negligence can lead to punishment. In addition, criminal plus financial liability can be there on parents. What is the role of schools and safety? If you want, as I told you, awareness campaign should be there, traffic education should be there, collaboration with authorities should be there. Now, role of medical profession like AHA doing great job all over India, including Maharashtra, everywhere. So, trauma risk should be explained to parents, to the people. Counseling of the parent is important, as you have done counseling very well in all the states. Advocacy for prevention is very important, which has been, should be taught in the, I think our school curriculum should be changed with this type of thing. I think that even medical curriculum should be changed. If you want to see what Maharashtra, India, facts and trends are concerned, overall road accident burden, 4.5 lakh accident annually. Out of that, 1.5 lakh deaths are official data. If data for India, if is concerned, road accident leading cause of death in youth, 15 to 29 years. Major group is this. Around 1,300 accidents had been there with 474 deaths per year. So this is what is, I think, take-home message. Major contributor in this is overspeeding, drunk driving, two-wheelers, which has got 45% death. Again, if you want to see current scenario in Maharashtra, I will take 1 minute. Maharashtra record 8% drop in road fatalities in first 3 months of 2026. Over 2 lakh has been booked for helmet riding. If crackdown work has been done in Maharashtra, in Nagpur, everywhere, it has found that about 65% of the fatal accident has come. In 2026, January to March, 9,000 to 259 accidents had been there, but take-home message good is there is 8% reduction in death due to sick enforcement. This is again Maharashtra, India fact. And in Nagpur, basically being from Nagpur, fatal accident had been reduced significantly after crackdown from 25 to 26 April. There is a strong action has been taken in Nagpur, Maharashtra, against drunk driving, underage driving, FIR filed against parent of minor and strict implementation of law. So, preventive measure, if you want to ask me, do not give vehicle access to any teenager less than 18 or less than 16. Keep keys secured at a place which is not accessible to teenage. Promote public transport. Encourage legal learning age. Key message: underage driving is a major contributor to preventable accident. Maharashtra is significantly affected. Strongly enforcement shows clear reduction in death. Parents play a critical legal role. Now, in conclusion, underage driving, as you all know, is not just an illegal, but it is a preventable cause of death among India's youth. Strict enforcement, parental responsibility, And awareness can cause thousands of lives can save every year. If you know driving is a preventable hazard, parents should be the key stakeholder and strict laws aims to save lives. So I think this is what we want to say. ये बच्चों का खेल नहीं, so I think you won. Thank you very much.
Thank you very much, sir. I now invite Dr. Jitendra Gawane. This session is supported by an academic grant from Bharat Biotech. He is a professor and PICU in charge of MGM Medical College, Kamote. He's going to talk about the new cholera vaccine. I request Dr. Uday Bodhankar sir and Veerana Kotrashetty sir to proceed for felicitation.
Yeah, good afternoon everyone. So today we will discuss about the new kid on the block, that is a cholera vaccine. We all know the pathogenesis of cholera, that organism is a comma-shaped gram-negative rods which thrives well in a contaminated water. The pathway is after ingestion it tolerates the acid environment of the gut and goes into the small intestine where it penetrates into the mucosal layer and where it forms a microcolonies. And those all microcolonies secretes the toxin which is liberated into the intestine again, and that causes a profuse watery diarrhea. We know that it is a catastrophic kind of diarrhea, and child can go into hypovolemic shock in 2-3 episodes of the purging itself. So it is a very killer disease, and there is a resurgence of global threat. 24 outbreaks has been, active outbreaks has been described, and 1.3 to 4 million annual global cases are reported worldwide with 1.5 million deaths. So that is almost 1/3 of the deaths are there with the cholera, with a large economical burden. And there is a global task force for cholera control which mandates the 90% control of the cholera deaths by 2030. Okay? So this is very difficult dream. India also faces challenges as there was an outbreak in just 2024 in Nanded. Odisha is a chronic carrier of cholera. There are Indore and other districts of Madhya Pradesh also reported the cases. So there is a surveillance happened in India where 12% of the population showed the antibodies against cholera. That means it is very much there. And it is not just a urban, rural disease. It is in Ahmedabad. Ahmedabad also reported many cases, 400 cases in 3 years due to aging of water infrastructure and sewage infrastructure. So all these are the pockets in India. This is the only disease where south is more contaminated than the north. Otherwise we see up-down trend. Here south cases are more. So there is an easy way to prevent this diarrhea and treat diarrhea also. So wash, what we say is washing of your hand, the sanitation and the hygiene. All these three contributes major prevention of the diarrhea along with a reliable oral cholera vaccine. Now there is a oral cholera vaccine already are there, few of them are there. In India there is one licensed WHO qualified vaccine available. The problem with that is the supply demand mismatch is there. The global demand is of 110 million doses, whereas the actual supplies in the world over is only 40 million doses. Out of that, 20 million doses are required in India itself. So there is a huge gap. The root cause of this is a manufacturing problem. The conventional, what we have, the vaccine, is cultured with 3 to 4 different bacterial strains separately on bioreactors. And there is an inactivation of those biocultures with different process. So it is a very cumbersome process. There is a Ogawa and Inaba strains which are not stable strains. So if we look at the microbiological target and serotype antigen, the cholera what we describe as a classical cholera where first 6 outbreaks or pandemics of cholera 1 to 6 are classical what we tell, and 7th one was a LTOR where it happened in a quarantine station in Egyptian population where the Hajj pilgrimage coming from Egyptians were quarantined, and in them the pandemic spread, and that was a LTOR in everyone, like whether it is a classical or LTOR, there is either Ogawa strain or Inaba strain. How to differentiate? These are not different strains. These are just looking at them microbiologically. If there is a methylation, then it is called as Ogawa strain. If there is no methylation, then it is Inaba strain. There is an in-between strain called as a Hikojima strain. Now this Hikojima strain has a specific genetic, specific gene which makes this Hikojima very unstable. So on one end, it either goes into Ogawa category or it goes into Inaba category. So when methylation power of this gene goes down, then it becomes Inaba. So in a pandemic stage, where population is acquiring a natural immunity, it immediately drifts to the opposite strain. So culturing this and making the vaccine against this was very challenging job. So genetic engineering was a breakthrough, and what they did here is this particular gene on the Hikojima strain, that is WBET gene, which I was talking about. What they did is they partially point mutated that gene. Now, after point mutation, this gene lost the ability of totally going into Inaba strain, and it retained the half of the activity going into the Ogawa strain. So we have a combination of Ogawa and Inaba both, which is stable now. So this is a genetic change which has happened. The legacy or previous vaccines were 3 to 4 independent strains were required. Now we require only one stable Hikojima strain, which is genetically modified. Then antigen expressions also were difficult in legacy cholera vaccines like Shankol and all. But here, simultaneously, Ogawa, Inaba expression is occurring 50-50%. Inactivation, multiple inactivation methods were used for common conventional vaccines, whereas only single formalin inactivation protocol is there. And production scaling, because it is a simple process after genetic engineering, it is a now production is a simple process, highly streamlined, low cost, higher yield, large amount of doses we can produce, so to cater the world population. And it has gone under preclinical safety validation on rats, mice, and white rabbits, followed by the stage 3 clinical trial, which is a large enrollment of around 3,000 odd cases which are enrolled as a arm 1, which received the Hilcol vaccine, and Shankol was given to almost 450. And here what the study duration was 6 months, and they proved that immunogenicity is equivalent to that of Shankol, and it is a non-inferior to Shankol for the seroconversion. At the same time, safety profile also was studied, and safety profile also was very good and non-inferior to the Shankol. So here it is a ampule of 1.5 ml, which is given on more than 1 year old children on day 1 and day 14. So 2 doses are required, and from 1 year onwards to any age we can use this, which contains 900 micrograms of LPS per dose. So to summarize, Hilcol is a revolutionary fight against global cholera. So all these 4 million annual cases can be controlled with WASH, and introducing or scaling up this Hilcol vaccination across the globe to meet the WHO 2020 goal, that is 90% reduction in cholera deaths across the globe. Thank you.
Thank you so much. I request Dr. Jitendra Gawani to proceed for felicitation. Now I request Dr. Sunita Inglam, who is a chairperson AHA Raigad, to conduct the prestigious ceremony of inauguration.
A very good afternoon to all. To formally welcome our gathering, we are proceeding with the auspicious inaugural ceremony now. May I request Dr. Chitra Kulkarni, Organizing Chairperson of MAHA AHacon 2026, and the Chairperson of MAHA AHA, to escort to the dais and welcome with a floral bouquet our Chief Guest, Dr. Ruchira Maheshwari Gupta, Honorary Secretary General of Central IAP, as well as special inaugural guest, Dr. Vinayak Patil, President-elect MAHA IAP. Dr. Sushma Desai also was here, but she has left already. Okay. Now I will request Dr. Vaishali Shirsetti. Please wait on. Dr. Vaishali Shirsetti, Secretary MAHA AHA, to escort to the dais and welcome with floral bouquets Dr. Shamik Ghosh, Secretary Central AHA, and Dr. Renu Boralkar, Secretary MAHA IAP. Vaishali Shirsetti, ma'am. Dr. Shamik Ghosh. Dr. Renu, Dr. Vaishali Shirsetti to escort Dr. Renu. And welcome with a floral bouquet. Dr. Shamik Ghosh, he's come. Okay. Now I request Dr. Neha Singh, Secretary IAP Raigad, to escort to the dais and welcome Dr. Piyali Bhattacharya, Chairperson-elect Central AHA. Yeah. I request Dr. Vaishali Shirsetti to welcome Dr. Shamik Ghosh. Now I request Dr. Chitra to welcome Dr. Sushma Desai. Madam, please come on the dais. Dr. Neha Singh to escort to the dais and welcome Dr. Piyali Bhattacharya. Okay. I'll request Dr. Vijay Kamble, Professor and Head of Pediatrics MGM Hospital, Organizing Secretary of the conference, to escort to the dais and welcome our MMC observers, Dr. Shrikant Tulsidas Dahake, and who's for today for the physical meet, he's there, and Dr. Hemant Gangolia for the online CME. Dr. Kamble, sir, please come. Dr. Gangolia, sir. You come on. Gangolia, sir. Now, yes. Now I request Dr. Chitra Kulkarni to escort and welcome Dr. Uday Bodankar, sir, on the stage. Music. इकडे. Huh? Yeah. Now we will proceed for lamp lighting. Please, I request all the dignitaries to go ahead with the lamp lighting. Dr. Chitra Kulkarni to invite Dr. Pandrikar sir. Of course, sir, you're welcome. Dr. Samir Shah, sir. Dr. Jitendra Gawane. Kindly proceed for the lamp lighting. Yes, sir. नहीं सभी इथेच ठीक है. Thank you.
या कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युत शङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा.
Now I will request all the dignitaries to be seated in the front row, except Dr. Chitra Kulkarni.
Good afternoon on this humid Sunday. It's very hot outside and this is lunchtime, we all know. But again, welcome to all the esteemed Central IIP, Central AHA and Maharashtra IIP dignitaries along with MGM Medical College Kamothe HOD Dr. Vijay Kamble sir, Dean Dr. Nar Shetty and Registrar Dr. Rajesh Goyal in absentia. Because of packed academic activity, we had split the inauguration in two parts, just to increase our academic quotient. We yesterday did in the cozy environment in evening, President and Secretary report, Treasurer reports by MAHA AHA Secretary Dr. Vaishali Shirshetty. We had faculty felicitations and an important event of presenting Lifetime Achievement Award to senior pediatrician from our Raigad branch, Dr. C.S. Dabhadkar sir. He is present in the auditorium. I request sir to come in front. May I request Central IAP Secretary General Dr. Ruchira Gupta Maheshwari to present the citation to Dabhadkar sir.
Hello.
Please, madam, here.
Dear friends, today I am feeling. So friends, it is a matter of proud privilege for me for being here present today on this occasion of festation of none other than Dr. Dabhadkar sir. It's a lifetime achievement award for him. And for me it is a special because he was my vice president when I was executive board member in 2019. Oh, no. He is very nice. He used to put in very valuable, very valid suggestions, and that was very visible to all of us, sir. So it was never felt or perceived as if it was a fight. So it is, again, I'm totally delighted, and I feel this is the best part which I could have done in this year. Thank you very much.
Thank you so much.
Thank you.
Now I request Dr. Renu Boralkar, Secretary MAHA AHP, to give her blessings. Dr. Renu.
Namaskar, good afternoon. Respected chief guest, Dr. Ruchira Maheshwari ma'am, who is a great friend, has come long way from Delhi to our own Maharashtra and Mumbai. So we welcome you ma'am. Special inaugural guest, Dr. Sushma Desai ma'am, chairperson Kaha. Dr. Chitra Kulkarni ma'am, who is the dynamic conference chair of current MAHA AHAcon. Dr. Vaishali Shirsetti, Dr. Piyali Bhattacharya ma'am, who is also a great teacher. Dr. Narsetti sir in absentia, Dr. Shami Ghosh sir, Dr. Neha and Dr. Sachin, and all the respected seniors, our Mahapitama, Bhishma Mahapitama, Dr. Bodhankar sir, Dr. Dabhadkar sir, Dr. Pandrikar sir, Dr. Vinayak Patil, my president-elect of next year. So on behalf of MAHA AHP, I, Dr. Renu Ajay Boralkar, Secretary, would like to congratulate all the organizing team members of IAP Raigad and IAP AHAcon, who has organized a very excellent conference. It's my great privilege. The adolescence is a period of immense opportunity, growth and vulnerability. The health and well-being of our adolescents can't be shaped within the clinic walls of our pediatricians. As pediatricians, we must build a bridge builders and connect the healthcare with families, schools, communities, policymakers, and most important, the adolescents themselves. Our vision is to strengthen the adolescent-friendly healthcare, and the services should be promoted with the help like the life skill promotion, mental health education, empowering the parents through awareness, and advocate for safe as well as supportive environment. And we should collaborate as a pediatrician with the stakeholders like the governments and the social organizations to address the nutrition, substance abuse, the suicide prevention, the digital well-being, and the reproductive health. Since yesterday, we have a very great all type of self-defense where workshop was there. Then there were two different workshops were there for the adolescent, and it was a very good learning by all of us for in a new way. And since this is the second year of the MAHA AHAcon, I think it is in the infancy, has just turned over, and it is the first birthday has come, because last year it was under the guidance of our Mane ma'am at Pune. She had done very well. So ma'am, congratulations for you starting, and it was a West Zone plus a MAHA AHAcon that time. So congratulations for starting the thing, and next year I think it is in Amravati where our own Pandrekar sir is there. So on behalf of MAHA AP, I congratulate all the team members, and today let us create a Maharashtra where every adolescent is heard, supported, protected, and empowered to achieve their fullest potential. Let us transform the challenges into the opportunities and nurture a generation that is healthy, resilient, confident, and future ready. So it is very appropriate, the theme, building bridges, empowering adolescents, shaping tomorrow. I thank you from the bottom of my heart to inviting me on the stage. Jai IIP, Jai Maharashtra.
Thank you so much, Dr. Renu. And now I call upon Dr. Sushma Desai, Chairperson IIP AHA, to give her blessings.
Very good afternoon, respected Dr. Uday Bodhankar sir, Dr. Dabharkar sir, who is my favorite as well, all the office bearers of Central AHA, Dr. Piale madam, Dr. Shamik Ghosh, Dr. Jayant Pandrekar, Dr. Samir Shah, all the AHA office bearers of Maharashtra. I am so very proud of them. Dr. Chitra, particularly, I'm so very proud of you, Dr. Boralkar, and all the team. That's Dr. Sangeeta, who is also an office bearer. And that's a kind of, it was meeting, Maharashtra family was always looking forward to for me, and I'm so very happy to meet you all, seeing you all in action, and that too much of dynamism, the comradeship, I would like to say, and a family feeling. That's really hatke, and that has influenced me, touched me to the core. And I'm so very happy to see my really good friends, Dr. Shailaja, who herself is an office bearer of Maharashtra AHA, Dr. Vaishali, and this is so much a, family gathering beyond words. Before I say anything, I would like to not only congratulate, but appreciate from bottom of my heart, Dr. Chitra ji. It is so very well organized, well thought of, and well planned conference. It has matched the standards of central or national conference of AHA. So it is really impressive. Everything, I would like to say not up to the mark, but beyond that mark. And I personally congratulate the entire team, including you also. And another important thing is, there is no one like, ye dikhayenge to main karunga ya karungi. Everyone is doing something on their own. Ye mera hi kaam hai. So that is what a team spirit is. And I personally congratulate Chitra ji to maintain that team spirit in your team. That's really, praiseworthy. So I look forward to have more and more scientific programs because these are so very well chosen topics as well. And the topics of the workshops were also very unique. and it was conducted very well. Unfortunately, I could not be a part of them, but I have heard a lot about it. And that speaks volumes about the success of your scientific program. So it was so unfortunate I could not be a part of MAHA AHA conference last year under Dr. Shailaja, but I think, that will always be like a, for me. But this workshop and this conference has matched up all the standards, and we look forward to more and more such scientific sessions, the innovative one, all intercepted with an excellent role players, and the very, very, thoughtfully chosen topics. Dr. Chitraji, I congratulate personally all of you, and my heartfelt best wishes are there with my MAHA AHA team, and we look forward to having all of you there in full colors at Jaipur National Conference. Thank you so much for having me here. Thank you.
Thank you, ma'am, for your kind words. Now I request our chief guest, Dr. Ruchira Maheshwari Gupta, Honorary Secretary General, Central IIP, to give a speech. It is there? Yeah, I'll request ma'am to release our e-souvenir. Please come on the stage. This e-souvenir has been compiled by Dr. Neha Singh, who is the Secretary of IIP Raigad and AHA Raigad too. And single-handedly, she has done all the editing work. She really needs a big round of applause.
Come forward. It indeed is a pleasure to release this souvenir today, and as told by whole Maharashtra AHA team, the person behind it, none other than Dr. Neha. Only and only. So big round of applause. Congratulations, Team MAHA AHA and Neha. MAHA AHA and Neha. Wow. So it's a good, yeah. Excellent, excellent. Thank you. Respected organizing chairperson, Dr. Chitra Kulkarni ma'am. The convener, Dr. Chandrasekhar Dabatkar sir. Organizing secretary, Dr. Vijay Kamble. Central Adolescent Health Academy chairperson, Dr. Sushma madam. Chairperson-elect, Dr. Piyali Bhattacharya. The secretary of Central AHA, Dr. Shamik Ghosh. And the legend from Central AHA, Dr. Sameer. Maharashtra IAP President, Dr. Joshi, in his absence, but our very young and vibrant leader, the Secretary of Maharashtra IAP, Dr. Renu Boralkar. Team IAP Raigad, the organizing treasurer, Dr. P.B. Jain, organizing chairperson, none other than our own Dr. Gangolia. Dr. Gangolia is doing dual purpose. Co-convener, Dr. Jain Parnikar, the great and humble person I have ever met. Dr. Vinayak Patel. Co-organizing secretaries, Dr. Jay Kumar Bhandarkar and Dr. Vaishali Shir Shetty. Co-organizing treasurers, Dr. Sunita Ingle and Dr. Ram Bharat. Dear colleagues, dear friends, postgraduates, and members of Indian Academy of Pediatrics, a very good afternoon to everyone. It indeed is my pleasure today to be standing here on this historic city of Raigad, a capital of Maratha Empire and a seat of coronation of Maharaja Chhatrapati Shivaji, whom we all are proud of, all Indians. Dear friends, I would like to congratulate this team of IAP Maharashtra for organizing such kind of platforms where young minds can interact with the experienced experts and the faculties over here to discuss important issues in the field of adolescent. Not only that, to have mentor-mentee kind of association, innovation, collaborations and all that. So yes, these platforms are much needed. Dear friends, today we have gathered here for adolescents' health. This reminds me of Chhatrapati Shivaji. He was a great visionary leader. A leader who's great is not formed in a day. Behind that leader stands the support of their parents, mentors, teachers, and the society as well during their youth time or adolescent time. Same way, the great vision and dedication and leadership in Chhatrapati Shivaji Maharaj was embedded in him during his foundation years, that is during teen years, by none other than his mother, Jijaji Bai, and other mentors. That's why it is important to discuss adolescent health today. Every adolescent whom we are seeing today can be tomorrow's Shivaji, can be tomorrow's leader, politician, scientist, teacher, doctor, engineer. So our responsibility is enormous. When we are talking about Indian Academy of Pediatrics, we know that Central keep on doing a lot of activities. And it is the academy which has the maximum number in any subspecialty chapter. So a big round of applause for Adolescent Health Academy and its leadership and its members, because an academy becomes successful when the members, they are very active and doing great job. when we are talking about Indian Academy of Pediatrics at national level, with the lot of persuasion from Central AHA, we are happy to announce, rather we already have started celebrating 18th day of every month as Adolescent Health Day. It is a big thing. Coming from leadership directly to have such kind of thing where every day in a month is being celebrated as Adolescent Health Day, that shows that IAP is also moving towards the future leaders, foundation of future leaders. And that's what is important. Dear friends, IAP under the leadership of our current president is doing a lot of activities in all the dimensions, be it academics, be it extracurricular, be it cultural, be it research, social, charity, everything. Recently, we have come up with a research fund. So, those who are teachers or the postgraduates who are sitting over here, I want to convey this message to all of you that IAP has come up with a research fund of 50 lakhs rupees this year, in which we want to promote postgraduates, undergraduates, practicing pediatricians who do not have that kind of environment or the support system to come up with the research. They have a lot of ideas, enormous ideas, but what do they need? They need the support system. Somebody to just give a slight push. For that, IAP is ready to do so. And we request you please share your ideas, you please share your research projects with us. We will support you with some financial sponsorship as well as we have got our ethics committee. So it will be all proper way the research happens, that will be done. Now, my two friends, Dr. Sangeeta Lodha and Dr. Shalja Mane, they are sitting over here. I can see a lot of legends sitting over here in this crowd. Those who already are doing a lot of work in the field of research and adolescent health. Not only this, I request you, all of you, to kindly do social activities, the charity activities, and whatever charity activities you are doing, I request with folded hands to all of you, kindly report to Central IAP, because that needs to be uploaded on Central IAP channel as well. Not only this, for post-graduations, as we say, they are our foundation, they are the future doctors who will shape the nation in terms of medical health. So whatever information, whatever kind of shaping we are doing during their foundation years in medical profession and during undergraduation and post-graduation, that will be reflected when they will be practicing. So what we need to do is that we need to have a PG or a UG who is having clear basics. Then latest all updates can be made subsequently. For that, we are coming up with a program called IAP Master Classes Pariksharthi, which we will be holding it in 5 zones, all the 5 zones of Indian Academy of Pediatrics, where the top teachers, the known faculties, they will be traveling to one zone, and the students, final year students across the zone from all the states, they will be invited. They have to be only their travel and stay. Rest everything will be borne by Indian Academy of Pediatrics. So this is a welcome. I think this should bring a change. If I have studied in Uttar Pradesh, then I had exposure of Uttar Pradesh only. When I moved to Delhi and I was in Safdarjung, then my exposure changed. Then when I moved to other place, I went to Singapore for a training course, my exposure changed. So this is a change. And same way teachers, the way they percolate their knowledge, that brings a change. We have started with IAP Digi under our president, Dr. Neelam Mohan, leadership. I request you to please actively participate in it. And if you want to be actively coming with any project on IAPDG, you are most welcome. Not only this, we also are coming up with IAP National Digital Library, where all the discussions, the topics, the scientific programs which have been done on digital platform that will be archived. Anybody can see them as per their convenience, and also we are buying the prescriptions of very reputed international journals, which will be free for all the members of Indian Academy of Pediatrics. So yes, this few things other than academics modules and all, which is a regular process which we keep on doing. Dear friends, coming back to again adolescent, I really want to say that these kinds of platforms which are talking only about adolescent health, it is important. That is happening on the city of Raigad. That is, Raigad is an inspirational city, I will say so. And the legacy of Chhatrapati Shivaji, we need to, it symbolizes the leadership and the vision. Same way, adolescent health symbolizes that foundation of young leaders is laid down during adolescence, because every Shivaji begins as a youth, as an adolescent. That is important, and I request you all to kindly get maximum interaction in such kind of sessions. And as Adolescent Health Academy doing Nukkad Nataks and all that, I mean, you are really praiseworthy. Whatever you do with your vibrant way of doing it, different energy, it is very contagious. And I'm sure that this one day program of Maharashtra AHA will be very beneficial, and a lot of take-home messages can be taken back home, and such kind of more deliberations are needed, and I'm sure that will be on the way. With this, I would like to thank you for having me over here, and I want to tell you one thing, that whomsoever you know who still is not IAP member, I request you, all of you, to kindly pursue them, request them to become IAP member, as currently we are the second largest organization of pediatricians in the country, in the world, and the largest in the country. But we want to be number one, as India is the leader now at global front. So same way, let IAP be the leader in terms of maximum number of pediatricians as its member. Dear friends, thank you very much, and I'm just a phone call away. Anything, anybody, I can be of any help, just give me a tinkle. You will find my response immediately. If not immediately, then definitely within 24 hours, I'll be there to respond you back. Thank you very much. Jai Hind, Jai IAP, Jai Maharashtra, Jai Raigad, Jai Chhatrapati Shivaji. Namaskar.
Thank you. Thank you so much, ma'am. That's really very inspiring for us. I will now call upon Dr. Vaishali Shirsetti, Secretary, MAHA AHA, to give vote of thanks. Over to you.
Good afternoon, everyone. It gives me immense pleasure to thank you all regarding this. First of all, I would like to tell that actually this is the second time we are conducting AHAcon. Initially, it was said to be Maharashtra AdolesCon, but this time Central IHA has asked us to change it as a AHAcon. So last year it was done at DY Patil Pune under the chairmanship of Dr. Shailaja Patil, all the time guided by Dr. Pandrikar sir. Second time we are conducting this AHAcon at MGM Navi Mumbai Kamothi. So I am really very happy that Maharashtra is the first state who is conducting such kind of AHAcon for adolescent only, and the other states will be also following this. So many thanks to Pandrikar sir that you have initiated this. I would like to thank Dr. Neelam Mohan madam, Dr. Ruchira Gupta madam for her pleasant and encouraging words. Dr. Sushma Desai, who is a chairperson of Central AHA, Dr. Shamik Ghosh, Dr. Piyali Bhattacharya, Dr. Hema Bindu Singh, Dr. Shailaja Mane, and Dr. Bodhankar sir also. Thank you, Dr. Renu, for giving those encouraging words also. I'm very much thankful to all who were present for yesterday's workshop and Dr. Shubhada, another one who has conducted the workshops very well. Even the public forum program was very well conducted by Dr. Amal Andadate at Vasudev Balwant Phadke Sabhagrah yesterday. So those two workshops as well as the public forum program was very good and very well conducted. I'm thankful to Dr. Jay Bhandarkar conducting a very good and enthusiastic program yesterday night also. It was it's great pleasure that all the, it is very difficult to take the names of each and everyone over here, but I'm thankful to all the management committee of MGM College, as well as the pharma companies, as well as the management for providing such a beautiful auditorium for our AHAcon. And of course, few names might be missing also, but those who were also in the role plays, Dr. Chandorkar and their team and all the role player who has participated in the roles, I am really thankful to them. And direction by all these things and narrations, those who are always welcome for this. So that was a unique idea behind this. Special thanks to Dr. Gangolia sir and Neha for these audio visuals, because of this it has not been very smoothly. So thankful to them also, and thankful to all the organizers, those who have worked behind the curtains also. I'm very much thankful to them. So the theme is building the bridge of healthy adolescence, which will be carried out throughout the year. So thank you very much.
With this, we have come to an end for the inaugural function. I will request all the dignitaries to have lunch. It's served at the IQSC hall. Please proceed. Now, to the next session.
Thank you, ma'am. Good afternoon, everyone. So we will move ahead with our academics. There is a slight change in the program. So we will be having our inclusive care sessions before the addictions. For the next session, I would like to invite the session in charge, Dr. Chitra Kulkarni ma'am, Chairperson MAHA AHA 26, Chairperson AHA Raigad 23-24, and Organizing Chairperson MAHA AHaCon 2026. Chairpersons for this session, Dr. Linesh Yavalkar, past AHA Nagpur Chairperson, Dr. Archana Joshi, Senior Pediatrician from Virar, past President of Palghar Academy of Pediatrics, to conduct this session.
Thank you very much. May I invite Chairpersons, Dr. Linesh Yavalkar sir and Dr. Archana Joshi ma'am. Yeah, thank you. Dr. Linesh. Adolescents are at a great risk from all the harmful elements lurking in society as they are vulnerable. And for that, insisting a person none other than Dr. Piyali Bhattacharya to guide us.
Okay, thank you.
Thank you. So thank you organizers for inviting me, and I acknowledge Preeti. Thank you for allowing me to present before you because I have a flight to catch. Thank you so much, Preeti. So today, actually, when Chitra gave me this topic, I was a little worried about what I would speak. So we all know that child drug abuse and child trafficking are two major threats which are affecting these children. But I actually did not understand how this could be connected to schools. And then when I went through, I found that there's a huge connection with the schools itself. And we pediatricians have the opportunity, are in a position where we can actually prevent these vulnerable children who are in schools. So the first thing that we must learn is what is the session going to tell us. So by the end of this session, you will have learned to understand the magnitude of the problem, identification of how this problem is actually displayed, what to do in prevention, and of course, how to report. So why this matters? Does this really matter? When we talk about matters, you have to understand that adolescent, as every previous speaker has talked about before me, is actually a formation of identity, a formation of a period of experimentation, and therefore, unfortunately, the young people first encounter any kind of drug use, any kind of trafficking during the adolescent period. Not only that, a lot of mental health problems, high risk taking, violence, they all come during the middle adolescence, where they now become a vulnerable group. The traffickers also know that this is a vulnerable group, and there is where they spread their tentacles and they trap these children, and school therefore becomes an important focus of trafficking of these children and of abuse of these children. The commonly associated drugs are these which I have listed. And you have to understand that national surveys are showing us that multitude of people, millions of adolescents are actually taking these. And inhalants, as I have marked it, inhalants play a special role because number one, they are cheap, number two, they are easily available, and number three, they are commonly used. So one to one, it carries forward. So many adolescents begin substance abuse, as I have said, before the age of 14. And trafficking is very high between the age of 16 to 18, especially in the case of girls. What does the data show? The data shows that the national surveys have been done in 10 to 17-year-old children, and approximately about 3 million children are using alcohols, 4 million are using opioid, ganja, hashish, and 3 million use inhalants, while 2 million are using cannabis itself. So understanding the drug abuse, we have to understand especially the second point which I have highlighted, early initiation risks. As the brain maturity does not occur, there is an ongoing maturation, there is an increased reward seeking, and another speaker has mentioned there is increased impulsivity. So they are also susceptible to peer influences. Now all these together, they actually increase the initiation risks. Now, human trafficking, as per the international standards, trafficking involves recruitment, transportation, transfer, harboring, or receipt of a person through coercion, deception, abuse of power, or vulnerability for exploitation. However, in children, proof of coercion is not required. And the forms are various, which I have enlightened you all on the left-hand side. Sexual exploitation, forced labor, domestic servitude, child marriages, forced begging, criminal exploitation, and online sexual exploitation. Next are the risk factors. You can see here a variety of risk factors on the right-hand side. Now these, you can always say that drug abuse, trafficking, and these risk factors, they go hand in hand. It is never that you actually point to a single risk factor. They are clusters of risk factors in an adolescent's life when they become susceptible to such drug abuse or to trafficking. So amongst them, remember, I have listed out the protective factors. The parental protective factors or the home ground is the best one which can protect these children. Then of course, school engagement, school participations. आप लोगों ने देखा होगा जो क्लास में सबसे बुरा बच्चा होता है, सबसे बदमाश बच्चा होता है, टीचर क्या करती है? If she is a good teacher, उसको डस्टर देती है, चौक देती है, बोलो मिटाओ, बोर्ड को मिटाओ, टीकी मीन engaged. उसको बोलती है स्पोर्ट्स एक्टिविटी में तुम मॉनिटर हो, तुम माइंड करो, तुम कॉपीज कलेक्ट करो. So giving them the important importance and showing them that you should be interested more in schools, school engagement, sports participation, and of course, schools may life skill education, as Samir Bhai has said, and everybody has been saying, that is an important part. And over here, the youngsters are here, PG students are here. Mentorship always remains a major part of a protective factor. So I had wonderful mentors, so that is why maybe I'm standing on this stage. Otherwise, I would have been tongue-tied and not able to speak in front of you. So mentorship is a very important part of it. And to everyone I appeal that as a mentor, you should actually mentor one more person, and that will lead to a cascade affair. So the school trafficking connection, what is the connection? You know, these children, they become very vulnerable because they have academic failures, they have bullying, they have so many risk factors which are pulling them down rather than pushing them up. So because there are school dropouts, because there is poverty, there is familial disruption, all these factors together make them vulnerable. And drug traffickers will actually target these school children who are dropouts, who are having some kind of a vulnerability. So trafficking may occur near the schools or even through peers, one promoting the other for a little bit of money maybe. So trafficking is a part of a vulnerable adolescent at school. So what are the warning signs? You have behavioral warning signs, you have academic warning signs, you have physical warning signs, you have social warning signs. And along with that, if there is withdrawal or fear, if there are unknown contacts, remember there could be some kind of a grooming or some kind of a coercion over there. So these are leading to a lot of human abuse because they fall back upon the easiest method available to them. गम गलत करने के लिए शराब पीता हूँ. So गम तो गलत नहीं होता है, you fall into that trap. Now teachers at school, healthcare providers, the pediatrician uncle aunties are the best ones who can be alert to these signs and symptoms, detect these signs and symptoms, and prompt further evaluation and assessment. Now, what is the role of us as pediatricians? For us, there is a scope of primary prevention, secondary prevention, tertiary prevention, and also some advocacy. So, screening adolescents, identifying the early warning signs, counseling the families about them, and address coexistent mental health issues which may arise, and referring for specialized. The parental part is difficult because the parents do not believe that their child is having a drug abuse problem or a trafficking may be ensuing. So what they will say कि हमारा बच्चा जो है हमने पढ़ने पुनः भेजा था और वहाँ पर बच्चा जो है देखो कैसी हालत में आया, उसके दोस्तों ने उस पर जादू टोना कर दिया है. So red eyes, child looking here, there, everywhere like this, not sitting still, and a withdrawal symptom could be visible to you. So ask these questions privately to the child. You cannot go directly, so you can ask about friends, about have you ever tried, do your friends use, and do you feel pressurized to use it? Has anyone online asked you to keep secrets, or have you received gifts from strangers? So these are the questions which would help. Supposing a 14-year-old girl receives an expensive gift. So the grades are falling, there is irritability, she complains of frequent headaches, and there is a smell of adhesive in the boy's clothes. So what would be the diagnosis actually? You would think of inhalant abuse. And when you think of inhalant abuse, you have fulfilled half of your screening part by identifying the warning signs. Then you go for prevention and for advocacy. So what would be the school-based effective intervention? Effective intervention, as we've all been talking since morning, is life skill trainings. Somebody had mentioned over there कि वो पंचतंत्र का कहानी से हो सकता है, बिल्कुल हो सकता है. Like teach them what is true friendship. You can talk to them about the crocodile and the monkey. They will learn about true friendship. You can tell them where to talk and where not to talk. You can tell them about the tortoise who was being lifted on a stick by two geese and taken to another pond, and he spoke out of turn and he fell and died. So there are so many stories about the brave rabbit who actually talked to the lion and said कि आपके जैसा दूसरा है वो मुझे रोक रहा था, and made the lion jump into the well. So these stories are very helpful in demonstrating to the little adolescents how life skills can be imbibed. And once you sow the seeds, it improves their mental well-being. Not only that, you have to tell them about the anti-bullying policies. Someone in my town has actually put a whole wall in the scene where he has put anti-bullying, and on another wall he has put POXO. So telling these people that you won't go unscathed if you bully, that you are not right, that is something that you must inculcate in these children, and then you should have safe reporting systems. Now, parental engagement, I said open communication. When they are little, we said, "Arey mera bachcha, aaj kahan tha, kya hua, din mein kya hua?" But when they grow up, na, khana rakha hai, kha lena. फ्रिज से लेके गरम कर लो, दैट इज द ओनली कम्युनिकेशन. आज होमवर्क क्या है, दैट इज द ओनली कम्युनिकेशन. सो रिमेंबर, दिस वोंट वर्क. कीप दैट कम्युनिकेशन विच यू हैड इन द earlier days open. Still that channel should be opened. So how were you? And that jadoo pi thappi which everybody saw in Munna Bhai, it really works. Remember, 3 jhappi to zaruri hai. 1 jhappi when the child wakes up, 1 jhappi when the child comes back home, and 1 jhappi when the child is going to sleep. So a story and a jhappi. These are actually very good if the parents can promote these things. Now about the legal framework. Legal framework, we have all these things, but more than the legal framework, जिस law का application नहीं होता है, वो law का कोई फायदा नहीं है. So who is going to implement these laws? Who is going to talk about these things? I will tell you the reporting pathway, but it is never followed in schools because unawareness hai, they don't know what to do. So once they are told about the warning signs, once they recognize what should be done, you should ensure first foremost the safety of the child. जो बच्चा सुसाइड करने जा रहा है या पता चल गया कि ट्रैफिकिंग में किसी अननोन पर्सन ने बोला है उसको यहाँ आके मिल और मैं तुझे फला जगह ले जाऊंगा, if you have recognized that, never ever leave them alone. Ensure their safety. You must document what is happening as a medico. You must report as a medico what is happening. I'll tell you the lines also. And you must refer for mental health issues and follow up. So who are the potential stakeholders? You cannot do it alone. The school authorities, CWC, police, and mental health. So the take home is that substance use often begins during adolescence. Early intervention changes outcomes. Trafficking frequently starts with grooming, and schools are ideal prevention settings. As pediatricians, we are in unique settings. We are positioned to identify vulnerable children, and every suspect victim should be known to us so that we can prevent. So you have here the distress helplines, and what I would say is, if you see something, if you identify something, say something, because one call can save a life. Thank you very much.
Thank you, Piyali. Thank you for this wonderful lecture. You emphasize the importance of Hitopadesh and Panchatantra and Teen Jhappi, सुबह आने के बाद स्कूल से और रात में. Thank you so much.
Thank you, ma'am. The next session is also equally
Thank you, Piyali,
interesting.
madam. Can I ask you one question?
Sir, later on. Sir, already we are late. Please. And continue with the next program. The adolescents in adverse social environments like poverty, violence, neglect face a separate risk of trauma and mental health struggles. We have inclusive care, and for this we are having a very important person, and I am graduate and working as Managing Trustee of Committed Community Development Trust from Mumbai for last 25 years. Over to Ms. Sukanya Poddar.
Thank you so much, Chitra ma'am. I'm really happy and I feel privileged to such a forum where inclusion is really shown. It is not only doctors, it is also community people who are doing day in and day out in rural, tribal and urban settings, where not only adolescents who are actually, in a situation where they are in trouble, but adolescents who are actually in poverty and always struggling to fight.
Those who have not had their lunch, please proceed to lunch area because in last 30 minutes they are going to wind up. Thank you very much.
So I think from morning, everybody is now very clear with all these things that are going on regarding adolescent health. So ma'am, this one, it's not changing. Either direct. It's not changing. No, that is what I was doing. Yeah. So I think the numbers are appalling. You all can see we have 253 million. This is NFHS 6. Maharashtra has 23 million. And out of that tribal, we have 55.2% of adolescents. What I will highlight here is 1 in 3 lives in actually in adverse condition. That is something is a concern for us today, which is almost 85 million adolescents in India. And this is, I thought that I'll introduce what is social adverse, situation. I think all of us know, but if we can highlight in 3 major areas, this is actually dealing with socio-cultural. When we say socio-cultural, of course, it is the children who are continuously staying in a poor situation, and there it's only a mode for them which is fight or flight. And you all know that this releases a lot of hormones which ultimately impact adolescent health. And the same is for the economic poverty. Poverty restricts us for accessibility and a lot of other adverse situations which make them even more difficult population to actually access services. Interpersonal, as you know, that poor civic engagement and low mutual trust among neighbors, and this continuously isolates. Now the problem is, what is the impact on adolescents? It increases the risks of the mental health issues, poor academic outcomes, what ma'am was telling before, and also unhealthy behaviors and long-term physical health problems. So if you see the vulnerabilities of adolescents, I'm sure you all have been talking for last 2 days, but majorly this is physical, cognitive, and psychosocial health inequities, where it is caste, gender, religion, geography, and also pandemic-like situations or displacement or war. This makes adolescent health very, very difficult for us to reach and work with them when they are having double burden of along with the vulnerabilities and the health impact. Because these are all leading to early marriage, gender-based violence, school dropout, and digital exposure and risks. So this is something that, that I will discuss in my next slide. So I just wanted to try that if, we all agree that there are vulnerabilities. We all agree that it has health impacts. WHO has already said, I just want to take 20 seconds here. When we started with adolescent 30 years back, so I am working on adolescent health for the last 30 years at the policy program implementation level. 30 years back when we started adolescent, WHO written it's a disease-free period, if you all remember. Now we have moved a lot that needle saying that it's a actually stage where development needs to be addressed. So it's a good progress in terms of that, and social determinants framework is there for WHO. This is something that I tried to put all the factors that are actually in the structural determinants, social position determinants, intermediary, and adolescent health outcomes. So here when you see the red ones, that is what these are the new addition, which is environment and climate change. It is going to impact adolescent health in a big way. Then it is also inclusion, sexuality, sexual orientation and identification, and digital access. Now we all know 85% of the internet users in India. Everybody is almost having a smartphone at home, even if they're in a poor setting. And this is going to impact especially in the HIV sector, TB, NCD, and obviously mental health issues. Now key snapshots data, I really don't want to run through this, but you all can see I have tried to put Maharashtra and also tribal areas, and the major issues that you can see is mental disorder prevalence. I was always thinking that it is an urban problem, But now when I was looking at the data, the tribal population is the highest, which is 9 to 14% of mental health problem with the tribal population. Then school secondary retention, adolescent pregnancy, this is also highest you can see in tribal areas, and Maharashtra in NFHS 6 shows 34%. So every 100 out of 100 adolescents who are crossing 18, 34 girls are getting married before they are 18. So it's a very big concern. RKSK utilization is very low, especially tribal areas, and substance use pattern, again, tribal area, it is very, very high. So this is, something that is a a big concern for us. Now, priority health challenges, if we take a thematic deep dive, we see nutrition and physical health, which is anemia. But I am really, NFHS 6 is silent on anemia data. Adolescent, you forget. So, that is a big concern for us. Though we have IFA supplementation under Anemia Mukta Bharat, but how far it is reaching the last mile, we have big questions. Then we have mental health and psychosocial well-being that I have already spoken about. Child marriage and gender-based violence, this is very much linked with adolescent health. Because the moment adolescents are exposed to child marriage, they are exposed to early pregnancy, and number of pregnancies are more, and then it is impacting their mental and physical health both. Child labor and, thank you. So the priority health challenges, obviously I'll run through quickly. Environmental, behavioral and climate change risk. Obviously air pollution and densely populated slums. Cross-cutting impacts are conflict and disaster. Adolescent girls bear disproportionate burden of wash gaps, which is menstrual health and hygiene. And seasonal migration also is a big issue. And climate change and its impact on underprivileged, marginalized, and vulnerable adolescents, that is taking a very, very big role now in every health discussion, even with the policymakers. Policy and program landscape, actually key programs are in place, but the critical implementation gaps that I wanted to highlight here, that, at district level, key coordinators posts are vacant, ASHAs are burdened, so we really don't know how the adolescent RKSK program is actually reaching to the adolescents. There is zero dedicated child and adolescent mental health services, especially in tribal areas. Out of school adolescents, invisible. All programs are school linked, most of them, even midday meal. So these programs are something that needs to be tailor-made for the last mile and people who are actually very, very far away from the services. And it's my humble request to all of you to think that where we can come together and merge and reach to these populations. Intersectoral convergence like health, education, WCD, women and child, they are all working in silos. So there is hardly any coordination. What is happening in another department, the other doesn't know. CHC specialists are having shortfalls, which is 79.5% nationally. So immediate recommendation is again, kept here. So integrate IFA distribution and deworming is actually part of midday meal program now, but it is very, very scarcely distributed and stock out is always a problem, major problem, and especially not reaching the tribal areas. And obviously short-term and systemic policy level. And key takeaways from this is that rural, urban, tribal or conflict affected all needs attention. You cannot focus your program in one place. Second, anemia, child marriage, mental health, malnutrition, substance use are 5 converging crises cutting across all geographies. So it cannot be again in silos. All the intervention has to be interlinked and stitched together. Programs exist, but implementation gap, workforce shortage, and intersectoral silos limit real-world impact. Tribal and conflict-affected adolescents remain the most underserved. Integrated school-based family and community action should be the priority, which is not happening. We are trying one. And every adverse social determinant is a modifiable risk. So it is not that we cannot do anything about it. And it can be done very well, if we all come together, join hands. We have come so far with the WHO mandate and working at the grassroots. I feel that, this is something that we need to take ahead, all coming together. Thank you very much.
Thank you, respected Sukanya Podar Madam. You have covered almost all the aspects of adolescent health in adverse social environment. Thank you very much.
Thank you, sir. Thank you, sir. The next talk is also equally important. And what is happening, especially in the juvenile homes, observation home or open shelters, we have to have first hand evidence from our Maharashtra AHA Secretary, Dr. Vaishali Shirshetty.
Thank you very much, organizers, for giving me this opportunity. Actually, this topic is not that much of academics one, but working as a RCH officer in Solapur Corporation, I have experienced so many of things, and I would like to present these things in front of you because this is the base platform where we can share what are the realities at ground level. As you all know, that the NFHS 6 has come and which has shown this, I'm going to focus on child marriages only, and NFHS 4 has shown so many of things which have been improved. But if you could see the point number 4, the child marriages, women 20 to 24 years married before 18, the percentage which is shown in Maharashtra is 21.9, and which has been decreased since last so many years. So NHS 6 shows it is 20.1. 2012 I had done one study and which has shown that 46% marriages are before 18 years of a girl. And I was very much shocked that being Solapur is not that much rural area, but the outskirts of Solapur is little bit extended one. And the area was showing that 46 marriages were conducted less than 18. And I went into the reality, what has happened exactly, why these girls are married before 18. So all of you know that feminism is very common, and people already see that the girl child always a burden to the family, especially very low socio-economic status. So these were my objectives. What I found in last 3-year study, that maternal deaths less than 18 years are increasing in last 3 years. Repeatedly, there was pressure to take serious note of teenage pregnancies from state. Whenever we used to go to state meetings regarding this maternal death which has occurred less than 18 years, so that was a huge burden. Then special drive was taken for less than 18 mothers in corporation area, and special homes were in the special homes. Fortunately, no malnutrition and undernutrition was found this year. So the malnutrition has gone, but the other thing, that is the obesity, has increased, that I will show in the next slide. There were administrative challenges, non-government organization, role of police commissioner, role of lawyer, child protection department, district women and child welfare department, and the rehabilitation. So you see that these are the children in the ashram schools. That is, you can't see any one of them to be malnourished. I think they are well nourished, which was the scenario before, but nowadays this scenario has changed. The reality is, if marriages is the end of the life, how it also be the goal of a life. So this has to be a point to be noted. The more we understand, the more our horizon shift. There are fissures, there are leakages. Its borders are porous and vulnerable. Motherhood is a biological fact and fatherhood is a sociological action. Gender-based injustice is always there, and there are multiple structural inequalities. These are the few of the papers which are last 3 months which has been constantly focusing on teenage marriages. Actually, we did the study and the data came to know that 498 marriages were held before 18 years. And we could get the number that is on paper, what was on 86 teenage marriages were held. And I issued police commissioner, always police commissioner of corporation, even the Bal Ayog commissioner, they have issued us a notice that how many marriages are occurring here and what are you doing. So there were so many paper cuttings, there were many pressure from all the faculties, and all the time always the NGO was also behind us, what we are doing, what you are doing, you are not showing anything. So that was the thing. And this was happened on 23rd of April. Bal Ayog, which has been associated in Wari, they called all of us, and 9 IS officers were there, and they asked us why this is happening in your area. And after that, there were strict instructions. We went to police commissioner, we went to all the faculties, but the police commissioner as well as the police department, they were not in position to report any of the less than 18 years mother. So that was a tragedy. All the time they used to say, go to some Aadhaar card, MAHA AHAcon and get the age change. If you don't have any proof of birth certificate, living certificate like that, and they say that you have to do this. When our doctors, they went to report these cases, the doctors were co-accused. So they were co-accused and FIRs were lodged. And this was the huge moment in our area that all the doctors were under pressure. All Foxy as well as IAP as well as medical officers, they were under pressure that we are being co-accused and what should be done. So the Bal Ayog, that is Child Welfare Committee Commissioner, he personally told us that you should go to the area and get the reports very well done within 1.5 months of time. So these were the paper cuttings who has showed that the number of child marriages were reported. I myself got few of calls that the girls who were less than 18, they called me and they said that madam, I am going to be married with someone and I don't want this marriage, please do something. So we could contact the child health department, child right department, and they could help us, and this is how we could stop at least 13 marriages in last 2 months. This was the various programs conducted for these teenage girls as well as for our Ashas, Anganwadi Sevikas as well as ANMs. These were online programs which were conducted because POXO, you know everything, but whenever you are going to implement it, it is very difficult, and there are so many hurdles in this. Ultimately, the decision has to be made by collector. So 8 days back only, we had a meeting with collector. I contacted all the faculties, that is IMA, IP, Foxy, as well as NGOs and Child Well Department, then Bal Vivaha, Pratibandhak Kaida, and all of them. We could meet the collector, and the policy decision was made that if the girl has been married, there will be a new amendment in Maharashtra itself, that each and every, whatever the marriage invitation will be there, the actually real birth date of a girl as well as the son or the boy has to be printed on the marriage invitation, and this rule will be implemented. And this policy making decision has to be made through collector. So collector has given this, and the amendment will be soon. Only thing is that there is a lot of pressure. Once we talk in front of this on the podium, and it's very easy to talk, POXO is like this, POXO is like this, and you should do like this. But once you have to do it, it is very difficult. Lot of legal, lot of political, and lot of social pressure is on you. So take-home message regarding this is, you have to fix your goal. तुम्हाला जर काही आयुष्यामध्ये करायचं असेल तर तुम्हाला तुमचं गोल फिक्स करावं लागतं. Then fight with full strength. You have to fight with full strength. Whatever the pressure comes, you have to face it, the consequences. Forget who you are. You have to forget your everything. I'm a doctor, I'm a so-called prestigious person, I'm a mother of this and that. So you have to forget everything, and last is your family support. So you need everything to be with you, and then only you can contact the policy makers, you can change the policies, you can ask them to change this, and you can make a change. But this is a very huge and tedious process, but you have to go through this, and I have witnessed all these things. So the major point was regarding this, that nutrition and all these things is very important, but once you go for some nutrition in special homes, you find something else, and which is a reality of this society. So thank you organizers for giving me this opportunity. Thank you very much.
Thank you, Dr. Vaishali, for this wonderful lecture and making us aware about the nutrition and health of children in special homes. Thank you.
Thank you so much. I request the speakers and chairpersons to please proceed for felicitation. We'll move ahead with our next session, which is addictions. So before we start the session, we have a small role play. I invite the performance of Vyasnanche Savat on the stage. Performers of the play are Dr. Prajakta Radke, Dr. Sonali Shirbhate, Dr. Upendra Sugwekar, Dr. Vaishali Deshmukh. This play is directed and written by Dr. Vaishali Deshmukh. We are still waiting for some of the performers, so we'll start with the lectures. For this next session, I'll invite the session in charge, Dr. Sangeeta Lodha Madam, Past Secretary MAHA AHA 2025-26, Chairperson Women's Pediatric Forum 24-25 from Nashik. And the chairpersons, Dr. Yash Banet, Pediatric Intensivist, Secretary AHA Nagpur, and Dr. Santosh Kangule, Pediatrician from Panvel, EB member IAP Raigad. We request the session in charge to finish the session in the allotted time and request the chairpersons to sum up the session in a minute at the end. Dr. Sangeeta Lodha ma'am, can we start?
Hello friends. After the lunch break, I think everybody is on sleep mode. But before that, I think this session will just make you awake. So the first session is on substance abuse is one of the commonest addiction seen in adolescent. Now I invite Dr. Priti Galagali madam for her talk, The Drug Trap. Dr. Priti Galagali is adolescent health expert from Bangalore, Vice President South Asia, International Association for Adolescent Health, and IPVP South Zone in 2025. The stage is yours, Dr. Priti Galagali.
Good afternoon, everybody. It's a pleasure to be here today in the land of Shivaji, and I think we need to combat drug just as Shivaji combated his enemies. The drug trap, a primer for pediatricians. So I hope that this talk, my objective is very clear. I hope that this talk will motivate you to read more about drugs and adolescents, and also to manage these patients in clinical practice. The young are heated by nature as drunken men by wine. Who said this? Anybody wants to take a guess? Yes? Aristotle 2,300 years ago, and mind it, he didn't know about the limbic system, right? And we have been talking so much about it since morning, and the amygdala. So he was smart enough to really tell us that yes, young are heated, the drugs are a trap, we know that, and is it just enough teaching them to say no? So may I have a show of hands? Is it just enough telling them, say no to drugs? No? Nobody believes that? So I'm happy that you said that, because there's something more beyond that. Saying no does not work, and even in prevention programs, it has been proved so. So in the next few minutes, we'll go through a situational analysis, discuss why adolescents are vulnerable, go through the socio-ecological determinants, the role of pediatrician, and a little bit about clinical management. So the prevalence, different studies say different prevalence, but let me tell you, overall the prevalence is increasing, right from a very younger age group, as young as 8 years sometimes, when drug initiation starts. And you know, the younger the age, the higher the chance of them getting addicted, and more impact on their overall quality of life, including education, and they kind of achieving their goals in life. I think this is a very important subset to take care of, the vulnerable group, the socio-economic, those belong to a low socio-economic status, those living in violent neighborhood, street children, orphans, those facing adverse childhood experiences, living in childcare institutions, children in conflict with law, LGBT, mental disorders, chronic medical disorders, school dropouts, and with a family history of substance use disorder, because we know that the brain works in a different way, and that substance use disorder is a chronic medical disorder. So this group is extremely important, and when I say just saying no, that's not enough. It's not enough, because unless we really handle all the stresses in this age, we are not going to be just successful and telling the adolescent just say no. The adolescent stays in a slum area, he belongs to a poor deprived situation, he doesn't even go to school, he doesn't even have food to eat, and then somebody introduces him to drugs to get a high, and you know how the brain functions. And then we say just say no. Are we even right in saying that? Now, what does the NFHS 6 data say? Now, the data is still not completely out, but definitely they say overall the drug use problem is very much reduced in males and also in females overall. But if you can see the adjoining study there, which is one of the latest studies which was done in 2024, it says 1 in 3 adolescents use drugs. And look at the socio-ecological determinants here. So it says that yes, if they belong to a low socio-economic status, they definitely are going to be on drugs, and if their peers use them, then they are going to be on drugs as well. And this is one of the latest studies on school use of substances, and here you can see it's a 2025 study. The good news is that when they're using substances, more than half of them use it occasionally. So it has great implications for us, because if they use it occasionally, and if we can stem the rot right there, there are less chances that they will get addicted to it. But look at the other far off figure which is telling you, but if they start opiates, they get addicted to it and they use it every day. Right? So when, you know, nicotine is a gateway drug, marijuana is a gateway drug, alcohol is a gateway drug. So this is what they are using infrequently to start with, but with time, when they go to more hard drugs, they find it difficult to stop. Now, when we talk about adolescent risk behavior, we talk of various domains of an adolescent's life, and this includes individual factors, interpersonal factors, and community factors. So, an adolescent per se, we have been talking about the reward center, the emotional ability, how adolescents are curious, they love to experiment, they have a reward-seeking behavior, they have high emotional reactivity, they do not have a mature stress response. So as such, adolescence is vulnerable to drug use, especially when they don't have a toolkit which helps them to actually handle stressors. But those with ADHD, right, those with autism, those with depression, definitely they are more prone to substance use. And interpersonal factors. Now, research has shown if parents use drugs or if peers use drugs, definitely they will be on drugs themselves. Now, the most powerful factor in India is actually the community factor, the media, and the availability and accessibility of drugs. We have different laws governing that, which are stopping adolescents from use of drugs. It is the legal age for alcohol use, the legal age for selling cigarettes, but unfortunately, they are not being implemented. So there is a propensity, there is an opportunity, and hence drug use occurs. Now, what are the protective factors? Again, this is cross-cutting against for all risk behaviors, parental and school connectedness is very powerful, and so is spirituality and religiosity. We belong to the land of Bhagavad Gita, the land of Mahabharata, the land of Ramayana. I think we need to go back to our roots, which is so very important. Now, what is the drug trap in the adolescent period? There is a hijack of the reward center. So the adolescent does not feel happy when he gets a prize in sports or when he gets a prize in academics. What does stimulate him the best, the dopamine high that he gets, is through drugs, if he starts them. Because why? The prefrontal cortex is not mature and there is no control over the reward center. And they can binge a whole lot without having a blackout. Again, this is because of the development of the brain. And if they use long term, the functioning of the prefrontal cortex is affected. There's a reduced size of hippocampus. It's very, very important to remember because hippocampus is associated with memory. And we want adolescents to function at their academic best, always. So this is a very powerful statement to give. And we all know that there's an epigenetic effect of use of drugs. What else can substance use cause? And I think to this august audience, I don't need to tell about the non-communicable diseases, but please remember road traffic accidents, injuries, crimes, homicide, suicide, drug overdose, and it can even lead to death. Unsafe sex practices, HIV, tuberculosis, COVID-19, hepatitis B, C, pancreatitis, gastritis, endocarditis, all organs of the body are affected. Decreased school performance, and they often present with this decreased athletic abilities and interpersonal problems. So, drug use is a medical, social, economic disease, and we should all remember it. What is the pediatrician's role? Definitely beyond the four walls of your clinic, going on to the community. We talked about life skill education, going for advocacy, going for adolescent-friendly laws, going for laws which keep them safe, going for the implementations of policy, very, very important. Anticipatory guidance, the screening tools, I'll just tell in a minute about those, and of course, management and referral. How do they come to us? What are the flag signs of substance use, which all parents, all pediatricians should know? There may be trouble sleeping or oversleeping, change in overall energy levels, difficulty in daily functioning, loss of interest in hobbies and friends, changes in appetite and weight, extreme mood changes, becoming withdrawn, being very aggressive, stealing money, spending a lot of time in the bathroom, and also a new set of friends. So these are non-specific signs. There are some very, very specific signs. We know about the date rape drug, which is called flunitrazepam. So what is done, what the adolescents, when they go for a party, they give them a drink which is spiked with this flunitrazepam, which is colorless and odorless. And when the adolescent drinks that, the adolescent has a blackout and then has retrograde amnesia. So the adolescent does not remember who gave the drug to them. Right? So it's very important to tell the adolescents, so if you want to go for a party, go for a drink, open the bottle yourself. Don't take just a glass from somebody. There are flu-like symptoms with marijuana, what we call the sweet munchies. They like to eat more and more of sweets, chest pain with cocaine, amphetamine, and constipation with opiates and marijuana as well. So what is the tool that you and me can do in clinical practice? This is an extremely simple tool to use, and this was by the American Academy of Pediatrics in 2016. It goes by the name SBIRT, S standing for screening, brief intervention, and referral. Before we use the tool, it's very, very important to do a psychosocial screening, the heads which we have been talking about. How do you ask for drugs? Do any of your friends use it? Has anybody asked you to use drugs or forced you to do drugs? What do you feel about drug use? Oh, doctor, I feel drug use is cool. Abhi nahi karenge to fir kab karenge? The moment the adolescent says this, you know your antenna should be up and you should start thinking about it. Oh no, doctor, I hate it. I hate it when my father smokes. Then you know the adolescent is relatively protected. We must also talk about duration, type, quantity, and triggers, strengths, aspiration, and goals, the stressors, risk, and protective factors. Please remember, comorbidity is a rule with drug use. So you have to rule out comorbid mental and neurodevelopmental disorders, multiple high-risk behaviors. They may be riding on drugs, they may be sexually promiscuous on drugs, you must rule that out. Family history of stressors, drug use, mental disorders, general physical, mental, and status examination, including a nutritional examination, extremely important. You will see the signs of mainlining, the drug puncture marks, and many other symptoms, even the smell. We can all smell alcohol, and those of you who have seen some patients using marijuana, marijuana also has a very typical smell. Now, this is a very simple tool, the S2PI tool, which has only one question. In the past year, how many times have you used tobacco, alcohol, marijuana? And stop if all never, and otherwise continue. Now the beauty of this tool is it correlates very well with the DSM-5 substance use disorder. So if the adolescent says he's never used substance use, what do? You just give positive reinforcement. If he says I have used once or twice, you give a brief advice. If he says monthly, it is probably mild or moderate substance use disorder, you have to do a motivational intervention. And if it's weekly or more, you have to do a motivational intervention and refill. So, har hafte mein peeta hu, definitely he needs the help of a psychiatrist, and you have to motivate him to go to the psychiatrist. That will be your plan of action. Let me just quickly discuss a few cases. 18-year-old first MBBS student comes for a typhoid vaccination because he didn't have it, and there was a typhoid outbreak in his hostel. So he says, thanks to life skill sessions, most classmates drink and smoke. I don't feel the need. I continue to get high on hockey. So you say, well done, khelte raho, khush raho, and that is what you say. And you say, do you know what's the effect of drugs on the brain? And you further talk to the child on it. So 16-year-old with tension headache, marijuana is legal, it has medical uses, doctor, there's too much of stress, I had a broken relationship, I want to become an engineer and fashion model, are e-cigarettes okay to use? So what do? You give brief advice, you tell the effect of marijuana on brain, and how you cannot, and how you cannot do well in studies if you are on marijuana, and you want to become a fashion model, do you want to see the picture of somebody who uses drugs? And the adolescent says yes, and this is the picture that I show. Because drug use can cause wrinkles of the face, they can cause staining of the teeth, and this is not what you want to, this is not what is in your goal. What about e-cigarettes? I tell them about the long-term and the short-term effects of e-cigarettes on the heart and also on the lungs. What is motivational intervention? I can understand that when you are under stress, you want to relieve the stress, but you want to become an engineer, right? But would you like me to share with you what are the effects of drugs on the brain? You also want to become a model. I would like to tell you how you can have a healthy skin. But doctor, I can't have a new set of friends. Okay, I do understand that you're very firmly bound with your friends. Is there somebody in your class who doesn't smoke or drink? Oh yes, there's one student. What do you feel about it? Okay, I can give it a try, doctor. But no, I can't leave my friends. It's okay, roll with the resistance. It's okay, you think about what I said. I'm shifting you from a pre-contemplation state to think about drugs, and that is okay for the first session. We also have to talk about life skills and a family-based treatment. This is another tool which I would like you to all remember, the CRAFT tool, very, very important. And this is the mnemonic, again, as we often have in adolescent medicines. Have you ever driven in a car ridden by someone on drugs? Do you use drugs to relax? Do you use drugs when you are alone? Do you forget things on drugs? Do your family and friends have ever tell you not to take drugs? Have you got into trouble? This is a very powerful tool, more than 2 positive. Each answer is given 1, and more than 2 positive indicates that there is a severe substance use disorder. These are the cases which we cannot handle in clinical practice, and they need to be referred to a mental health professional. India has a Nasha Mukt Abhiyan. We have some fantastic helplines which are available, and I would urge all of you to know about one helpline at least, 14416, the Tele-Manas helpline, and NIMHANS has a mindfulness app. If you want to learn more about drugs, please join the NIMHANS Digital Academy. They give a lot of courses on drug use. Make every day a World No Tobacco Day, and always remember that we pediatricians have a major role to play, not only in our clinics, in the society, in policy making. Thank you very much.
Thank you very much, ma'am, for enlightening us on a drug trap. Now, social media has reshaped how we interact online. It has become an integral part of our lives. Now, I invite Dr. Amol Annadate to speak on how it can be a boon for us. Win-win with social media. Dr. Amol Annadate. Young and dynamic pediatrician from Vaijapur near Sambhajinagar.